26. Our presenters are all here and probably very eager to present. So I would like to request Dr. Bharat Yalgi and Dr. Vijay Mandora whenever he joins us. He's here. He's outside. Okay. Please join us on the dais to chair the session.
Good morning, everybody. At the outset, I would like to thank Dr. Ishwar Gilada, President Emeritus ASICON, and Dr. Glory Alexander, President ASICON, for giving me this opportunity to chair the morning session. Let us pledge today only that we will strive hard to give a healthy and AIDS-free world to our future generation. Let us achieve WHO and UNIAID slogan of 95, 95, 95 and try to achieve AIDS-free world by 2030. Let us join hands in sharing the challenge. With these few words, let us begin today's morning session. Thank you.
We'll call the first speaker, Dr. Aditya Seth.
Okay. Okay, I can just begin the first.
Good morning, everyone. I'll be presenting a longitudinal analysis on progress towards UNAIDS 90. Good morning, everyone. I'll be presenting a longitudinal analysis on progress towards UNAIDS 95, 95, 95 targets among people living with HIV, a longitudinal analysis from Uttarakhand, India. Myself, Dr. Aditya Seth. I'm first year PG resident in community medicine. The co-authors for this will be Dr. Romila ma'am, Dr. Vinita ma'am, and Dr. Puneet Ori sir. Background: the global HIV epidemic remains a critical public health priority with an estimated 40.8 million individuals living with the disease and approximately 630,000 AIDS-related deaths recorded in 2024. In 2021, UNAIDS established the ambitious 95-95-95 targets as a roadmap to end the AIDS epidemic by 2030. These targets mandate that 95% of the people living with HIV know their status. 95 of those diagnosed receive continuous antiretroviral therapy, and 95% of those on treatment achieve durable viral suppression. Despite the treat-all policy adopted in 2017, structural barriers such as human resource shortages, supply chain weaknesses, and persistent social stigma continue to undermine the HIV care cascade. This study seeks to analyze the longitudinal outcomes and predictors of attrition within this complex landscape, providing evidence-based insights to bridge the remaining gaps in India's journey towards 2030. Research gap. The first research gap was limited. There is a limited longitudinal state-specific evidence from geographically unique and low prevalence regions such as Uttarakhand. Secondly, predominant focus of existing literature on high burden states with underrepresentation of Himalayan settings. Third, inadequate district level stratified analysis to identify intra-state variations in HIV burden. And fourthly, underexplored programmatic gaps in diagnosis and ART coverage within low prevalent context, limiting targeted strategies towards 2030 HIV elimination goals. First objective is to compare the performance of Uttarakhand on the 95, 95, 95 indicators with national average. Second, to assess the temporal trends in the 95, 95, 95 indicators in Uttarakhand from 2020 to 2025. Thirdly, to estimate the gap between current levels and the UN-AIDS 95, 95, 95 targets in Uttarakhand. Methodology. This study utilized a retrospective longitudinal design employing secondary data analysis. Data were extracted from official publications of the NACO, including NACO Sankalak Report 7th edition. Additionally, data were obtained from USACs. These sources provide validated and comprehensive information on HIV epidemiology, testing coverage, ART, uptake and viral suppression trends in India and Uttarakhand. To assess the progress towards UN-AIDS 95-95 targets, indicators were operationally defined as and were explained in backgrounds. Trend analysis was conducted using reported annual data on HIV testing, ART enrollment, and viral load suppression. Descriptive stats were applied to evaluate year-wise progress. To estimate the projected timeline for achieving the first 95, the arithmetic projection method was employed using this formula. Results, epidemic burden analysis by district. Two states, Udham Singh Nagar and Haridwar, were moderate. Low were Dehradun and Nainital, and 9 districts were very low. There was no high burden district. This is the distribution of ART centers in various districts of Uttarakhand. As you can see, Dehradun has 7 ART centers and other districts, other 6 have 1 ART center. And there are no ART centers in places where there is prevalence is high or the ART centers are less. So this is the first 95 of Uttarakhand versus India. So as we can see in 2021, it was 70.7 for India and 51.1. In 2024 to 2025, we see a trend which is going upwards, which is good. And it came from 70.7 to 83.9 and from 51.1 to 76.3. Then we have second 95. We can see a dip in 2021 to 2022. It went from 72.1 in 2020 to 77.9 in 2025. Then in 2020, from 85% to 98%. And we can see a dip in 2022. This is of Uttarakhand. As we can see, the first 95 was 85.9, second was 72.1 and 51.1 in 2020. Then it has come to 98, 78 and 76. So the results, Uttarakhand demonstrated a positive temporal trends in the first 95, rising from 51.1 in 2020 to 2021 to 76.3 in 2024 to 2025. Yet it consistently trailed the national average. The second 95 showed fluctuations ending at 77.9 in 2024 to 2025 compared to the national average of 86.6. Remarkably, the state surpassed the third 95, reaching 95% by 24 and maintaining this level through 25, aligning with the national success. District level analysis identified Haridwar and Udham Singh Nagar as moderate burden areas. 1 line districts reported very low prevalence. Limitations. This study is limited by its reliance on secondary programmatic data from NACO and USACs, which may be subject to reporting bias, data incompleteness, and variations in surveillance quality. The descriptive design using aggregate state level data precludes casual inference, and limits exploration of individual level determinants, influencing gaps in the HIV care continuum. Conclusion: while Uttarakhand has achieved the global target for viral suppression, significant gaps remain in the first two pillars. The state faces a 18.7% gap in reaching the first and 17.1% in the second. To bridge these disparities, public health efforts must align, and particularly in moderate burden states, to align with the 2030 goal of ending the AIDS epidemic. References?
Thank you. You are in time. The next speaker. Next oral. At the end of. If there are any questions.
Sir, I'm not sure of. Yes, sir, Dehradun is there, maybe because of that. Dehradun is nearby, so Dehradun is a high prevalence of injection users, so it may be because of that.
If there are no more questions. The next speaker, next oral presenter, Dr. Srijit Sri Kumar, will be speaking on a rapid emergence of pan-INSTI multi-class resistance in a treatment-experienced patient, a care of conscious salvage therapy in resource-limited government facility. Over to Srijit.
Good morning, everyone. I'm very honored to stand here today. I'm working as an ART medical officer in Thrissur, Kerala. And thanks to team ASICON and ASI for giving me this opportunity. Today, we will be dealing with a case report of the emergence of a pan-INSTI multi-class resistance in a treatment-experienced patient in a government health facility in an ART plus center in Kerala. The background of the study, as we know, the dolutegravir-based regimens had become the global cornerstone of HIV treatment programs worldwide, especially in India, where the National Health Program had adopted dolutegravir as the mainstay of drug, and we were quite happy. But as we have seen in the recent reports and also in the yesterday's discussion, certain red flags have been coming up now because, or related to dolutegravir. And many of the metabolic complications and the drug side effects were discussed yesterday. But one of the red flag which was not highlighted much was the instance of resistance. And that is mainly because the main reason why dolutegravir-based regimens became a backbone was because of its high efficacy and also the high genetic barrier of resistance, which was shown in most clinical trials. But the recent reports like the WHO HIV drug resistance testing report in 2024 and the DTG resist study has shown that the real world data about resistances was more as compared to the clinical trials data of resistance. And this was especially different between the low and middle income countries and the high income countries. And as we can see, the resistance scenario between the two types, one is the main is the HIV subtypes, because in the Western and the US, the main HIV subtype was the subtype 1B, while in the low middle income countries like Africa and India, we have the subtype C, which is the dominant. And then about the treatment approach, where the individualized approach of the Western nations compared to the public health approach in India. And also it was seen that in many studies, recent studies, that the low and middle income countries, the observed resistance to DTG and the backbone drugs were about 20 times higher than those resistance in the Western regions and the trials in the Western region. And also the mutational pathway for the resistance was different. That is the G18R in the Indian and subtype C variant versus the R263K in the Western variant. And also the level of resistance seen, like it was moderate to low resistance in the high income countries, while it was high to very high level resistance in the low and middle income countries. And coming to the Indian constants, we can see all the negative factors like the HIV subtype is subtype C. We have a public health approach, and we have a low and we are a middle income country. And also the level of resistance seen in our case was also high, which was depicted in my case, which I'm going to detail. The clinical case scenario, this was the case of a 55-year-old female who was started on ART in 2018, and she was detected with PCP pneumonia. And as per guidelines, the PCP was treated, well controlled, ART was started, all the prophylaxis like CPT and TPT were given. And she had no major comorbidities, not even non-communicable diseases. Neither she had major recurrent infections, no major STIs at diagnosis or till date, and no serious recurrent OIs. And she had good adherence all throughout, but still, she faced a rapid sequential failure of regimens, and she progressed to third-line regimen within a short span of 5 years. And the regimen details and the viral load and CD4 monitoring details in table. She was started on first-line regimen in TLE in 2018, and you can see that the baseline CD4 was 85 at diagnosis. But later, in 1 year and 6 months of first-line regimen, we can see that her viral load was never suppressed. The first viral load was 4 lakh and the next was 5 lakh. And the CD4 had fallen from the baseline. That was 51, 43, and 33, and we diagnosed first-line failure. And she was at the peripheral ART center. And then she was changed to second-line ART regimen as per the protocol to sidovudine, lamivudine, atazanavir, ritonavir. And again, she was on 2 years in the second-line regimen. Initially, it showed some response because the amount of viral load was 1,651, and the CD4 also improved to 300. But later, we can see that in further follow-up, the viral load kept on increasing, and the CD4 had a declining trend, and it was diagnosed second-line failure at the peripheral ART center. And then she was referred to second-line SASF at our ART Plus center, and we shifted them to third-line, zidovudine, lamivudine, dolutegravir, and darunavir, ritonavir, BD, which was according to the program, and hence she was taken up to our center in third line. And we followed her up in our center for 2 years. And as you can see, her viral load results was much promising than before. That is, the first viral load result was suppressed. It was 158 copies. And the CD4 also showed an improvement of 300 from 100. But then you can see that there was again waxing and waning of viral load results despite having good adherence. She had viral load results of 1,000 and 2,000. And CD4 also started to show again a declining trend. So this was a typical case. We felt that never in her life in 5 years, she has never achieved TND. And this because we thought that it's a low-level viremia, and that we requested for a genotypic drug resistance testing at the Center of Excellence, Tambaram. And it was a very difficult procedure because it is very tough to get an approval for this resistance report. But we had strong suspicion of multiple drug resistance. And as you can see in the report, this is the report that we obtained from Tambaram. To summarize the report, this was a report. So HIV1 subtype C was identified, and in genotyping, it was seen that it was high-level class-wide resistance to INSTIs. It was resistance to all the drugs like dolutegravir, cabotegravir, bictegravir, even without exposure to cabotegravir or bictegravir. The protease gene also showed a major mutation, and it was multi-drug resistant, but a low-level resistance to atazanavir and lopinavir, but remaining susceptibility to darunavir, luckily. And to our surprise, there were no resistance to the RT gene. All the NRTIs and NRTIs, which were there in the first line and second line regimen, were shown to be susceptible. So clinically, we suspected archived resistance. And also, the triple threat in this report, if you closely see, there are three mutations that we identified in the integrase gene. The G18R, which was the primary mutation which conferred the resistance, as well as the reinforcement resistance, the minor resistance, which made increase the efficacy and replicative capacity of the virus, making it a very stable resistant variant. And the big picture is that the presence of L74M shows that the patient had to stay on unstable viral loads for a long time because this is a mutation which occurs when the virus gets some time to modify its resistance. And the management, as per the SASA National Guides Protocol, we shifted her to the darunavir, ritonavir, BD regimen, ZL as the backbone, and efavirenz. And the principle behind this was to give a regimen depth so that the higher dose of darunavir was used, and it was also given susceptible. And multi-class synergy was used so that more than one group of drugs was used, and cumulative antiviral pressure was used to overcome the suspected archived mutations. And you can see the outcome was being very good. For the first time in her life, she achieved TND viral load results, and the CD4 also went more than 400 within a span of 1 year, and she has been maintained on this for 1 year. But we are on vigil because we are always, in the back of our mind, we have the possibility of tissue reservoirs and archived resistance. The discussion, as we know, there are many factors affecting ARV drug resistance, including viral and patient factors. But this is the major Achilles heel in our program because this mutation, as we know, we have learned that dolutegravir has a very high genetic barrier for resistance. But this one mutation is the one thing which can create an easy shortcut for the virus to attain resistance because because usually multiple mutations are required for a resistant stable virus. But in the case of a subtype C variant, only a single point mutation is required. And that is shown in this diagram. For in the first diagram, you can see subtype B, the 2 mutations, including a transversion, is required for a stable mutant variant. But in our subtype C on the right side, you can see that a single point mutation can confer a very high resistant virus. And hence, in Indian subcontinent condition, even DTG is susceptible to resistance and also transmitted resistance in future, if not under vigil. And the public health approach, we know the challenges and what are the advantages. My only suggestion for this would be a hybrid model rather than a comparison between public and private. We require a public health model for the scale and equity and for the accessibility of resources. But at the same time, we have to identify early treatment failure cases and give targeted genotyping. And an HIV subtype specific resistance sentinel surveillance has to be done. And also newer drugs like lenacapavir or doravirine, which are showing high promise in such conditions, have to be applied at least as a salvage drug or reserve drug for these patients. Conclusion, I would just like to mention that a public health approach that ignores resistance is a program that eventually will lose most of its powerful tools. And hence, strategic genotyping, novel drug access has to be there to protect the integrity of the national medical program, a hybrid model so that the cost of it will also be the cost effective model is better than maintaining patients on expensive third line regimens and advanced disease. Thank you.
Thank you, Dr. Sri Kumar, for good discussion about this thing. If there are any questions, one or two questions can be taken.
Actually, sir, the first line drug she was taking from a different ART center in Ernakulam, and we are having a SASTAP at Thrissur. So, we don't have the first hand information. Yeah. This, that was one of the suspects, but we could not trace it because while the patient had come for ART in 2018, her spouse was already died. And from her available evidence, it was just a road traffic accident. So we don't know about it. Yeah, we had a strong suspicion. Yeah, actually, we had the same concern because this decision was taken from Tambaram, and we were there because third line has to occurs at Tambaram. So we flagged the same reason. We were actually not very happy with the regimen that they suggested with darunavir and efavirenz. But despite the, and we had even urged for a NASEP. And we got a NASEP consultation, but they again reinforced the same regimen and they asked us to monitor for 1 year. Luckily for the patient, she became, yeah, 10 of her. Yeah, yeah. Yeah, we actually we had our SASAP at our institution had a suggestion, similar suggestion. Thank you, sir.
Efavirenz resistance because a lot of people who told they had adherent, but they were not. Probably 600 to 400 would have helped. Even now also when you are thinking of reintroducing efavirenz, 400, and there is a definite role of doravirine.
Yes. So actually the first line, the case when she was documented with resistance, ideally we should have done a genotypic resistance testing to identify whether there was really mutations to efavirenz, because once she was put off of efavirenz, maybe that mutations were archived. So what happens is in our setup, it is very difficult to get a genotypic resistance testing or even evaluation reply for a treatment failure cases, because in the regimen it is always very tight line that if you see a viral load high, so the only thing we could from available clinical history and what history we saw from the third line when the patient was first hand with us, she has appreciable adherence. And we also ruled out whether there were any conditions where it was inhibiting the drug therapeutic levels in the blood, like absorption issues or any drug-drug interactions. That were also evaluated in our institution's ASAP and we had ruled them out. And taking the caregiver considerations and all the history we have regarding her opportunistic infections, clinically she is not having much failure. So we thought like maybe it is a true resistance to efavirenz. Yes, that was what we were expecting in the last regimen, but it's only 1 year now, maybe.
Dr. Rijit, I think good case presentation, good follow-up. I think your recommendation that NACO should consider at least selected cases wherever possible drug resistance testing need be. I think this is a very important advocacy point to be given.
Yes, sir. Actually, in our center, in the last 4 years that I've been working, we found 3 cases of resistance, and that was 2 cases to dolutegravir and 1 to zidovudine. And we had another 4 cases which we were suspecting resistance, but we didn't get permission from NACO to do a resistance testing. And the patient could not afford testing outside because it cost an upwards of 10,000 rupees. Okay, thank you.
Thank you, Dr. Srijit Sri Kumar. for a good presentation. May I request Ritvik Jain, Dr. Ritvik Jain to come forward, and will be speaking on determinants of an elevated AST to platelet ratio index and fibrous scale.
Good morning, respected Chair, ladies and gentlemen. I'm Dr. Ritvik Jain, presenting this given presentation titled Determinants of an Elevated AST to Platelet Ratio Index and Fibrosis for Scores in People Living with HIV on Stable ART Regimen under the guidance of Dr. Satish P. Rao from Kasturba Medical College, Mangalore. Yes, we are well aware of the fact that India ranks second globally presently as far as the HIV burden is concerned. So the most important thing here is that there has been a post-ART era, there has been a significant paradigm shift from infectious to non-infectious causes of morbidity and mortality in people who are living with HIV. And liver diseases now ranks among the top contributors to non-AIDS mortality. HIV itself is an independent risk factor with viral hepatitis, alcohol, MASLD, and hepatotoxic drugs as established causes. Therefore, what I would like to state here is that early identification of liver fibrosis is essential for individualized management. Then, coming to the practical alternatives, we are well aware of the fact that tests like transient elastography, that is FibroScan, and liver biopsies, although are considered to be gold standards, are not widely accessible. And therefore, APRI, that is your AST to platelet ratio index, and FIB-4 scores offer practical alternatives. Now coming to the study objectives and methodology, the aim of the given study was to determine the risk factors that influence APRI and FIB-4 scores in people living with HIV on stable ART regimen, to detect the proportion of people living with HIV on stable ART with elevated APRI and FIB-4 scores. Then alcohol assessment, the ones who had proportion with significant alcohol consumption, to judge the independent predictors and compare the given factors. So study design, it was a cross-sectional descriptive study done in the ART centers of KMC Mangalore involving 251 participants. Now, as we can see here in the given charts, that the mean duration of HIV positivity in ART usage was about 10 years, but ART regimen starting was only about 7 years. Males and females were near proportionate, about 55% for males and 45% for females. Alcohol consumption significant as per the NIAAA criteria was noted only in 11.6% of the given participants. And the mean BMI starting before and after ART regimen has been mentioned in here. Now coming to the key findings, prevalence and alcohol impact, 29 patients had elevated APRI scores, 11.6 in percentage, 40 patients had elevated FIB-4 scores, that is 15.9%, and 29 patients had significant alcohol intake, 11.6%. And if you look at the alcohol interaction analysis, 31% had statistically significant data, FIB-4 with alcohol interaction. Now coming to the correlation analysis, here I would like to point out that age is had the strongest positive correlation with FIB-4 scoring. HIV duration also had a positive correlation, and so did, and with the current BMI, there was a moderate negative correlation. So the clinical takeaway from this given slide is that we have to prioritize fibrosis assessment for older patients and those who are on a longer HIV duration. Now, coming to the discussion, the key insights and the clinical relevance, as I have noted here, age as a FIB-4 driver. It highlights the need for age-adjusted cutoffs in screening algorithms for people who are living with HIV to prevent over-referrals in older patients and under-referrals in younger patients. Alcohol, significant alcohol consumption has been noted, so we need to develop regimens that prioritize alcohol reduction and further cessation in people who are living with HIV. And HIV duration suggests a cumulative effect of chronic inflammation in long-term ART exposure. And there is a paradoxical BMI correlation. This finding suggests that FIB-4 might underestimate the fibrosis risk in leaner patients who still may have a significant liver fat. Now, coming to the conclusions and the clinical implications, screening imperative is that APRI and FIB-4s are influenced by HIV-related and non-HIV factors. So we need to implement a routine periodic liver risk screening for all people who are living with HIV, not just the ones who have traditional risk factors. Significant alcohol use is associated, raises FIB-4, so we need to prioritize brief interventions and referrals counsel the people who are living with HIV to reduce or stop alcohol to lower the fibrosis risk. Coming to the duration monitoring, longer HIV duration is linked to a higher fibrosis scores. Thereby, we need to institute longitudinal monitoring for people who are living with long-standing infection to detect slow progression at an early stage so that interventions can be done accordingly. And age is known to heavily skew FIB4, as has been noted with this given study. Now, the future research directions are there needs to be urgent studies which are needed for differential ART regimens, hepatotoxicity. We need to investigate CD4 thresholds that increase fibrosis risk. We need to validate age-adjusted FIB4 cutoffs, especially in people living with HIV cohorts. The clinical urgency with this given research is that we need to integrate routine liver risk screening into HIV care pathways, deliver targeted alcohol reduction interventions, and prioritize research to refine FIB4 interpretation. Early action is going to prevent progression to advanced liver disease and improve long-term outcomes for people living with HIV. Any given study has its limitations. So we did not have a viral load for multiple patients that were taken into consideration. Different ART regimens could not be assessed for differential hepatotoxicity. Comorbidity impact of diabetes, hypertension could not be assessed with this given study. Age cutoffs were not applied for the FIB4 scores. And confirmation method still remains liver biopsy as the gold standard. So that could not be done for this given study. These are my references, and thank you for your patient listening.
Thank you, Dr. Jain, for good discussion about this thing. If there are any questions, if there are no questions, may I request the next speaker to come over oral presentation. This is Sabina Chogle. Prevalence of cryptococcal antigenemia in advanced HIV, a retrospective study from Mumbai. Over to.
Good morning, everyone. I'm Sabina Chogle from Unison Medical and Research Center. Okay. Today, I will be presenting our study on prevalence of cryptococcal antigenemia in advanced HIV. This study evaluates the burden of cryptococcal antigenemia in advanced HIV and highlights the importance of targeted screening. Sorry. To begin with, let us first briefly discuss the clinical significance of cryptococcus in HIV. Cryptococcus remains one of the leading cause of mortality in patients with advanced HIV. Even in the era of ART, patients with severe suppressions remains at high risk. Many patients are often asymptomatic until they develop meningitis. Therefore, screening for cryptococcal antigen is recommended, especially in patients with low CD4 count. Early screening through cryptococcal antigen screen can prevent progression to meningitis and reduce mortality. Despite effective antifungal therapy, mortality remains high mainly because of delayed diagnosis. Let us now look at what Indian data suggests. In India, the reported prevalence of cryptococcal antigenemia among advanced HIV patients varies is approximately between 2% to 8% depending upon the region and CD4 threshold used. In large Mumbai ART program, the overall prevalence was 0.9%, but it increased to 3.6% in patients with CD4 count less than 100. Another study from KM Hospital in Mumbai showed prevalence of 2.7% in patients with CD4 count less than 100. Another study from Northwest India reported 5.17% of asymptomatic cryptococcal antigenemia. A study from Pune found prevalence of 8%. Routine cryptococcal antigen screening in patients with CD4 less than 100 is increasingly being emphasized in Indian guidelines as well. However, real-world Western Indian data remains limited, which forms the basis of our study. The objective of our study was to determine the prevalence of cryptococcal antigenemia in advance in patients living with HIV, to compare their prevalence between patients with CD4 count less than 100 and 100 to 200 cells per microliter. We also assess their association with ART interruptions and clinical outcomes. It was a retrospective study conducted between May 2022 and December 2025. We included 62 patients living with HIV with CD4 count less than 200 cells per microliter. We collected their socio-demographic data, their laboratory data, including CD4 counts, HIV viral load, and cryptococcal antigen test results, and other opportunistic infections, and their ART status. We then stratified them into two groups, CD4 less than 100 and CD4 between 100 to 200. Coming to results, we included total 62 patients. 74% have CD4 count less than 100, indicating severe immunosuppressions. Their mean CD4 count was 53 cells per microliters. 72% patients were male and 28% were females with mean age of 44 years. Importantly, all of them have detectable viral loads, suggesting treatment interruption and delayed diagnosis. Coming to their ART status, 72% patients were on ART but had defaulted on treatment. 28% were newly diagnosed and ART naive. One person was diagnosed 2 months earlier, but ART was not initiated. Now coming to primary outcome of our study, cryptococcal antigenemia was found in 2.1% of patients, that is one patient. Importantly, the positivity was confined to patients with CD4 count less than 100. No cryptococcal antigen positivity was observed in patients with CD4 count less than 100 to 200 cells per microliters. Tuberculosis was detected in 30% of the patients, and highlighting the burden of opportunistic infections in advanced HIV. Let us now briefly look at the cryptococcal antigen positive patient. The patient had long-standing HIV infection. He was diagnosed in 1997 and enrolled at our center in 2003. Over the period of 17 years, the patient had defaulting and interrupted ART. He last visited our center in 2020 and was lost to follow-up. When he returned to our center in 2022, his CD4 count was 55 cells per microliters, and serum cryptococcal antigen was positive with titer 1:160. As per standard protocol, lumbar puncture was confirmed CSF cryptococcal antigen positivity, confirming cryptococcal meningitis. Despite initiation of treatment, the patient succumbed to infection within 2 months of diagnosis. This case highlights how delayed diagnosis and ART interruption can have fatal outcomes even when screening is performed. Coming to conclusion, although overall prevalence was 2.1%, cryptococcal positivity was confined exclusively to the group having CD4 count less than 100. This enforces the importance of targeted screening in patients with severe immunosuppression. Strengthening early HIV diagnosis, timely ART initiations, and sustaining adherence to treatment remains critical to prevent any cryptococcal-related mortality. To conclude, even low prevalence does not mean low clinical significance because a single missed case can be fatal, as demonstrated in our study. Thank you.
Thank you, Dr. Sabina, for completing this in time. If there are any questions? Dr. Kumar?
For the guidance, my only question is, your patient comes to you, you do a CD4. Do you do a cryptococcal antigen test along with that?
If the CD4
short-
count is less than 200.
Yeah, but of course, the CD4 count is going to take like 3 hours or 4 hours, or by evening it comes. After looking into the CD4, you're going to do the cryptococcal antigen, or you did that all these at baseline itself?
No, mostly when sir suggests we do it, but after the CD4 count is less than 200, we do it. Cryptococcal screening.
Okay, so here you'll have a mixture of patients. Some of them you would have done along with the CD4, because they are clinically sick, right? Some of them after the CD4 count. Yeah, I'm just wondering, anyway, your percentage is 2.5%,
0.1%.
2.1% in an outpatient clinic. So, sorry. Yeah, small study. That's a good number, actually. It is as compared to the lot of published reports, that equates. But on the other hand, how you're going to choose this? How you're going to do that? That's an important question. But it's a very important study in a outpatient clinic, because all the published reports are all from inpatient clinics services, or tertiary care centers. Very rarely it's been reported from outpatient clinics.
Hmm. Yes, yes.
Dr. Vijay, I think. Thank you. May I request Dr. Jayakrishna Kurada to speak on recurrent tuberculosis and mortality among people living with HIV in a high burden setting in India, a cohort study from Andhra Pradesh.
So I'll be presenting this on behalf of Dr. Kurada, who could not be here. So I'm presenting this study on behalf of my colleagues from Share India and also from CDC Delhi. So very quickly, this study was done primarily to look at what happens with tuberculosis and HIV in Andhra Pradesh. It's programmatic data. It's a retrospective cohort analysis. Sorry. So, and the reason for this is Andhra Pradesh happens to have a high prevalence of both HIV and tuberculosis. So the critical time period is the time 2 years after somebody has completed a course of therapy for tuberculosis. That is the reason. So it's a retrospective cohort study of 3,357 PLHIV over 15 years of age. Successfully completed ATT in 2017 to 2021. 14 ART centers across Andhra Pradesh. And follow-up period was 2 years. So a total of 6,372 person years. And recurrent TB or new TB post-ATT was the thing that was looked at. All-cause mortality and then incident rates per 100 patient years. So here's the key results. 6,372 person year follow-up, 270 cases of recurrent tuberculosis. So that's an incidence rate of 4.2 per 100 person years, and a total of 510 deaths. So that's 9.1 per 100 person years, pretty high rate of deaths. So the predictors of recurrent tuberculosis, male sex, pulmonary tuberculosis is a little surprising versus extrapulmonary, and delayed secondary ionized prophylaxis, limited exposure to DTG. Now this is, of course, at a period of time where we were transitioning to nationwide DTG. So part of it, this is legacy ART regimens. And then most importantly, non-suppression of the viral load. So other predictors of mortality, low CD4, viral non-suppression, no dolutegravir, and lack of viral load monitoring. So early IPT initiation reduced mortality risk. So key conclusions are, we do have a significant risk of recurrent TB post-ATT. So this is a time period that we should be looking at very carefully. And non-suppression of the viral load is a key predictor of both recurrent TB mortality and early initiation of secondary IPT associated with significantly reduced mortality. So this is the program implications that we need more intensified follow-up in the period of time post-ATT young people. Now, obviously, all of this data pertains to the period of time when we were still transitioning from legacy regimens to dolutegravir anchored regimens. Thank you.
Thank you, Dr. Vijay, for presenting. Wow.
We don't. We don't know. This is all retrospective analysis of existing program data. So you are correct. You know, yeah, and this is a crucial question because A, these are people who had low CD4s. So treatment failure is a significant concern. Second, a lot of them had unsuppressed viral load. So they were not optimally treated. Third, these are all legacy regimens, as you know, much less efficacious than dolutegravir anchored regimens.
Any data on MDR TB on these cases?
No, I don't have that. Well, what Kumar is referring to is inadequate treatment and treatment failure. Okay, so some of these clearly are probably treatment failures, but as we all know, people who are highly immunocompromised are subject to reinfection. So a lot of old TB cases that we thought were treatment failures or inadequate treatment reactivation, we later learned that they were actually new infections, reinfections. So that's why I'm saying it's not very clear.
Sir, there was a case series from Hinduja Hospital by Dr. Soman telling this FDC we use in government program. When they do the therapeutic drug monitoring or rifampicin, there is a subtherapeutic level of rifampicin.
Tell me about it.
Recurrent
I have seen so many patients in my own clinic who are being followed in the TB program who are on suboptimal rifampicin dosages because they eyeball them and say that, you know, the average Indian weighs only 40 kilograms and therefore they get only 400 or 450 milligrams of rifam. It's absurd. You know, one of the things that we should remember is the 10 per kilo dose of rifampicin was not chosen for optimization of efficacy. It was chosen for other reasons, including cost. You know, although there is one study that I'm aware of that did not show a significant advantage of going to higher doses of rifampicin, like 20 per kilo. But I think that the key take-home message should be that giving somebody less than 10 milligram per kilo of rifampicin is really not desirable. I agree with you there.
Thank you, Dr. Vijay. On behalf of Dr. J. Krishna Kurada, you have presented a good paper. May I request the next speaker will be speaking on Yash. May I request Yash Wag to present a clinical profile and pattern of dyslipidemia in HIV patients receiving antiretroviral therapy, a prospective observational study. Over to Dr. Yash Wag.
So, good morning, everyone. I am Dr. Yash Wag, a junior resident from St. J.S. Medical College and KM Hospital. Today, I will be presenting our study title, that is the clinical profile of HIV patients who is on ART, develops dyslipidemia, and the potential risk factors and patterns of lipid abnormalities in such patients. So HIV is transformed from highly fatal disease to chronic manageable disease after the introduction of the ART. But the long-standing exposure of the ART now causes the severe metabolic dysfunction such as dyslipidemia, which further increases the cardiovascular risk and which is the leading cause of morbidity and mortality in the patients. So this dyslipidemia is multifactorial. It is because of mostly chronic infection, persistent immune activation, and because of the ART exposure for the longer duration. So Indian data on ART-associated dyslipidemia is very limited. So our study was aimed to evaluate the clinical profiles of HIV patients who is on ART, who develops the dyslipidemia, and patterns of the lipid abnormalities. So our Primary objective is to determine the prevalence of and pattern of dyslipidemia among the people living with HIV receiving the ART, and to assess the clinical profile, and also to study the lipid components such as HDL, LDL, and triglyceride, and also to evaluate the proportion of the patient receiving the lipid lowering therapy in such cases, and to study the treatment gaps, and also to evaluate the proportion of patient develops the cardiovascular abnormalities and the risk factors. So the materials and method, was an observational, analytical, and prospective study was conducted at St. Jude's Medical College and KM Hospital. The patient attending an ART outpatient department OPD and those who are admitted in the department of the medicine are included in this study. So data was collected over the 18 months of the period. We included the patient who are the HIV infected individual, which is more than 12 years of age, who have been on the ART since more than 12 months with informed consent, and excluded the patient who are associated with metabolic disorders such as obesity, diabetes insipidus, thyroid disorders, and we exclude the patient such as who is specifically on the drugs which are affecting the lipid metabolism such as diuretics, beta blockers, cyclosporine, and the long-term steroid therapy. And we also excluded the patient who are chronic alcoholic and the pregnant patient and some autoimmune disorders. So from this, our result was the study included the 216 participants, out of which the 141 are the males and 75 are the females with male predominance. So in the lipid abnormalities, our study was out of the 216 participants, 5.1% of the patients shows the hypercholesterolemia, 18.4% of the patients shows the hypertriglyceridemia, 81.3% of the patient shows the reduced HDL, and 51.6% of the patient shows the elevated LDL. So overall dyslipidemia prevalence in our study was 91.7% of the prevalence, and out of which only 16.6% of the patient was on lipid lowering therapy. So dyslipidemia is highly prevalent in the ART patients, predominantly driven by the low HDL and high HDL triglyceride, notably seen in the abacavir and dolutegravir based regimens. The complication because of the dyslipidemia as cardiovascular accident and ischemic heart disease. So we also studied in our study, we also studied the BMI profile. The nearly half of the patient, around 47% of the patient shows the normal BMI, but there are some overweight and obesity we are noted in the study, which is improved because of the ART, but sometimes indicate the shift from slim disease to overweight and metabolic risk phenotype risk in people living with HIV. So compared to the Zambian study, our study showed the lower underweight prevalence with higher overweight and obesity rate. It is because of the mostly improved access to ART, better nutritional support, sometimes lifestyle factor and dietary changes, and metabolic effects of ART, especially dolutegravir-based regimens. So the predominance of low HDL and high LDL triglyceride indicates the pro-atherogenic risk in people living with HIV. As compared with the other studies such as Kigongo and Aquila, which shows the 78 and 86% of the prevalence in dyslipidemia, our study shows the higher prevalence, suggesting a greater metabolic burden, which is possibly because of longer duration of ART exposure and predominant use of dolutegravir-based regimen, and sometimes lifestyle and dietary factors and genetic predisposition in the Indian population. The clinical implication is to do routine lipid monitoring is essential in people living with HIV, and early identification can help in cardiovascular disease. So despite 91.7% of the prevalence of dyslipidemia, only 16.6% of the patient receiving the lipid lowering therapy, which signifies the significant treatment gap in the management of dyslipidemia in people living with HIV. So there was one study by Daniel B. Kasten, which suggests that we prefer mostly the atorvastatin and pravastatin as a lipid lowering agent, as a safer option than using rosuvastatin and pravastatin because of the lesser interaction of the drug with the protease inhibitors. So many patients in the study, especially those with isolated low HDL, were not on the lipid lower therapy. So in the conclusion, the study analyzes the clinical and metabolic profiles of people living HIV, people with living on HIV on ART, with and noting the trends in age, gender, BMI, and treatment patterns. Although the ART access and public health measures have reduced the HIV prevalence, the metabolic complication and renal dysfunction remain the major concern. The very high prevalence of dyslipidemia highlights the needs of routine lipid monitoring and cardiovascular risk management. Despite optimized ART regimen, lipid-lowering therapy is underutilized and indicating the gaps in dyslipidemia management that require the pharmacological and lifestyle interventions. A multidisciplinary and preventive approach, future longitudinal research are essential to better address ART-associated metabolic risk and improve the long-term outcomes in people living with HIV. These are my reference, and thank you very much.
Thank you, Dr. Ashwag, for completing in time. If there are any questions from the audience?
So it's a very good study. I wanted to know what was the timing of doing lipid profile? Was it fasting sample or any sample? Number one.
So we generally do the fasting samples.
Generally, but not all or all. If yes, because many patients who are on antiretroviral drugs, they have got more triglyceride levels. Triglyceride levels are more when the sample is not fasting, after breakfast or after meals. Number one. Number two, if the triglycerides levels are more, then the LDL level, which is reported, usually it is a calculated level. So in that case, LDL has to be done separately.
Yes, sir, we can.
So do you have clear-cut data that LDL in such cases is directly done or it is a calculated value?
No, sir, we don't have clear data.
Don't have. Okay.
Yeah.
Age?
What is the age of the patients, of dyslipidemic patients in your study?
In study, we included the HIV patient who are more than
Dyslipidemic patients, what is the age of range?
age, more than 12 years of age.
Not duration, it is the age of the
Duration
patient.
of the illness was
Age
5
of the
years,
patient.
5 years.
Because it
Yes.
advanced stage in elderly people also, it is very common whether it is included or not. Age of the patients.
If there are no questions, let us conclude this session.
Thank you very much. We'll be concluding the session. I'd like to call upon Dr. Kumaraswamy to felicitate our chairperson, Dr. Bharat Yalgi. We'll now be commencing with our next session, ART in 2026, Choosing Right, Switching Right. I'd like to invite our chairpersons on the dais, Dr. S. Nageswaramma from Guntur and Dr. Dilip Mathai from Vellore. We'd like to hand over the proceedings to our chairpersons.
Hello, good morning, everyone. We all know ART makes major difference in PLHPs. It not only increases the quality of life, it also prevents transmission of HIV. When patient is on antiretroviral therapy, there may be failure, there may be side effects, or there may be metabolic disturbance. In such conditions, or in naive patients, what is the regimen we have to choose, when to switch? This will be explained by Dr. Kumar Swami, who don't need any introduction. He's a well-knowledgeable person. He's working in this field since 55 or so.
Suswagatam, welcome Dr. N. Kumarasamy to ASICON 2026.
It's not me.
A distinguished HIV expert from Chennai, he plays a pivotal role in shaping evidence-based art practice and translating global guidance into meaningful clinical impact. Today, he speaks on WHO art guidelines in 2026, what has changed and what matters clinically.
Good morning, everyone. So today, what I'm going to do is, as many of you know, that we have a new WHO guideline being launched late last year and still not implemented in many parts of the world, including here in India, in our national program. I thought I'll just walk you through what is new in that and what are the things which you can take home, to get it implemented as soon as possible. As all of you here know that these are the various antiretroviral till today been approved for use. I've been using this slide since 1996. At that time, I used to have a small slide. Then we developed it in the PowerPoint presentation. The new one, which we have added, is the lenacapavir, which is the one now approved for use. There will be several new molecules will come up in the next year or so. Now, coming to these antiretroviral drugs, the first question will be when to start antiretroviral drugs, which we all know that soon after you diagnose, irrespective of the CD4, currently you start on it. Any change in the new guideline? So nothing new. And again, these are the two pivotal studies, one called HPD-1052, another START study. Both study very clearly showed that there is no other study I've ever proved now till today that you should not start early. So, and also in the new WHO guideline, there is a stressful things on starting treatment very quickly. There are a lot of stresses have been given on rapid ART start and same-day ART start. So which again, we can debate on that, which is again being stressed in the new guideline. But it's also part of the earlier guideline, but more stress had been given because there are some individuals start a little late, like after 2 weeks or 3 weeks, which there is a huge loss to follow-up had happened in different programs. Coming to these on what to start with, there were few changes that happened, which I'm going to walk you through today. What are those new changes, particularly on the second line, even on the first line, and also simplifications, as well as some of the long-acting stuff. I'll just closely walk you through on this. As all of you know that you have been practicing this guideline, 2021, where the preferred therapy is TLD. And even in the 2021 guidelines, we had indicated TAF as an alternate, but people are not using it in programs, but it was used a lot by the private physicians, particularly in aged populations, postmenopausal women, so on and so forth. But in the new recommendations, which came in late 2025, which is not, again, implemented in the national program, what that is not only the tenofovir, but also TAF is a preferred therapy, along with the lamivudine or emtricitabine and dolutegravir. So the new addition being TAF, which is again, it's been a preferred therapy. Earlier, it was not a preferred therapy. Now it will be a preferred therapy. Why it has been chosen is, again, we all know that. So this is one of the first data our group published here from India, stating that risk to renal toxicity following tenofovir, which was further supported, well supported by data from other Asian countries. Why I'm showing Asian countries is many of the drugs have got a genomics predisposition causing certain toxicities. So it very clearly shows that even in other Asian countries, we have got a similar risk to develop a tenofovir toxicity. Following this, all the guidelines started recommending giving creatinine annual monitoring, and there are creatinines going up, changed to the other alternative drugs. So again, why TAF has been preferred? You need to know that, why? Because you're going to make a very critical decision, changing many of your patients from tenofovir to TAF. So we all know that when someone swallows a tenofovir tablet, it will not get absorbed. It just excreted. But on the other hand, the drug what you're using, TDF, that is tenofovir dispropyl fumarate, as a 300 milligram, get absorbed. Only a small portion of the drugs go to the target site to inhibit HIV, but larger chunk of the drug get excreted as renal tubular cell function, causing toxicities here. So this is a major pathogenesis begin, renal toxicity following tenofovir. But the drug of TAF, which is a prodrug of tenofovir, but it can be given as a 25 milligram. When it has been swallowed, the major portion of the drug goes and suppresses a target site, and a small proportion of them get excreted to the level which causes the ileotoxicity. This is a simple mechanism behind this TAF on the prodrug. Now, this principle is going to be used for a lot of other future drugs, not only in HIV, even for a lot of other diseases, and as well as other comorbid conditions. This is a very classically example shows that how this prodrug can minimize the toxicity. Following this, now this TAF recommendation had been done on this. So moving to these next recommendations, as you all know that we all have bictegravir in a generic market too, here too. Some of you have already been using. Already DHSS and the British and the US guidelines clearly recommend TAF, emtricitabine, bictegravir as also one of the starting treatment, not only on tenofovir, emtricitabine, and dolutegravir, and tenofovir, lamivudine, dolutegravir. And why it is not recommended in the WHO guidelines? The reason is not because of any science, because this drug has got interaction with the TB medication. Since don't give along with rifampicin, there are some studies that have been done which showed interactions. Then they try to double the dose, but again, unfortunately, this drug is not available as a single tablet. It's always available as a single, as TAF, emtricitabine, and bictegravir, not as a bictegravir single. Hence, if you're going to double, you're going to double all the drugs. So that's not good for the patients, increase the cost, and also can have some toxicity, particularly in FTC if you give it a higher dose. Hence, for this reason, it is not recommended in a national program because they want to pick one particular drug, not for any other science. In your private setting, if you got patients who don't have TB, you can safely give, and also bictegravir is now recommended even in pregnancy. So the next major changes happen in the WHO guideline, which you all will be implemented across the national program, is on simplification. Someone who is already on antiretroviral therapy, they got a suppressed viral load, you can change them to this 2-drug therapy. It was initially been developed as a molecule called Day-2. In India, it is available as a Twinact. The recommendation today is, yesterday you heard a lot of presentations on this 2-drug therapy and as well as today. The one recommendation what we have made is, now at this time, for all patients who got suppressed viral load, who have got a previous failures, treatment failures, who have been started on treatment in your clinic, where they all have a suppressed viral load, you can change them to this 2-drug therapy. And again, why this recommendation made? It's not a new data. This has been published almost 7-8 years back. There's a study called Gemini study, where they've shown this particular drug is not only for in suppressed patients, but also even if we are initiating treatment, particularly in patients who got less than 500,000 copies, it has been non-inferior. Based on this analysis, it's initially recommended in other parts of the world, but in India and as well as for other lower and middle-income country, we have been waiting for more and more data, particularly because we don't want to lose this drug of dolutegravir when you're giving along with one other drug. Now we have got enough solid evidence on this. Also, we recommend if you give them, make sure that they adhere to the medication, and also if there is a possibility, repeat the viral load after 2 to 3 months. I'm sure you can do it in your private practice, but I don't know how they are going to implement this. We have given a small note in the WHO guideline up to the national program to adapt that, so that you make sure that they are continuing to have a virological suppression. And very importantly, as you know that tenofovir is very important for hepatitis B management along with lamivudine. So it is not recommended in hepatitis B co-infected. Yesterday, we had a lot of discussions on this. Make sure that there is a hepatitis B screening should be done. And they are negative, make sure that they are being vaccinated because it's a very cheap vaccine. And also, we do not have enough data on TB patients who are taking on rifampicin therapy. So here you cannot double the dose of rifampicin along with the DTG, 3TC. We do not know about the data, but it can work. At this time, don't experiment on this. Put them on the triple therapy and as well as the rifampicin containing therapy, and you can double DTG, but not as a 2-drug therapy. And also, the Western guidelines recommend also to initiate treatment, especially in patients who have got a viral load less than 500,000 copies. Since we are not doing baseline viral load, we are not doing these recommendations. Hence, don't do this in your clinic, because unless you have a clear baseline viral load, which is less than 500,000 copies to initiate, but otherwise use it on your patients who got suppressed at this time. But we may even make more and more recommendations based on newer data coming up on lower and middle income countries. So this will prevent major renal toxicity and as well as bone toxicity in our patients who are already on antiretroviral therapy for a long time. And also, I personally feel that this is a very important recommendation, particularly for India. We got a lot of other comorbid conditions, which we can prevent this by doing these substitutions before they start developing toxicities. Moving to this next recommendation, which is on the viral load, which you all know that viral load is a preferred way of monitoring patients, which we all do these viral load monitoring, CD4 monitoring, clinical monitoring. All this monitoring is important, but a lot of programs are moving away from CD4 monitoring, but don't move away from any viral load monitoring. So we have a clear recommendation, should be done 6 months after initiating treatment. You can even do even before also, if you have got access to that, 3 to 4 months. And once suppressed, again repeat after 6 months. And if it is suppressed, it's annually. But if you have got access, you can do every 6 months also, because it's very important, not only for the patients to know that whether they are virologically suppressed, and also for our physicians to know that whether they are adhering to the medications also not. Also, we are now talking about usable. This viral load suppression is important. Coming to the guidance, if you look into those, I don't want to take much time of that. So this very clearly shows that someone who has been failing therapy with more than 1,000 copies, you improve the adherence, repeat the viral load after 3 months. If still continuously more than 1,000, then you consider it can be a failure. If you got access to resistant testing, you can do, or you can, the public health setting, you can switch to the second line. Whereas there are a significant number of patients might hover around between 20 copies to 1,000 copies. This we call it as low-level viremia, which is a very important, these patients, they have a high risk to failure. Identify them, make sure that they adhere to the drugs, keep doing viral load monitoring on and off, you have access to that. And if they have been going more than 1,000, immediately switch, don't wait for it, because high risk to develop a failure if they have low-level viremia persistently. And again, if they develop a resistance, it's mainly to the suboptimal drug pressure. It can happen to all these RT protease and as well as integrase gene. And as you know that once developed, it's permanently archived. Some drugs are low genetic barrier, which you are removed, like favrans and nevirapine. They can have cross resistance. Somebody fails with dolutegravir, don't change them to bictegravir. Both belong to the same class. And also against a PIs between arachnavir and lopinavir. And also, once they fail, it can also accumulate mutations. Hence, it's very important to switch quickly before they accumulate more and more mutations and cause severe failure. And again, the principle for second line is also the same. Once they fail, they should have minimum 3 drugs or at least 2 drugs and 1 from a new class. If they're on NNRTA failure in the past, use integrase or a PI. So this is very, very important. And again, 2 NRTIs should be selected based on the resistance if it is available or speculate. So here we have got some new recommendations coming up. I'm going to walk you through this. So what is those recommendations? So this is the one in 2021, which I used. Someone who fails TLE in the past, what you have done is you change them to AZT 3DC and dolutegravir. So why you did that is because of resistance profile, where tenofovir, when they develop resistance, you change to the another NRTI, which is from a different group, but the same class, different group with a different resistance profile. So, but on the other hand, someone who failed a DTG with a resistant mutation, the earlier recommendation of change them to arachnavir or lopinavir. So here the recommendation is of darunavir 800 was only an alternative in the earlier guideline. So again, we have 2 recommendations from this, which I'll walk you through now. One is we have severe toxicities, AZT already been reported from globally in many, many studies, both retrospective and clinical trials. So we don't want to give a toxic drug when they fail along with a good drug like DTG, where there is a profound risk to develop a major morbidity related to AZT containing therapy. So to understand this, there's a very nice study happened in sub-Saharan Africa called Nadia study. A few years back, it's been published. So what they did is in patients who have been failing tenofovir, lamivudine, and efavirenz, they randomized into 2 groups. One group, they recycled tenofovir along with the DTG or darunavir. Another group, they changed them to the public health WHO guidelines or AZT 3DC, DTG, or darunavir. Just for want of time, I'll just quickly go into the results. So, if they don't have a tenofovir resistance, AZT also equally working. But of course, we do not know that very well that tenofovir will work very well. But if they had a failure to the first line resistance, even with the tenofovir resistance of K65R, when they compared this with the AZT, which did not have a resistance, based on the earlier public health guideline, still tenofovir containing therapy worked very well, even they have a K6VR mutation. It was a very interesting finding. Following that, there are guidelines started recommending, but they do not know what to do that. They wanted more evidence on this. So for that, we constructed a study, which I led this global study, which now got published a year back, and we presented a couple of years back. It's called DEF study. This is a large multi-site study done in 18 different countries. Patients who have been failing NNRTA containing therapy, we randomized into 3 different groups. One is, we recycle tenofovir along with DTG to answer the critical question, can we recycle? Another group, instead of arasenum and lopinavir, we used darunavir 800-100, and as well as we also had a newer version of darunavir 800-100 with the DTG. I'll quickly go into the results. So what we found in this particular trial is, all right, things went back. Can you go back? Okay. Right. So what we found in that trial is, when we recycle tenofovir, lamivudine, and dolutegravir, with dolutegravir is a new drug, tenofovir we recycled, we just got a little higher virological suppression as compared even to the WHO recommended PA of darunavir 800. So that means even if they have a resistance testing in a large clinical trial like DEF, it really worked. And also we found that the newer regimen of darunavir dolutegravir, which is much more superior as compared to the current recommendation on this. So again, there are a lot of sub-analysis going on this. We may come up with more and more recommendations based on this particular study. Now, from the initial results, now we have done some recommendation with the WHO guideline, 2025, is someone who fails TLE, you safely change them to TLD. So that is a recommendation. You don't use AZT, high risk to develop a toxicity. And if they develop a resistance to DTG, which is very rare, if they have mutations, you can change them to darunavir 800-100 and also recycle tenofovir 3DC, based on this DEF study. So again, we have moved atazanavir and lopinavir to alternate regimen because of weaker PI and as well as more and more risk to toxicities. So this is something, a new guidance. I think programs has not started implementing. They start implementing one by one. Private doctors have already started doing, do it very well. And third line, we don't have any recommendations major. Same thing was being repeated. Use resistant testing wherever possible, and based on the available drugs, use it. Then we may plug in doravirine somewhere, since the drug is recently launched from the generic market. Hopefully, might be the next guidelines can have something on that based on the data. So based on these current WHO guidelines, there is a modeling group in Harvard have done that. What they did is, based on the viral load suppression across the globe in lower and middle income country and the research settings, what they did is they did a life expectancy score, and they found that today, if someone who have got access to antiretroviral drug, if they're following WHO recommended guideline, if they have a suppressed viral load and good CD4, their life expectancy will be similar to people who don't have HIV. So this is something already proved not only for the US and Europe, but also for lower and middle income countries. So again, that will be possible only if the patients have a suppressed viral load continuously. That should be ideal response. But on the other hand, if they keep missing pills, they are not going to obtain that life expectancy. There could be transmission also. To take care of this, now we have got this long-acting drug, which has already been approved for use, called Cabenuva, which is a long-acting injectable of cabotegravir and rilpivirine. Cabotegravir is a long half-life up to 2 to 3 months. Again, rilpivirine up to, which is a second generation NNRTA, 2 to 3 months. There are many studies in the past have shown the combination of cabotegravir and rilpivirine. I may take 2 minutes to wind it up. It's an important recommendation. So where this combination of these two, if you give every 2 months in a suppressed populations, will work very well. So following these studies, the US DHSS guideline and European guidelines 2 years back, they recommended this particular regimen, particularly in people who got suppressed viral load, and also they should be virus susceptible to both to cabotegravir and rilpivirine. They have to do a genotyping. And again, we all know that we had used a lot of NNRTA, nevirapine and efavirenz. So we thought there could be a risk because of rilpivirine use, which is an NNRTA. We didn't know the answer, so we wanted to have a little more data before we make a recommendation for resource-limited settings. So at that time, there is a study happened in Sub-Saharan Africa called CARE study, again, well-done study, which again, patients who had previously even failed NNRTA, but after that, they had got suppressed viral load with other regimens. They randomized into 2 groups. One group, they continued the same oral therapy. Another one group, they changed them to every 2 months of cabotegravir and rilpivirine. And also, they stored specimens from baseline. They did some analysis on their ARCAD mutations, and they found that irrespective of any resistance mutations present at baseline, so this particular regimen of cabotegravir and rilpivirine is been comparable as compared to oral therapy. So following this, now WHO also been recommended someone who got a suppressed viral load. If you got access to cabotegravir and ripivirine, please use it. But unfortunately, we don't have this right now. But there are many Indian companies who have been working on that. Hopefully, we'll have this product. So once it's available, you can safely use it. So this is something, a new recommendation from WHO for lower and middle income countries on long-acting injectable for treatment, especially people who got a suppressed viral load. This is the only recommendation? No. There are a lot of new drugs in pipeline, which you hear from other speakers soon, might be from the next speaker. Again, among them, lenacapavir is getting advanced, where you all know that it can be given every 6 months as a subcutaneous injection for prevention. But there are good data also showing if you give for treatment also will work. But unfortunately, we don't have a partner for this. It's given every 6 months, other injectable every 2 months. Hence, this recommendation is not done for treatment at this time in the WHO guideline. But we will wait for more and more data, which will be the best partner drug once every 6 months to be given. Again, we had some new data from CROI, which will be again presented by my next speaker, Dr. Babu soon. So and then we can wait for it. I'm going to wind my talk stating that the new WHO guideline also browsed something on non-communicable diseases, which earlier we never had this. What are those interventions? As many of you know that HIV causes more inflammation, causing all those age-old disease. And also many co-infections like TB and opportunistic infection can cause. And also microbial translocation and obesity causing by integrase inhibitors can cause. And also some of the particular antiretroviral drugs, especially protease inhibitors, can also cause cardiovascular disease and predisposition to diabetes. Here, now there are different groups working on how we can prevent some of those non-communicable diseases. One of the things which you got some answer is on cardiovascular disease. There is a very large trial, which I just wanted to spend 30 seconds on this because I was involved in this clinical trial, which happened in Chennai, where Indian site recruited 500 patients out of the 7,000 global trial patients. What we did is patient who got suppressed viral load, who got no previous cardiovascular disease, normal lipid profile, we randomized into 2 groups. One group received pitavastatin, another group placebo, along with antiretroviral drugs. This was followed for 7 years, and the trial showed 35% reduction in any major adverse cardiovascular events, and also 21% reduction in death due to any cardiovascular disease as compared to placebo, which is a major finding, which no ever clinical trial has ever shown this type of results, particularly in preventing a cardiovascular disease. These are people who are HIV positive, suppressed viral load, no previous cardiovascular disease, not hypertensive, and as well as no abnormal lipid profile. So following this, the US DHSS guideline, British guidelines, and European guideline recommended anyone who is HIV positive, more than 40 years, irrespective of the lipid profile, a statin is recommended. What statin? We use pitavastatin for trial, but since it's not widely available and very expensive, so we also recommend atorvastatin and as well as rovastatin for this. For the WHO guidelines, still under discussion, not because of science, because of availability and the cost and a lot of other things. But on the other hand, for India, since we have got a high risk to develop cardiovascular things, I think I strongly recommend you clinicians start using statins on your patients as a prophylaxis to prevent cardiovascular diseases. And also there is a touch upon those lifestyle modifications. You all know that about integrase inhibitors. So start doing this on your patients. While you're prescribing the drugs, start walking about the food, exercise. This will prevent frailty, obesity, and so many other things. I'm going to end stating that the WHO guidelines will stress a lot on U is equal to U. I think that is very important. We have to use this to counsel our patients. So this is again not part of the WHO guidelines. My personal conclusion for you all, HIV persists throughout despite antiretroviral therapy. So we have to make sure that they continuously adhere to the drug. All our patients will read everywhere in the social media and ask about this cure of 10 patients following stem cell. Please tell them this method is not scalable. It's very, very important. They keep asking everyone. Also, following the next presentation, you'll see this. We got some good data coming up about promising cure. Your patients will ask you soon, anytime soon. So where we have to make sure that currently it is not available, it's a work in progress. And also what we have is make sure that everyone should be functionally cured by suppressing to undetectable viral load. And very importantly, as a clinician, give a lot of importance to prevent resistance, improve adherence, and as well as prevent non-communicable diseases. Thank you so much. I know I took a lot of time. Thank you.
Thank you. Thank you, Dr. Kumarasamy. Very elegantly presented. You have chronicled the whole story about the triple therapy and now to dual therapy. Now in 2026, endorsing WHO's point of viewpoints into our practice, certainly there is a We have had extensive discussions yesterday, a debate, etc. But from an internal medicine point of view, first time, so you asked this question yesterday, what is the prevalence of tubular acido RTA amongst patients who receive tenofovir? You got the answer, prevalence is 5.1%, which translates, and you also presented in about 1.7 per 1,000 patient years. Okay, that's also a significant number. Now, please remember, we physicians are very poor at monitoring preventive prevention. We don't monitor. There is no test in the world that will tell you that my kidney is failing until my creatinine, 75% of my kidney is damaged when my creatinine creeps up from 1.4 to 1.5. Secondly, nobody does renal tubular testing. Who measures urinary phosphate excretion? Who measures fructosuria? Who measures the uricosuriya? Nobody does it. So you get the renal tubular damage. Then you've also got proteinuria, which suggests it is a glomerular damage. Brother, using a tenofovir regimen, when you have got other alternatives, I wouldn't subject my patients to prolonged hurting the kidneys for 25 years. So it is time, but I do not know if two drugs is the answer, but WHO has given a guideline on that. Perhaps the combination, you will have to use it in steep plus emtricitabine or 5-3-TC. That's a different story. Secondly, you have shown, honestly, I don't have the confidence of these long-acting injectables simply because I don't have the experience. I might consider somebody who is poorly adherent to go in for this long-acting. I don't know the cost of it. The third part of it is the WHO has also given guidelines on infant transmission. What are the drugs, 3 triple drug regimen that you would give for the infant for the first 6 months, first 6 weeks postnatally? I don't know the answer. It's a triple drug. We are giving only 2 drugs. That's also in the ART guidelines. The WHO ART guidelines also prepares us for receiving the TB vaccine, which you listened to yesterday, which is promising. I still don't know, I don't have the confidence of using this 3-month, once weekly rifampicin and INH for a period of 3 months. Has anybody used it here? Do we need to do that? Where are we going to get the courage of our conviction to do that? Yeah, yeah. One thing is rifampicin. Yeah, yesterday when we spoke to Dr. Hamid, he said I will bring rifampicin in the previous conference. Yesterday you had a very nice discussion. First time I'm seeing, thanks to the organizers, I interact with the industry. I like the presentation from industry saying how much money we have invested. It's not that I'm promoting the instas, but they are also working hand in glove with us physicians to change our practice. So anyway, thank you for the update. Whatever you're doing, NACO may not follow the update as of now, but time will come when they will have to follow when you see more patients with ART lining up for renal transplantation. So I would probably want to, say that we should follow some of the WHO guidelines. Remember, when textbooks are published, it's 4 years late. When you've got a conference like this, maybe you're 6 months late. So you have to make a call on how you want to change your practice. And changing practice takes a lot of courage. Okay, so thank you, Dr. Kumarasamy, for making your presentation. Really appreciate that.
We invite the next. to invite Dr.
Hello, great
Kamal
delight to be with you virtually.
to
My name is
explain the
Tristan
update-
Barber,
yeah,
and
the
this
update from
presentation.
Troy.
Hello, great delight to be with you virtually. My name is Tristan Barber, and this presentation is entitled Antiretroviral Therapy Updates from CROI 2026, What Should Change in Practice? I just wanted to share this photo of when I was in Mumbai last year and say that I'm very sad not to be there with you in person this year, but I hope to join you on a future occasion. These are my disclosures with regard to this talk. So in terms of an overview, I'm going to speak first of all about existing long-acting antiretroviral therapy and then present some of the novel antiretroviral therapy data that was presented at the recent CROI conference in Denver. In terms of affecting practice, I think it's very difficult for any of us to see how some of these novel treatments yet will affect our practice, mainly because, of course, access to novel agents remains very variable globally, including in the UK. And of course, in India, you will have access to different antiretroviral therapy treatments. But I still think it's exciting to think about what the future options might be for our patients. In terms of injectable therapy, we've seen a license for injectable cabotegravir and rilpivirine for people who've achieved viral suppression on oral antiretroviral treatment. But we know that there are limitations not only to daily oral treatment, but also to existing intramuscular injectable therapy as well. In terms of daily oral antiretroviral therapy, we know some of the limitations include adherence challenges, issues around stigma and privacy, side effects and tolerability, complexity of regimens, the potential for drug-drug interactions, dosing challenges in those with abnormal renal function, and issues around polypharmacy. And long-acting therapies can overcome these challenges by improving adherence and persistence, reducing stigma, simplifying and making regimens more convenient, bypassing gastrointestinal-related drug-drug interactions, and overcoming problems with renal insufficiency as well. With regard to injectable cabotegravir and rilpivirine themselves, we obviously would like the opportunity to be able to treat people who struggle with oral adherence and have detectable virus. Now, although we're acquiring data in real-world cohorts for the use of injectable therapy in those with viremia, we also have studies that support the use of injectable treatment in areas where monitoring is limited or reduced. The CARES study, which was presented last year, is a study that looked at the use of cabotegravir and rilpivirine in 3 African country settings with limited access to monitoring and showed really good results in terms of virological outcomes here in blue compared to standard oral antiretroviral therapy. We also have the Latitude study that was performed in the US. This was a group of people who struggled with oral adherence, who often had quite chaotic lifestyles with lots of drug use and struggled to engage with healthcare. They were incentivized to be in the study, but nonetheless, on injectable treatment, showed really good outcomes compared to standard oral treatment. We also see a push to have innovative combinations that often are combinations that drug companies will not collaborate to do studies on. And there are data sets looking at the use of lenacapavir with infused intravenous ibalizumab. This is really only available in the USA, but also studies looking at the use of lenacapavir with cabotegravir and with or without the inclusion of rilpivirine. And often the use of these combinations in people with viremia and resistant virus can be very useful to achieve viral suppression. This is a study from Atlanta, again presented in 2025 at CROI in San Francisco, showing the impact of long-acting antiretroviral therapy in a group of people who started with viremia. Now, it's quite small, but of these, 361 people were included, and 81 of those had detectable viral load at baseline. This is 22%. Nearly 70% got cabotegravir and rilpivirine alone, 28% had the addition of lenacapavir, and a small proportion had the addition of ibalizumab. And I just wanted to show that in this group, a large percentage were black, almost all of them, in fact, 93%. A lot had very advanced HIV with an opportunistic infection, and many had socioeconomic issues. But despite all of this, 73 out of the 79 of those who started with viremia achieved an undetectable viral load after a median of just one round of injectable treatment. So we see here that in this group that had difficult to treat virus, the use of injectables in a pragmatic way is very helpful in terms of achieving viral suppression. We now have a study, the CROWN study, which is fully enrolled for adult participants that is looking at the utility of cabotegravir and rilpivirine alone in viremic individuals for whom their oral therapy is failing. And this will definitively answer the question about whether we can safely use injectable cabotegravir and rilpivirine in people with detectable viremia. What's really important, I think, is that if we restrict the use of injectable agents, only a very privileged proportion of people are going to benefit from them. But if we use them in a pragmatic way for people who struggle with oral treatment, I think they can really help us achieve the UNAIDS goals of ending new HIV transmissions and achieving better viral suppression in people with HIV by 2030. And we see here a number of people who may benefit from the use of injectable treatment in this way, including people who are diagnosed but not linked to care, people who are linked to care but not retained in care, people who struggle with oral treatment, and people who are not on optimal oral antiretroviral therapy. So I think the wider use of injectable treatment, when available, will really help more people with HIV to achieve an undetectable HIV viral load. On to some novel treatments. This is all data that was presented in Denver at the CROI conference very recently. This is the 60-41 study. This is a study in people who were already suppressed, who were randomized to either continue on Biktarvy or to switch to oral lenacapavir and islatravir once a week. The outcomes at week 96, this is extended data. The 48-week data had already been presented here by Amy Colson. You can see that at week 96, no patients on therapy had a viral load greater than 50 copies, and no emergent resistance to islatravir or lenacapavir was detected in either group. Adherence was very good, and the safety of the investigational regimen was very good, with no treatment-related grade 3, grade 4, or serious adverse events. Importantly, because of the safety signal that had been seen previously with islatravir resulting in a reduction in total lymphocyte counts, CD4 and absolute lymphocyte count changes did not show any clinically significant changes in this study. You can see the virologic outcomes are really good. So in the blue bar here, you can see the virologic outcomes on the islatravir lenacapavir weekly arm. And in the sort of browny beige color, you can see the outcomes in the group that were on Biktarvy initially and switched to islatravir lenacapavir at week 96. So overall, very good virologic outcomes, and phase 3 studies are underway investigating this combination. We also saw a switch study to daily doravirine islatravir. There were 2 studies presented, one by Amy Colson and one by Chloe Orkin. This is a switch to daily doravirine and islatravir. You can see the 2 studies described here. In the 052 study, people were randomized either to switch to the investigational regimen or to continue on oral Biktarvy. And in the 51 study, people were on a range of regimens at baseline. They were randomized to either switch to doravirine islatravir or to continue their baseline combination and switch at week 48. In the 52 study, you see that high rates of virologic suppression were maintained in both treatment arms. Now, there was one incidence of treatment-emergent resistance to doravirine and islatravir, but in the Biktarvy arm, there was no emergent resistance seen. Overall, doravirine islatravir was well tolerated, and the safety was comparable to Biktarvy. And there were no between-group differences in mean change in CD4 or total lymphocyte counts. And you can see really good rates again of viral suppression in both these arms that are comparable. In the 51 study, again, you see these really high rates of virologic suppression maintained in both treatment arms, no treatment emergent resistance to doravirine or islatravir, and again, switching to doravirine islatravir had no adverse effects on total lymphocytes or CD4 cell count. Doravirine islatravir maintained a favorable safety and tolerability profile. One of the things that's come up in these studies is the importance of making sure that people are vaccinated against hepatitis B before they enter a study with a two-drug combination that doesn't offer any hepatitis B protection. So I think that's a very important safety point to remember. Doravirine islatravir also went head-to-head with Biktarvy in a group of treatment-naive individuals. This is data presented by Jürgen Rockstro. I think it was very brave, actually, of the manufacturers of doravirine islatravir to go head-to-head with Biktarvy, which we know is an extremely potent and effective treatment for HIV. This was a double-blind, non-inferiority trial in treatment-naive individuals who had to have an HIV viral load of greater than 500 copies, had to not be living with hepatitis B co-infection, and had to have no documented resistance to the drugs that were used in the study. They were stratified according to CD4 count and HIV viral load at baseline, CD4 count either above or below 200, and an HIV viral load either below or above 100,000 copies per mil. In this study, you can see the outcomes here at week 48. So the virologic efficacy was very good. Doravirine islatravir daily was shown to be non-inferior to Biktarvy, also dosed daily. And similar results were seen by the stratified CD4 and HIV viral load groups. 4 people discontinued due to a lack of efficacy in the doravirine islatravir arm, and 2 of these did show treatment emergent resistance. In the Biktarvy arm, just 2 people discontinued due to a lack of efficacy. Reassuringly, the CD4 and total lymphocyte changes showed no difference between the 2 treatment groups. And both treatments were overall well tolerated. Interestingly, the weight gain was similar in both arms, and this has led to a lot of discussion around our previous hypothesis that the combination of tenofovir alafenamide with a second-generation integrase like bictegravir is responsible for excess weight gain. I think people were hoping that in the doravirine islatravir arm in this naive group of individuals we would see lower weight gain, but that was not the case. Chloe Orkin also presented data from the Artistry-1 study. This is a study looking at people that were on very complex regimens at baseline. The median age in this study was 60 years, and people had a number of comorbidities and also had a lot of polypharmacy. 77% at baseline were on a protease inhibitor-based regimen. So these were a group of people that had been living with HIV for a long time and were receiving complex regimens. And they were randomized in a 2-to-1 fashion to either receive bictegravir lenacapavir, 1 pill once a day, or to continue on their baseline regimen. There were really good virologic outcomes in the Artistry-1 study. The switch to bictegravir lenacapavir was shown to be non-inferior to continuing your stable baseline regimen, and no treatment emergent resistance was detected. CD4 counts remained stable after switch, and bictegravir lenacapavir was well tolerated. There were more drug-related adverse events in the bictegravir lenacapavir arm, but of course you would expect this in a study where a randomized arm included people staying on their existing antiretroviral regimen, and in the other arm people were switching to investigational drugs. But the discontinuation due to adverse events was at a very low rate, so just 2% in the bictegravir lenacapavir arm versus 1% in the stable baseline regimen arm. In the interest of time, I haven't gone into this study in more detail, but I think this does offer a convenient, non-boosted, non-protease inhibitor regimen for people who currently are on very complex antiretroviral therapy. And of course, that can have metabolic benefits as well as avoiding the potential for drug-drug interactions. In the Artistry-2 study, this was a group of people who were stable on Biktarvy, and they were randomized to either switch to bictegravir and lenacapavir or to continue on Biktarvy 1 tablet once a day. The results were very good, showing that the switch to bictegravir-lenacapavir was non-inferior to continuing Biktarvy. No treatment emergent resistance was detected, and CD4 counts remained stable after switch. In terms of safety, bictegravir-lenacapavir was well tolerated, and there were 2% discontinuations in each of the groups in this study. Moving on to something a bit newer, we see here data from the EMBRACE study. This is a switch to a broadly neutralizing antibody, formerly known as N6LS, now known as lotivibart, with cabotegravir and hyaluronidase to extend the PK of this treatment. People had to be stable on antiretroviral therapy for at least 6 months with an undetectable HIV viral load. They had to have had no prior antiretroviral switch due to a virologic failure, and they had to have a phenotypic test to demonstrate sensitivity to lotivibart. They had to have a CD4 count of greater than 350 cells, and they had to have no active hepatitis B co-infection. You can see the arms here that they were randomized to, either to receive lotivibart intravenously or to receive it subcutaneously, both dosed at 4 monthly, or to continue their oral standard of care. Now, these were the outcomes. Lotivibart demonstrated good viral suppression in a high proportion of adults with baseline sensitivity to the agent, and it was generally well tolerated when given as an IV infusion with no adverse events leading to withdrawal. There were no serious or severe immune reactions, but injection site reactions were much more common with the subcutaneous versus the IV administration route. All patients receiving lotivibart via either route of administration reported low pain scores and high tolerability. But overall, it's been deemed that the intravenous route is the one that's worthy of further investigation. Just to conclude, these are some of the other drugs that were presented at the CROI conference. From Gilead Sciences, we see GS3242, which is an integrase inhibitor comparable to others given once a day orally in terms of activity. There's the potential for this to be given as a long-acting intramuscular injection every 4 months, but they're hoping to extend it to 6 months, possibly to pair with lenacapavir as a twice-a-year injectable antiretroviral therapy regimen. And phase 2 studies on this agent will begin later this year. From ViiV, there's VH184, which is a long-acting capsid inhibitor. And again, this is being explored as a long-acting treatment, as an injectable therapy. And the phase 2b study looking at this as initial antiretroviral therapy will begin later this year. Also from ViiV, VH499, this is a so-called third-generation integrase inhibitor, again able to be given intramuscularly and subcutaneously, both routes being well tolerated. And again, there's the potential for this to be given twice a year. So I really do think we are looking to the future and seeing the possibility of twice yearly injectable 2-drug regimens for HIV infection. Finally, Gilead also presented extended data on their combination of lenacapavir with 2 antibodies, TAB and ZAB, showing that people could interrupt antiretroviral therapy safely after a one-off injection of these agents. And this combination is also going to be further explored in further clinical trials. So in summary, I think we do now have injectables that can be game changers for both pre-exposure prophylaxis and for treatment of chronic HIV infection. But of course, they can only be game changers if they're available in the right place and for the right people. And I would add, of course, at the right cost. We have daily 2-drug combinations that are novel, and islatravir is now looking safe at the revised 0.25 milligram dose without the impact on total lymphocytes or CD4 counts that led to the previous discontinuation of the studies that were looking at the higher dose of 0.75 milligrams once a day. We also have a novel combination, bictegravir-lenacapavir, that can be used in people who are on complex regimens, and we have extended safety data on a weekly 2-drug combination in terms of islatravir-lenacapavir now being explored in phase 3 studies, the Island 1 and 2 studies. In terms of broadly neutralizing antibodies, I think these are starting to look more exciting and less experimental, But again, we have to bear in mind the sensitivity tests that are required, and again, the cost and the ease for people to access these drugs globally. But I think what is reassuring is that the antiretroviral pipeline remains strong, and I think we have a positive future ahead to build on the experience we've had so far of oral antiretroviral therapy and to be able to offer people innovative treatments in the future. Of course, as I've mentioned, these need to be accessible globally, and we have to keep fighting and advocating for access to these drugs for those who need them most. We do not have access to lenacapavir for treatment currently in England, and we have a number of people who have highly resistant virus who would benefit from access to this drug. So we continue to campaign for access to new drugs that can benefit those most at need. I just wanted to highlight the journal that I'm editor-in-chief for. I'd be delighted to receive any of your publications, any of your manuscripts to be considered for publication in HIV research and clinical practice. And you can always get in touch with me via any of my contact details here. Thank you very much indeed for your attention, and I look forward to taking.
Thank you. Thank you very much, Dr. Tristan Baba. Thank you. You have highlighted the recent publications in the CROI 2026 on these long-acting agents, long-acting cabotegravir plus investigational third-generation entities. I don't know when it would come to practice in my country, because injection-based ART, we will have a lot of problems on, let's say, scheduling and retention systems. What do we do for missed doses? How do we counsel them for injection sites? Impact on adherence? All these would become problems, but I agree with you, it fulfills a need. Let's say a need or a gap that you have identified in trying to reach the goal of 2030. Now, thank you so much, and we look forward to these publications. Now, when we review thesis, we don't accept abstracts as reference, simply because we do not know whether these abstracts will translate itself into full-fledged paper presentation. You need a full paper presentation in order for it to be peer-reviewed and in order for practitioners to comment, and then it comes into practice. It would probably take another, I don't know, 2 years before they come into practice. Really, maybe in India a little longer, 3 years, because there would be many other questions that are asked. So thank you very much, and we hope to see these studies come into full paper presentation in your journal that you are promoting. Thank you very much for your presentation. Thank you.
We invite the next speaker.
Suswagatam, welcome Dr. Gwyn Stevens to ASICON 2026, Mumbai. Representing Cepheid in South Africa, he plays a pivotal role in advancing rapid molecular diagnostics and integrating point.
Good morning, everybody. And it's a pleasure to be here amongst this really accomplished audience. And a big thank you to the ASICON conference organizers for this opportunity. Today, I'll focus on how rapid near-patient molecular diagnostics can strengthen a response to the HIV epidemic, particularly in India. As we've all heard over the last couple of days, India has made major progress, but the epidemic is still evolving. We're identifying new hotspots, late diagnosis, and persistent gaps still plague our response today, not only here in India, but in my home country, South Africa, as well. Throughout this talk, I'll link diagnostics directly to clinical action, program performance, and real-world impact across the spectrum of both diagnosis and viral load monitoring. I will cover a couple of topics, including a brief introduction to India's HIV landscape, the current gaps we see in scaling up viral load, why timely diagnosis still matters, a look at the global trends around HIV viral load monitoring, and very importantly, looking at some of the evidence that exists for the impact that we see if we are able to decentralize diagnostics like HIV viral load. And then I'll touch on what Cepheide's solution looks like, which is the Expert HIV-1 viral load XC product, and make some concluding statements. So let's start briefly with a look. Now, I don't have to tell this particular audience about the HIV landscape, but while national prevalence remains low, as we've heard, the epidemic is heterogeneous. The important geographic and population-specific differences across India, and this means that our national averages can sometimes hide critical gaps around early diagnosis, access to viral load testing, and timely linkage to care. It's understanding the context that is essential in identifying where diagnostics can actually add value. So India was the first country, actually, along with South Africa, to develop operational guidelines for ART services as early as 2007, with the aim of ensuring a minimum standard for quality of care for people infected with HIV. These were updated again in 2013 to accommodate this programmatic changes and the huge upscale of treating people living with HIV. Many countries have followed suit and developed guidelines and operational plans based on what was done in India. And as we've seen, ART services have undergone an enormous scale-up across the country. If we have a look at the figures on the right-hand side of the slide, India's progress to 95, 95, 95 has been significant. However, although that indicates strong progress, particularly on treatment and viral suppression, it also highlights the remaining gaps, especially for the first 95 around diagnosing HIV, and of course, in the last 95, which is all about scaling viral load testing to support sustained suppression. So, NACP Phase 5, as we've heard about yesterday, really defines India's HIV direction through until the end of 2026. It is entirely funded by the government of India, which makes it unique and reflects a really strong domestic commitment to ending HIV as a public health threat. The program has very lofty goals and aims for an 80% reduction in new infections and in deaths. It aims to eliminate vertical transmission from mother to child, and of course, the achievement of the 95, 95, 95 cascade goals. What it emphasizes here is universal screening in pregnancy, rapid ART initiation, and routine viral load monitoring, really as the core of treatment success. But perhaps most importantly, a recent national assessment shows that India's epidemic is changing. We have new hotspots, rising incidence which is linked directly to injecting drug use, and we heard a lot about the digital dating scene in yesterday's presentation as well. It's really shifting transmission outside of traditional key populations, and we have to be aware of this. And this makes the strategic priorities of NACP 5 more relevant than ever. Timely diagnosis, continuous treatment, and viral suppression really as the foundation of epidemic control. So the next section is really a little bit about scaling up of HIV viral load and what are our current gaps. This slide reflects what clinicians are facing daily in ART clinics in India. It was recently published, and what it showed was that clinicians face a number of challenges, including limited access to routine viral load testing, which means virological failure is often detected late. And without timely viral load results, clinicians are forced to rely on clinical or immunological signs and symptoms, which really makes it hard for a clinician to distinguish between true non-adherence or treatment failure as a result of drug resistance. Centralized referral testing, complex logistics, and really long turnaround delays decisions that the clinician can make, especially when it comes to switching to second-line ART. And what are the results that are delayed? They in turn delay the action that the clinician can take. It increases the risk of resistance and increases patients being lost to follow-up, particularly in the public sector. The real issue here isn't really whether viral load testing works. It's whether results come back fast enough for us to act in time. So why does timely diagnosis still matter? Time to diagnosis is not just a technical metric. It directly determines outcomes. You've heard in this morning's presentations how important, how critically important viral load monitoring is. Delays increase the risk, we've heard, of onward transmission, disease progression, and loss to follow-up even before treatment initiation. And this is particularly and becomes even more important during acute infection and in decentralized settings where turnaround times can be long. And according to the publications that I reviewed a couple of slides back, this is the reality on the ground. The goal is not to simply test. The goal is to have actionable results that enable same-day clinical outcomes. So why is time to diagnosis still important? Well, we know the cornerstone of the global AIDS control effort really is around universal test and treat. Our strategy is to identify people early on, as we heard, the earlier the better, and to promptly initiate our ART and to achieve sustainable viral load suppression. Diagnostics continue to be at the heart of epidemic control and patient management. I need not remind you how important, if you have a look on the right-hand side of the slide there, how important it is to ensure that we're using the right diagnostic at the right time. If we're considering intervening really early and monitoring people for acute HIV infection, then molecular diagnostics is a suitable diagnostic technology to use. Early diagnosis plus timely treatment is equal to epidemic control and better outcomes. Diagnostics matter, but only when results drive action. We all understand and are well into the third decade of HIV viral load being the key and the tool to achieving lifelong suppression. India's viral load monitoring system is now nationally scaled and very widely accessible. A nationwide high-quality viral load laboratory network has been expanded, as you've heard, to support routine viral load monitoring across numerous ART centers. And as you saw on the 95, 95, 95 cascade goals, India has really achieved very high viral load testing coverage. However, the value of a viral load is not just its measurement. It's enabling timely clinical action, adherence support, repeat viral loads, and regimen changes as per the policy. Of course, these are backed up by the WHO and other guidelines like the European AIDS Clinical Society. We all know that viral load remains the preferred method of ensuring our patients are well managed and receive timely support. This slide shows the WHO treatment monitoring algorithm and how viral load results drive clinical action. When a viral load is suppressed, patients can continue on current therapy and move into differentiated care models, which really are extremely important when it comes to closing those gaps we see. Going the sort of last mile, we need to be innovative and we need to have differentiated service delivery mechanisms. Of course, when a viral load is elevated, the response has to be rapid, starting with adherence support and followed by repeat viral load within a defined time frame. If an elevated viral load persists, this signals treatment failure and the need for regimen change. But these have to be done in good time. Near patient or on-demand viral load testing has shown to strengthen this pathway by shortening turnaround times and reducing missed follow-up visits, or even the number of patient visits, which really enables same-day or rapid clinical decisions. The WHO went as far as to recommend the use of point-of-care viral load in terms of monitoring treatment, and they call out particularly high-risk key populations who would benefit from this, including pregnant and breastfeeding women, infants and children, people requiring a repeat viral load, and people for whom treatment failure is suspected. And of course, people who present sick. So there's this clear return on investment if we ensure that we are investing and using diagnostics in particular population groups who are in need. So let's have a look at some of the evidence of the impact that decentralizing HIV viral load testing has shown. To begin with, though, I just want to call out a study that was done early in 2017 here in India, looking at the performance of the Gene Expert HIV viral load 1 quant assay. And it was shown to be really comparable to big centralized PCR testing systems. In this case, it was the Abbott M2000. And the paper concluded to say it really, the use of this expert technology would support the scale-up of decentralized viral load testing in India. This slide highlights a very practical opportunity. It was a commentary that was published in The Lancet by Madhu Pai's group, and it provides a practical opportunity for HIV care in India. India has already this very large number of gene expert systems that were deployed for TB, more than 3,000. But for many years, viral load testing continues to be centralized and in some cases very slow. This 2017, so a number of years ago, analysis showed that the gene expert platforms were actually underutilized and they could be leveraged for HIV viral load testing without building any new labs. For clinicians, of course, the relevance is simple. Decentralized viral load testing means we could get faster results, we have fewer patient visits, and we can make quicker clinical decisions. So access, however, in India to viral load testing still remains limited due to a heavy reliance on centralized testing. Challenges with sample transport, cold chain, and turnaround time really results in this missed opportunity. And we should take note that this could or presents itself as an opportunity without any further increased investment in technology or instruments. Of course, the slide highlights a very this NACO-funded study, right, evaluates whether HIV viral load testing in India can be decentralized using the Gene Expert platform, and it's currently underway. And we feel that once the results from this very important pivotal study are available, they will provide key indications for policy informing decentralized HIV viral load testing. So what is the, and that, sorry, I'll go back, but there have been a number of studies showing the impact that decentralizing viral load testing can have. So what does our solution look like quickly in the last 2 minutes? Cepheid has a product that we call the Expert HIV-1 Viral Load XC assay. It is a dual target RT-PCR assay which quantitates HIV viral load in plasma. It has a dual target, both the LTR and POL regions of the HIV genome, And it is a very simple workflow and uses a mil of plasma to get a result in around 90 minutes. All right, it has been proven to be comparable to any of the large centralized testing platforms. This list was a comparator looking at Abbott Alinity, showing very good sensitivity and specificity of the assay. Extremely simplified workflow. It's really sample to cartridge and a viral load result within 90 minutes. And we saw in a number of studies in South Africa that task shifting to nurses and, non-laboratory healthcare workers was very feasible. As you've seen with the TB program and the Gene Expert can be used across numerous different tiers of the healthcare system, including hospital laboratories and community health centers or public health facilities. On-demand testing, simple workflow, and fast results is what improves viral load monitoring services. So, in conclusion, the current challenge we face, not only in India, but in a number of low middle income countries, including South Africa, is that centralized viral load testing leads to delays in results, limiting timely clinical decisions on ART. What is the clinical impact of this? We know without rapid viral load results, clinicians can struggle to distinguish non-adherence from treatment failure, really delaying optimization of care. What is the clear opportunity we are faced with here, particularly in India, is the fact that we have this existing diagnostic infrastructure, and this can really support decentralizing viral load testing closer to ART centers. And we know, and we've heard numerous times this morning already, that earlier viral load results enable faster adherence support, timely regimen changes, and sustained viral suppression, which is the end goal for all of us. So bringing viral load testing closer to patients enables faster decisions, better ART management, and improved long-term outcomes for people living with HIV. Thank you.
Thank you, Dr. Stevens, for your presentation. Now, I was just wondering, it will work well perhaps in the ART centers because you need faster results and optimization of care. Patients are also wanting to know that whether they've done a good job and adhering to the medicines, etc. Even in practice, we find that same-day results given to the patient for any disease, blood pressure, diabetes, chronic renal failure, much better outcome. They don't have to wait for 3 days to get the report. I might find this useful in preventing mother-to-child transmission because I would like the mother to be totally suppressed, and this may give me the result in half an hour, 1 hour, and I might prevent it. I might use it for that. Now, whether the government programs would use it, I'm afraid that it may be expensive. We have 23 million deliveries in my country, and we do not know how many of them are really coming up for institutional follow-up and things like that. Anyway, I'm not getting into cost as economic factors. I don't look into it at the moment because that is something that can be, managed in several different ways. Thank you. And Cepheid is a household name for us because we use it a lot for AMR detection, bacterial sepsis and AMR detection. Of course, TB is your main bread and butter. HIV would also be, but mainly it is on even HCV, and yesterday you had a presentation on HPV and other STIs as such. So there is a good,
all about integrated care.
Thank you very much.
Thank you.
You explained the need of the viral load and point of care tests. Of course, cost also important in India. Thank you very much for giving us this opportunity, Dr. Gilada and Dr. Tupti Gilada. for giving me this opportunity.
Thank you very much. We'd like to call upon our chairpersons to commemorate our speakers. Starting with Dr. N. Kumarswamy. Dr. Gwen Stevens. We'd like to call upon Dr. Gilada to please commemorate our chairpersons for this session. We will now be starting with our next session, the debate. So we'll be starting with our debate right now. The topic is long-acting ART, promise and pitfalls. Our moderators for today's debate are Dr. Meka Satyanarayan from Hyderabad and Dr. Niranjan Rathod from Kolhapur.
Dr. Pooja Shah and Dr. M.V.S. Subbalakshmi will present the pros of the motion, while Dr. Ashwini Taide and Dr. Atul Jogia will present the cons.
We now hand over the session to our moderators.
Good morning. Welcome to the debate session on long-acting ART, promises and pitfalls. Format of the debate, 2 speakers on pro side, 2 speakers on con side. The total duration of debate is about 30 minutes. Each speaker will be given 4 minutes for evidence-based arguments in the initial round. Second round is for rebuttals. Each speaker will be given 2 minutes. Last 5 minutes are for the discussions and answers to the audience questions. So antiretroviral therapy has been evolved from multiple toxic drugs with pill burden to single tablet, fixed dose, once a day combinations. Today, we stand for another turning point, the era of long-acting injectable ARVs like Cobatagravir and Rilpivirine given as intramuscular injections once in a month or bi-monthly, especially in virologically suppressed patients. Now the question is whether this shift to long-acting ARVs
are really a game changer, making a paradigm shift to the future HIV treatment, or we are introducing a new clinical or public health challenge with these injectable ARVs. Let us start the debate on this. Now, I invite the first speaker on pro side to proceed. Dr. Subbalakshmi, Professor of Medicine, Internal Medicine, NIMS Institute, NIMS, Hyderabad.
So, good morning, everyone. I am Dr. Pooja Shah. I am working as an assistant professor in infectious diseases at Tata Memorial Hospital. And without much further ado, I think I would like to dive straight into our discussion for today. And that is on the liberating concept of long-acting ART. And there are a number of reasons that I have labeled it as liberating. I would like to take you forward through the same. So as we all know, in 2016, the WHO set the global health strategy for HIV, setting the 90-90-90 target, saying that at least 90% of those who are suffering from HIV should ideally be diagnosed. At least 90% of those being diagnosed should be treated, and at least 90% of those being treated should be virally suppressed. And we have come a long way along this journey. But while we were making this journey, we also realized that we have made huge strides, but still every patient suffers the stress of taking a daily dose. That dose then serves as a daily reminder that he or she is suffering from an incurable disease. It also, with every dose, there is a risk of disease revelation and social stigma. And also there are long-term toxicities of the current drug classes. So that led to the evolution. First, we were at multiple tablets per day. We have now come down to a single pill for most patients. And now from a single pill, we are moving to long-acting and ART, a number of which are actually injectable options. So as you can see, there are a number of drug classes that are being studied: attachment inhibitors, capsid inhibitors, entry inhibitors, and also there are injectable formulations of already existing drug classes like the integrase stand transfer inhibitors, NRTIs and NNRTIs. Out of all these, I would like to focus mostly on cabotegravir and rilpivirine, primarily because that is actually the only FDA approved combination that can totally replace the current medication. A number of other options that are there, including lenacapavir, are as an add-on to a failing regimen, but this is one regimen that is so strong that it can replace the currently available standard of care or the best available therapy. Now, pharmacodynamics, I would not like to dwell much on it because we already know that it is an integrase stand transfer inhibitor and an NRTI combination. What is more impressive is the pharmacokinetics, and that is exactly why these are being able to use as long-acting regimens in the injectable formulation. So what is unique? It is that the oral cabotegravir, which has a half-life of 41 hours, gets prolonged to as much as 6 to 12 weeks in the injectable formulation. And rilpivirine, which has a half-life of 45 hours as the oral formulation, gets extended to as much as 13 to 28 weeks as an injectable formulation. And there are a number of opportunities that there is a less frequent dosing required. It avoids a pill fatigue. It has 100% bioavailability, less adverse effects, and less drug-drug interactions. But there are also a lot of challenges. And like our Indian team, I would like to focus on the challenges. And we now have solutions for each of these challenges also. I would like to take you all through the challenges and the available solutions for these challenges. So if we say that these are new drugs and there is not enough evidence, why should we use these drugs? No, there is now enough evidence. This is actually a meta-analysis of 6 studies which had close to 3,000 patients, and it proved that the safety as well as the efficacy of long-acting ART is as good as the currently available standard of care. Next is the concern that every time we take a long-acting agent, there is a need for more healthcare visits and expertise. That is also not the case. When there was a comparison between at-home versus in-clinic receipt of long-acting injectable, what they found is, so now there are options that we can receive these injectables even sitting at home. So the safety and the efficacy is similar, but the patient satisfaction is much, much higher. So these medications can be safely delivered at home as well. And this was a study conducted in 5 countries in the European Union. I'll just take a few seconds more. So this was a study conducted in 5 countries which had no previous experience with long-acting ART, and they checked whether any enhanced staff training is required for giving these long-acting injectables. It was found that any staff who is equipped in giving just subcutaneous or intramuscular injections can easily provide this. So no additional staff training is required. Adherence. So obviously for the reasons known to us, this has a much higher adherence compared to standard of care. And many would argue that in clinical trials, we can see adherence is better, but that does not translate into real world data. But now we have real world evidence showing that people on long acting ART are 4 times more likely to adhere to their regimen rather than those who are taking oral ART. Then there are some concerns about injection site reactions, but I would like to assure everyone that these are at best mild or moderate, and they can easily be managed with simple analgesics. And moreover, they decrease with time. So they can happen with the first doses, but often they decrease with time. And what about viremic patients? So initially, I agree that these agents have been studied in the virologically suppressed hosts, but now we are having increasing evidence. So this is a study where 14 of 561 patients in 14 cohorts, only 14, all of them were virologically active in the sense that they had an ongoing viremia, and still most of them were virologically suppressed when started on this regimen. Cost, yes, that is a concern. Currently, the loading dose comes at a cost of $5,000 and maintenance dose at a cost of $4,000. But I'm happy to share that there are voluntary licensing agreements with 3 generic companies, and the drug is expected to be available by 2027. We don't know the cost yet, but I'm sure that with time, as the patents wear off, it is going to be very manageable. And I would like to just highlight that we, along the HIV timeline, there are a number of cases where a lot of changes have happened. And every time there is a change, it feels very hard at first. It is messy in the middle, but I can assure you that this will be gorgeous in the end. So this is my argument as a pro for long-acting ART.
Yeah. I will call Dr. Ashwini to depends on one concept. One.
Good morning. Thank you, Gilada sir and Trupti, for giving me this opportunity. So, morning 2-3 sessions, we have heard a lot about long-acting ART. Is it really a game changer, or it's just a mirage? And exactly what are we dealing with? So if I look at my national program, we have a huge burden. We know almost 60,000 new patients we see, and out of which 50% mortality is still there. Though we have established this program very well, we have, with this program, what we as of now have, we have very good virological suppression, single once-a-day regime, very low cost, which is really important for programmatic point of view. And what I need for programmatic enrollment is this regime, which is TLD, which is once a day, high genetic barrier, durable, and low cost. And that's why I need agent 007. Do I have similar agent as of now? I don't think so. This is injectable. Sorry for this. This is injectable. It has very poor genetic barrier. Long-term data is still missing, and cost is exorbitantly high. So can I enroll it as a programmatic molecule? Probably not. We have evidence from FLAIR, ATLAS, and ATLAS-2 study, but then all of these are non-inferiority trial, and none of this during trial proven a superior efficacy. So why should we disturb a successful system? So FLAIR trial was done in a naive patient, ATLAS in those who it was given every 4 weeks, and in ATLAS-2 it was given every 8 weeks. So it definitely reduced the pill burden, but then failure was not uncommon. up to 1 to 2%. And if we keep it exponentially or over the years, probably it might add up to significant number. We really don't know it. It often leads to dual resistance, and which is significant because we are best in a country the program was running with an NRTI for more than 2 decades now. The risk factors are basically rilpivirine resistance. Do we have existing? Yes, we do have. High BMI, yes. India is a diabetic capital and second largest obesity capital in few years. And cost, and the important factor is large pharmacological tail. So long-acting ART is effective, but failure can compromise the program, and both of these molecules are prone for failures. Resistance mutations, like we know, integrase and NRTI, both are reported. And if I look at the existing resistance, what do we have? So if you look at this is from Varanasi actually. The NNRTI resistance is somewhere 10% more than that, and that's why we shifted to INSTI-based program. And this is AFMC data, which says rilpivirine existing resistance is nearly 10%. So are we really going to get a molecule which is prone for resistance and which is based on this data, if we start using it, we might have a turmoil situation. Infrastructure, definitely a problem. Putting a cold chain, it's a big issue. Injection clinics, are we heading for an epidemic of needle stick injuries? I really don't know. If I have to ask my staff to give benzathine, because we know syphilis is increasing, so it is difficult for them to give benzathine because it's a large molecule, it's a thick molecule, and this is going to be same. So it's really a challenge. And drug supply and cost, all of us know cost is going to be really huge. If you ask our well-to-do patients also, even in private, probably they might not be able to take it. So it's very difficult. Now just have a look at the data. So this is a study wherein they have established rilpivirine and the adherence challenges. The important point I like to highlight is all of them were given a month of oral daily therapy before putting them on injectable, and then they were randomized. Despite of that, the failure rate was really good, almost 20-30% or more than that. And the important point here is, if you look at those who failed, those who had high viral load failed pretty early, and the failure was significant actually. So that is something which we'll have to keep in mind before implementation in programmatic management. And like I said, the injectable part of it, the specification about needle is also very significant. So someone who was used a smaller needle, they had higher chance of virological failure. So we really have to look into very minute details, including the cold chain, how we are storing it, how we are using the needle. And it really needs a good amount of training for staff, which will take a significant amount of monetary and time to establish it into the programmatic management. This another paper, which again, this OPRA study, which has significant number of patients, which were studied more than 1.5 lakh patients. So again, this has a lot of missing baseline data. Not everyone had complete follow-up. The classification was not clear. Oral bridging was not clear. Who was giving oral bridging, who was not. That was not clear. There were significant operational and bias issues. The follow-up was not clear. Selection bias was there. And monitoring, again, we know injectable have better monitoring as compared to oral. So they are picked up, the blips are picked up early when you give injectable, because they are coming to you every 3 months, and someone who is on oral comes to you every 6 months. So blips are picked up early in injectable as compared to oral. So that is again a drawback of study actually. So one more evidence, one last evidence. So this is, they have studied real world treatment setting, almost 60 patients, 15% discontinued by 12 months. Which is a good number actually. 15% should not discontinue if you have so much of discomfort of just one injection every 2 months. And why did this happen? Again, virological failure, injection site issues, and non-adherence. And the important point here I like to highlight is the archived genotype testing is something which is really important and which is missed. And to get that data for a huge population will be a challenge if we decide to implement it as a national program. So I'll rest my I'll rest my case here by saying this is really expensive. It is really demanding as far as infrastructure is considered, and the risk of resistance is really high. And if we lose this molecule, we are losing our DTG-based regime, which is really doing good and which has given a very good era for HIV in India. If you ask me about HIV a decade back, it was completely different, and we used to struggle with resistant mechanism. We used to struggle with drug interactions, multiple things. It's not that we don't have drug interactions, but we used to struggle with multiple things or multiple issues before putting the ART. Now it is so easy that you just have, we are discussing more of lifestyle diseases than resistance profile. So we don't want to lose our good molecule for the sake of something which doesn't have major data, which has a lot of risk of resistance and cost issues. Thank you.
Professor Balakshmi, please stick to the time. We are running late.
Good morning, everybody. So first, I would like to present a case, a 32-year-old male, a common case which you all see in your OPDs. HIV positive on TLD regimen for the last 4 years, virologically suppressed for 3 years, and CD4 is very good. And he's a frequent traveler, and he's getting pill fatigue, and his HPSAG negative and no resistance history. So what do we done? So, yesterday we heard a lot of lectures. One is to take him to 2 drugs or to put him onto injectable drugs if they are available. So patient is already having a pill burden. So if he has an option, he would definitely choose. If he doesn't have the issue of the finances, he would definitely choose long-acting antiretroviral therapy. We all have enjoyed the HIV antiretroviral therapy management, and it also has worked good for PrEP, and it is still working. And but then people are getting fatigued. As yesterday's lectures, Dr. Gilada sir's presentation, now the Gen Z and the digital apps and all that, so they are picking up, and they are a restless population. They are now, how very well they are going to accept daily drugs is the question. So for good results, we need good adherence. Suboptimal adherence leads to incomplete viral suppression. Multiple barriers to adherence like inconvenience, side effects, stigma, and discrimination. All these things do put the patients to not adhere so very well. So many of the times we heard from our patients, when is the cure for this disease coming? So many of them are tired, but then that generation is started to experience and fatigue now. So the advantages of long-acting antiretroviral therapy are the pill fatigue can be taken care of, the ease of travel of many of our patients, patient satisfaction, reduces intermittent viremia, and reduces stigma, reduction at the crowding at the antiretroviral therapy clinics, and my disclaimer is that these drugs have to be given in select patient population, non-pregnant, HBsAg negative, and the indications for these 2 molecules which are there, that the cabotegravir and rilpivirine, and for lenacapavir, these 2 indications are separate, and the population, they are select populations, then maybe we can give it appropriately. Not for all patients, we are not generalizing it. And the available long-acting antiretroviral therapy agents, the cabotegravir and rilpivirine, the trials and all was shown by my other debater, Dr. Pooja. So they use a nano suspension and depot retention for slow absorption. The technology that is used. So rilpivirine and cabotegravir can be given monthly, and there are also studies which say that they can be given 2 monthly also. That is the advantage. So this is the study which Dr. Pooja has already enumerated. And what is the other molecule that I would like to discuss is that lenacapavir regimen. Lenacapavir is a novel drug, and first in class, it's a capsid inhibitor, and it works at different sites. It works at viral uncoating, nuclear transport assembly, and also capsid formation. It is indicated in selected patients failing multi-drug regimen. This is the ideal drug because it's very long-acting. It can be given once in 6 months. There are also studies which say that it can be given once in 12 months also. And the treatment, HIV treatment, HIV-1 patients with adults with multi-drug resistant in combination with other antiretroviral therapy, it should be given. And it is accepted in other countries. And this is a study which Dr. Kumarasamy about half an hour ago has shown that the viral suppression is sustained even up to the age of week of 80. And this is accepted in, and also good viral suppression is seen in up to 94% viral suppression is seen in many studies. And future innovations involve the research explores implants and ultra long acting injectables. And so I am for the long acting injectable drugs. And coming to the costs are definitely high, but then you look at the other injectables like the other departments like endocrinology, wherein the semaglutide was thought very, very costly, and both the oral and also injectable were very costly. But then now the patent is taken away. Now that there are several companies which are batting for it, and you can see the number of companies now already in the market. So yesterday I heard the lecture, and there are increasing indications. The dil mange more. You just not whatever drugs, you cannot have that inertia of continuity. You need to have the increased indications like HIV transplantation, HIV malignancy, HIV pregnancy, and the Gen Z and the digital apps, and how it is going to go, and we should be ready with the long-acting antiretroviral therapy drugs. So the scientific research is like a rising sun. So much research is going on very, very rare diseases, and why not for a common disease like HIV? And let's welcome the new long-acting injectable drugs into our country also. Thank you.
Dr. Ratul Gogia.
Thank you. Thank you so much. Good afternoon. Thank you, Dr. Gilada and Dr. Tripti, to have me here. And I have been taught at home that never argue with the ladies, and I've been pitched against the ladies. So I've taken a special permission today at home that I do argue, but I be gentle and soft so as to not create any problems here and back home. So we've had the evidence. We've had everything. There is no doubt. New drugs, amazing drugs. There is no problem. There is enough data that they are efficacious. We've had this. The pros have already been put forward. But just want to show this. We've seen the era of SMSs. We've seen the era of WhatsApp, where you could not delete the message. And now you have the option where you can delete it for all. So it's just like that. If you have an injectable long-acting drug, you once give it, you cannot delete it from your body. It's in there, your system. So, you are deleting a message, you realize after an hour that there is a problem, you can delete it. But once the drug in, you cannot take it out. So there is persistent protection is there, but it cannot be stopped. There may be problems with the drug. There may be a reaction. There may be additional medication which needs to be added. So that is one of the inherent problems upfront, which is there once you get the injection in the system. Sorry, it's not. Yeah. Similarly, one size does not fit all. So when you are starting oral ART, you are quite confident of giving medications. But here, you need to screen the patient properly. You need to see for drug interactions. You need to screen for hepatitis B. Then there is a problem for suspected resistance, breastfeeding, pregnancy. So these are the issues where you cannot use this drug. So an active pre-screening is very, very critical. We need to screen before all this is there. most of the daily oral ARTs are safe in these settings, whether it is hepatitis B, whether it is pregnancy, and you can modify the dosage schedule when it comes to using drugs like rifampicin. So those are the challenges. We are a high TB burden country. So, and there are these issues. So we have to be very thoughtful while using the drug. Much has been said about the virological catch. Failure, we know, is rare. It's very, very rare. But resistance risk is very high. So even if there is a small failure happening, the resistance, if it happens, is going to be huge. So that is the major concern which is going to be there. Talking about the threat of the pharmacokinetic tail, it stays in the system for a long period. So it is going to be weeks and months when it is going to be there, and it is going to be exposed the body. It may take, depending on you're a male or a female, or what is the BMI, it may take a long time to clear the drug from the system. So there is inherent chance of developing resistance. Then the ASIC threat, there has been a polymorphism, the L74I polymorphism, and the impact is that it can cause a resistance to the commonly used oral drugs, and this is local, but it can spread on with the traveling and the population mixing which happens. So we've already discussed this, just reinforcing injection burden, cold chain storage, and enzyme inducers, which is a problem. Visit frequency and logistics. You do not want long queues. Problems with transgender women, people who are using drugs, and systemic medical mistrust. So these are certain problems which are there when we are going for this thing. You have visit multiplier, you have financial friction, we've discussed. Then you need staff who's trained for dispensing oral tablets and for giving injectable. The training is different. So you need differently trained people. We are all talking about fatigue and the pill fatigue, but there is fatigue in the physicians, especially in the public health system, when you have queues every 2 months coming in for an injection. The waiting time for the patient as well as the burden on the clinician is going to go up, and which is a challenge which has been reported. So as we see, the vulnerability window is there. Complete drug washout takes time, and during that there is a high chance of the selection of drug-resistant viral variants. Though this is another major concern, which we will see once we use these drugs over a period of time, for which we do not have much. So the important is, before we successfully roll out these things, we have to have targeted prescription. We have to understand the tail phase protocols. We have to understand the infrastructure investment which requires, before we blindly follow what's happening in the West or we get excited about it. So that is what we need to see. So we need to monitor these vulnerabilities. We have to automate administration and build the infrastructure before we go further. So these are the final takeaways, that obviously the injectable cabotegravir is a monumental leap forward for a patient dignity and HIV management, offering undeniable freedom from the daily pill burden. But global responsibility needs to be there, because drastically we have to adapt the healthcare infrastructure. Clinicians must maintain uncompromising virological surveillance to prevent the pharmacokinetic tail from unraveling the global efficacy of integrase-based therapies. Thank you so much. I rest the case here.
Thank you. Thank you. We'll start second innings now for the debate, rebuttals. First, Dr. Pooja Shah. 2 minutes only, madam, because we took late now.
So I think few points that I would like to highlight, which were mentioned. One is about the staff training. So there are now studies, including the ones that I had quoted, that when a standard implementation versus enhanced staff training was compared, there was no additional staff training required. Any staff who knows to give intramuscular or subcutaneous injection is capable of giving this. So not much staff training. Coming to the cost, I understand that currently, there is no denying the fact that it is currently under patent and it is prohibitively expensive. But this is something that is still being rolled out. And I'm sure, like ma'am said, that once it comes into generic setup, there'll be a significant reduction in cost. Third thing is about the pharmacokinetic tail. Yes, there is a delayed clearance of the drug, especially in those who have increased adipose tissue. But there is a very simple way of dealing with it. That is to give the oral antiretroviral therapy. So I think that is something we have been doing for decades. So I don't think that should be very problematic. If you are stopping the drug, you just give the oral medication and that should take care of it. Fourth thing is about the pre-initiation testing that is required. Yes, currently that is a mandate that if possible, we should have a genotypic resistance testing prior to drug initiation. But there are many scenarios, including real world data, that show that in virally suppressed hosts where we are not able to do genotype testing, they have gone ahead and given the drug. They only need to ensure two things in those scenarios. If you're not able to get a genotype testing, you need to make sure that the patient does not have a risk factor for virologic failure, that is previous BMI of more than 30, A6 genotype previously documented. Actually, A6 is very uncommon in India. It is predominantly of the African descent. So I don't suspect that will be a big problem for us. And so with that being there, I think that that is also not a major hurdle in implementation of these strategies.
Rashwini.
There are 2-3 exclusions like pregnancy and obese patient, like I said. So obesity, whatever failures were there, majority of it had high BMI. And that was one of the reasons for failure. So that is one point I guess we have to keep in mind. And quite a few of our patients, especially post-staph and ATG, the weight gain is significant. And those who are high BMI, the population is really increasing. Cost, okay, we'll work out the cost of the medicine. What about the cost of transportation for a patient who is coming after 6 months with great difficulty, because there are lots of things involved when he travels. Forget about the finances part of it. Baki arrangement he has to do, work factors and all those things we have to keep in mind. Someone who is not coming for follow-up after 6 months, I'm not sure whether that person is going to come for follow-up every 2 months. Very practically not feasible. Hepatitis B, 10% is something is our basic rate as of now, and we are really seeing increasing hepatitis B rate. So even if we are working on increasing the Hep B vaccine coverage, we are not able to hit the target. So that is something, again, I guess will be a big hindrance. And transplant population.
Dr. Subbalakshmi.
So coming to the patient population and the transport. So not every patient is being offered. It is not in the ART centers that we, initially being introduced. It is a very, very select population. So that is the disclaimer. So not every patient will be, offered this. The cost, the transport, if everything is taken care of, then maybe, these patients will be given. So that is the first thing. Not every patient, not into the ART clinics right now. So all these, and excellent, a very good point. Patient should have an excellent screening, and after that only patient should be started on this. And the very unlikely event of tuberculosis, then only we should, take these patients, enroll them. And one more important thing is there should be a central monitoring when we introduce this in the beginning, and there should be intense monitoring to track these patients, not to be losing them from our follow-up.
Dr. Atul Gogia, final.
Thank you. So I think I'll just sum it up. They have agreed to the fact that it is not a drug which can be given to everyone. It's a new drug. It's got good efficacy, but you have to choose patient selecting. It is not that you can give it to everyone, because we have discussed about screening, whether it is pregnancy, whether it is other drugs, or whether it is cost of travel, cost of workload, taking more days off during the year than taking oral. And the other thing is, if you have to switch to oral, what is the point? So if you miss the drug, it is a problem. If you have to switch back to oral to, cover up for that, then what is the fun of taking a long-acting injectable? So that is another issue. So there are these kind of challenges which are there. Then there will be so many transplant populations, other immunocompromised patients who are on multiple and immunosuppressive agents. We need to have more data about this drug, and the drug-drug interaction is going to be a big challenge. Patients ending up in the ICU, it will be a challenge if they have already this drug in their system and they need antifungals, azoles, so many other drugs which are there. So that will be a challenge. So it is not something you can blindly go for everyone. We have maybe in a selected few, yes, but not for everyone.
Thank you. Now I request Dr. Kumar about his comments. Audience question.
Maybe since you asked, okay, first congratulations for the debaters, but I'll totally disagree with people who talked against cons, because you use certain data and criticize that it cannot be given. That is wrong, actually. There are a lot of ways where you can argue in a way that, there are cons, but not using the data. The data, whatever you interpret it, is wrong, because those data very clearly shows that you can easily can be given, right? And again, we recommended this in the guideline, not for everybody. If you read this, there are population select where we feel that the clinician feel that they are not going to adhere. So this is going to be benefited, you can do that. But on the other hand, there are patients who wanted to, even in the United States, when they have all these long-acting injectable, the whole US, only less than 1% of the HIV-infected people are on long-acting injectable treatment. All the other prefer still oral therapy for various reasons. So this again, now this is a start. We have CAB, rilpivirine. But on the other hand, there are a lot of drugs on pipeline. You heard from Dr. Babu, and as well as a lot of every 6 months, even rifampicin-friendly drugs are in pipeline, even for many other occasions. So this is something, the debate is on whether you want long-acting or not the product. At this time, we have only this product, right? But on the other hand, a lot of newer drugs are all been there. So, but on the other hand, you can always argue in many, many ways. In a way that patient coming to having an injection, many times they may reject, because it's painful. They may prefer to take a oral tablet. And again, cost definitely is going to be high, as compared to the oral, it's not going to be less. Even Clinton Foundation projecting the cost, I won't believe that on a long run, it may even go up. There are so many other things are all on that. But on the other hand, the data currently, whatever we publish, every shows that it is very convenient and it is very favorable. Yeah, thanks.
Any questions from the audience? Any questions?
For every doctor, there are two types of patients, poor and rich. Rich people always feel more stigma. They always ask about the injections or long-acting injections or complete cure. And many parents are suffering a lot to give medicines regularly to their children without knowing the HIV status. At education, at jobs, it is very stigma to regularly take medicines. In such populations, it is definitely a useful option.
Okay, let us summarize. Long-acting ARTs represents an innovation, but innovation must be evaluated with thorough clinical safety, public health and logistic practicabilities, accessibilities and flexibilities and cost effectiveness and so on and so forth. It is neither an universal replacement for oral ART nor merely an expensive alternative. It is a tool whose success depends upon the careful patient selection, monitoring system, and responsible implementation. So ongoing research will still refine further. Thank you. Let us have some poll in the audience. Who are for injectable? Please lift their hands. About 20. Who antagonize? Who are not for it? Rest. Okay, thank you. Thank you. We had a fruit.
Thank you very much.
Thank you very much. It's a fruitful discussion. We will winding up the session and take over.
I'd like to request the moderators to felicitate the debaters the memento. We'd also like to call upon Dr. S.K. Guha to felicitate the chairpersons of the debate. We'd also like to request the audience to stay back for the group photo, which will be occurring shortly after. Requesting everyone to come to the stage with the group photo.
Everyone, please step forward. All the seniors or those who consider themselves seniors can please take the chairs. Kumar uncle, you'll have to go here. Gloria auntie, you'll have to come at the center. फैजान स्टेज ठीक रहेगा ना? काफी लोग जा रहे हैं ऊपर. Moti uncle, you'll have to be up. Please. आप अगर सीनियर नहीं होंगे तो फिर कौन सीनियर होगा? आप चलो. Go on the chairs. Go on the chairs. Go na. Yeah, go.
हे माइक नाही.
नील्स ऐसे ही आ जाएंगे. जरूरत पड़ेगा चेयर का? नहीं लगेगा है ना? चेयर्स, डोंट टेक द चेयर्स. As long as y'all can see the camera can see you. So आपका आ गया वाइड? पूरा आ रहा है? पूरा हो जाएगा? आ रही हूँ, I'm coming. बीच में. You can all take your cups of tea and coffee and come back. It's right here, so you don't have to step out today. You can get the tea and coffee from the left side here. And you can take your chai and coffee, come back so that we can start on time. Thank you.
नहीं डबल प्लाई है. 400 लोग खड़े हो सकते हैं अगर आ जाए. मैडम अभी किसका नाम है?
Everyone is requested to bring your chai and coffee and come to the hall so that we can start the session on time, and that way we can also end the session on time. Welcome back. We'll move on to our next session, which is on HIV and aging, when viral control is not enough. For this, I would like to invite our co-chairs, Dr. Amar Pazare from Mumbai and Dr. G. Samaram from Vijayawada to the dais.
Good morning. Starting the new session, HIV aging, and when viral control is not enough. First speaker, Dr. Naval Chandra, our own office bearer. He speaks on the diabetes and metabolic syndrome in patients on AI.
Welcome Dr.
Over to
Naval
Naval.
Chandra to ASICON 2026, Mumbai. A respected clinician from Hyderabad, he plays a pivotal role in addressing metabolic complications and diabetes in people receiving ART. Today, he speaks on diabetes and metabolic syndrome in patients on ART.
Wow, I didn't know I was looking so smart. Anyways, thank you, Dr. Gilada sir. So, okay. Good morning, everyone, and thank the chairpersons and thank you for that brief introduction. I was given this talk by Dr. Gilada, I think purposely with a vision, because this is where we are heading today. It's not only about treating ART or HIV positive patients with ART and, kind of managing the ART scenario only, but we are aware our patients are getting older. They're going to come back to you with a lot of these NCDs and comorbid issues. So when Sir gave this topic, you will all realize this is the way to go. And there is a model I would request, and hopefully one should look at this in the future. Yeah, so changing landscapes of HIV care, we are all aware. ART has transformed HIV into a chronic manageable disease. Life expectancy is now approaching the general population. A new set of HIV-associated complications have emerged, that especially with the NCDs taking the center stage also. There are certain metabolic complications which are major drivers of long-term outcomes, and CVD has emerged as the leading cause of death in well-treated HIV populations. It would also be, it's interesting to note that people living with HIV experience accentuated burden of cardiometabolic comorbidities compared to age-matched uninfected counterparts. Well, this is what I mean by chronic diseases. So on the left is the continuum of a chronic HIV positive patient, and on the right is the interventions one needs to be taking care of. So you have a HIV positive patient, please get him under the, integrate him under the care, and retain him under care. Then you start ART, look at a less toxic ART. You know that there is a continuous stage of inflammation going on in these patients, and there are certain ART related toxicities. So we need to, one side, start certain anti-inflammatory molecules pertaining to that specific issue. And also look at aggressive, monitoring on other parameters of NCDs, like look at the lipid lowering agents, look at management of other screening like cancers and so forth. Then you know that we've got patients who are aging into the geriatric syndromes. Please, the most important thing is healthy aging, which we need to concentrate on diet, lifestyles, and so forth. So we all know it's a huge burden in our country, and these delivery systems are so important. So, there is a module one should look at when you design, when you look at where our patients are heading. And I'm just going to stress a little on that module in my next few slides. So this is a little burden of diabetes and metabolic syndrome in people living with HIV. We all know it's about 1.5 to 2 times higher versus HIV negative. The metabolic syndrome prevalence in ART-treated people living with HIV is as high as 20 to 40%. Insulin resistance is going to be a huge issue, especially its prevalence in non-diabetic ART patients is as high as 44.7. The earlier onset and higher cardiometabolic risks are seen more in South Asian population. There's a strong association with duration of ART exposures. So when it comes to the Indian population, where are the issues? It's primarily because we have a high visceral adiposity issue with a lower BMI. These are some of the factors prevailing in our country. There is a high background prevalence of insulin resistance. The incidence of dyslipidemias are high. The incidence of NAFLD increasing in our country. And these are all going to pose challenges in the years to come for our patients. So key epidemiological data, these are some of the data from Indian studies. So if you look at the right side, this is the study content, the left side, the parameters, and what the prevalence is. So just a brief mention, metabolic syndrome overall in our HIV positive patients, not taking into account a particular regime, as high as 19.8 to 26%. Metabolic syndrome ART treated is 33.43%, dramatically higher than ART naive. In naive, it's as around 2 to 10%. When it comes to insulin resistance, look at the prevalence. It's as high as 40 to 60%. Especially those with metabolic syndromes. Diabetes mellitus, ART treated 20%. There is a North Indian cohort. And there's also a South Indian tertiary care study, which shows overall in diabetes prevalence in overall HIV population is around 11.7%. So what is metabolic syndrome? I'm not going to dwell too much on this. We all know diagnosed when more than 3 or equal to 5 components, central obesity, waist circumference plus any 2, either patient triglycerides more than 150 or equal to, or on therapy, HDL-C less than 40 in men, less than 50 in women, or on therapy, BP more than 130 by 85 or equal to on treatment, and fasting plasma glucose more or equal to 100. When do you say diabetes, fasting or equal, more than or equal to 126, HbA1c more than 6.5, and random blood glucose more than or equal to 200 with symptoms. So pathophysiology is, again, we know that there is a persistent immune activation despite the viral suppression. There is a chronic immune activation and inflammation state leading to insulin resistance. And these are some of the other pathophysiologies linked. Insulin resistance is the big hidden epidemic. What among the predictors in our population? One should keep in mind the duration of HIV infection, more than 5 years, the incidence, prevalence of insulin resistance is going to go up. Especially ART exposure duration is also very important. Female genders are more prone, and also having a lower baseline CD4 count is also a predictor. A little on ART-related metabolic changes. Just want to tell you that be on the lookout, have a word of caution. I mean, a thought of caution when we are dealing with these patients. These are all, some of these molecules are gone by, PIs, older ones, which are linked to higher insulin resistance, hypertriglyceridemias, thymidine, NRTIs. Also, we don't use that now. But the important thing is a little caution on TAF. We use that in our day-to-day, a single pill molecule, which is also available with the NACO. But remember, there is a concern with some amount of weight gain and central adiposity linked with TAF. I'll be emphasizing a little on this. Well, what are the guidelines, current landscape? Those IAS guidelines 2024, it says there is a significant weight gain which is seen with DTG. So we know, as I said, it's not to replace DTG out of your regime, but you have to realize these patients are going to live the next 20, 30, 40 years on DTG. So a word of caution here, one needs to assess whether DTG is responsible for this particular weight gain. And that's where we need to decide what we need to do for our patients. Bictegravir is also linked with a bit of weight gain. Compared to other molecules, bictegravir has a little less incidence of weight gain. More pronounced among, again, women, ART naive patients, and those switching from TDF to TAF. What are the risk factors? Again, for diabetes and people living with HIV, traditional, we are all aware, it's in general population, age, family history, sedentary lifestyles. But what are the HIV-specific risk factors? Again, duration of infection, as I said, ART exposure, chronic inflammatory state, and in our Indian context, a high visceral fat at a lower BMI. This is some of the data, INSTIs-related and diabetes risk. It's an emerging evidence coming on. So overall diabetes incidence in people living with ART, around 10.7 cases per 1,000 person years, more than 4 times greater diabetes incidence in people living with HIV versus those with untreated. And there are a few studies which are just cautioning us on the INSTI-specific risks involved. Mechanism of INSTI-associated metabolic dysfunctions. Again, there are 2 weight-dependent and weight-independent pathways, which are the emerging evidences, something like a direct action on adipocytes, induction of oxidative stress and fibrosis in adipose tissue, impairment of insulin signaling and glucose transport, and so forth. So coming to PIs, so there is a persistent metabolic concern. We all know PIs are always been linked with the dyslipidemias, insulin resistance. We also have lipodystrophy and so forth. So there is a small comparative data. We've always placed atazanavir boosted ritonavir, which is a more favorable option when it comes to PI selection because of its a more favorable lipid profile than the lopinavir boosted regime. Though a little concern was the bilirubin, which is not really, in your clinical setting, you must have seen it's not really an issue. Well, modern context used largely reserved for salvage therapy or INSTI resistance, and a boosted darunavir is preferred when PI is required, which has got a better metabolic profile. Screening recommendations, baseline, pre-ART. So this is where we need to start focusing. We have a patient, we want to initiate ART. It's not only about checking his CD4 count or viral load and then moving on to starting ART. We need to do a fasting glucose, HbA1c, lipid panel, blood pressure monitoring, check his waist circumference, and also calculate his BMI. Post-ART initiation, month 1 to 3, repeat lipids, glucose, every 6 months, a weight, BMI, which is mandatory, every 6 to 12 months, lipids again, and every visit, a blood pressure monitoring. So this is what we all need to incorporate into our clinics in the years to follow. If we have to give that particular theme, what Sir has said, that it is about adding life to years. So This is just a screening, again, not, just emphasizing the good history taking, lipids, talk about glucose monitoring. You've got the body composition details. You need to focus on these when a patient first comes. Check his blood pressure, check his CVD risk, and also run a proteinuria component to check for his baseline eGFR. Well, NRTI backbones, TDF versus TAF, we've heard so much about this. Just want to, again, emphasize or just to mention that TAF, though an advantage on renal and bone safety, there are some disadvantages where it is associated with a greater weight gain when combined with INSTIs particularly. It has gone to show that in the advanced study. So consider TDF containing regimes in patients with high cardiometabolic risk if the renal function permits. This is very important. These are some of the IAS guidelines when it comes to cardiometabolic recommendations. Again, monitoring protocols, management principles. Do not switch ART solely due to weight gain, hypertension, or insulin resistance. Talk about counseling, lifestyle modifications for all starting ART, especially in TAF recipients. Statin therapy, though we don't have the pitavastatin, which has got a few drug-drug interactions, but atorvastatin is a good molecule. There are certain behavioral interventions, diet, exercise, smoking, cessation, alcohol moderation, but everyone needs to know. Counseling, as I said, pre-ART counseling is very, very important. And when it comes to individualized approach, you look at the demographics, female sex, Black, African, older age, high risk profile, clinical baseline BMI more than 25, family history of diabetes, prior NRT exposures, socioeconomic, low socioeconomic state, food insecurities. So you need to evaluate the patient as a whole rather than just looking at the ART module as to what you would like to start. Consider non-INSTI options in high metabolic risk patients. And if INSTIs are required, consider raltegravir or if elbetagravir, which has got a less weight gain compared to DTG. I'm not saying to do that. There are a lot of limitations everywhere, but keep that in mind when you have patients developing these issues down the line in years to come. So first line, managing hypertriglyceride, hyperglycemias, diabetes, we all know metformin, drug of choice, standard first line. We have emerging role of GLP-1 receptor agonists, SGLT2 inhibitors, and do not routinely recommend switching ART for glycemic control. Consider ART modifications only if there is a progressive insulin resistance, severe dyslipidemias, avoid older PIs, and critical never to switch at expense of biological control. These are some of the situations where you may switch. Boosted PI, you have a regime of ritonavir, boosted cobicistat, and you want to get a rationale as to reduce lipids, insulin resistance, then you go into unboosted INSTI. Older PIs, like a lopinavir boosted ritonavir, I mentioned, go into a atazanavir boosted ritonavir or a darunavir or INSTI. It will help your lipid profile. So these are some of the situations where you can change your ART regime. CVD risks are very important, but integrated HIV NCD clinic is what is preferred. I want to talk a little on this module. Please, I think this is the way we need to go in time to come. We need to form a HIV metabolic clinic, which gives you an integrated care. We need to assess the cardiometabolic risk at a 10-year ASCVD risk calculation at every visit. You have to identify the HIV-specific risk enhancers like the CD4 less than 350, history of delays, ART, prior treatment failures, MASL, and co-infection with our patients. It has to be a multidisciplinary approach. You need to get the clinicians in the picture as to giving a longevity for your patient. So practical algorithm at ART initiation, follow-up every 0.36 months, as I mentioned. New approaches, GLP-1 receptor agonists. We Soon, I think one of our companies is going to launch semaglutide. Also, ART treating companies, they're getting into this, but we are all aware of semaglutide. I'm sure there's so many of our patients who are on this molecule. This has been showing some promise for HIV-associated lipohypertrophy and weight management. There are research priorities in this area. We should look at mechanistic studies on INSTI-induced insulin resistance, long-term cardiovascular outcomes of INSTI-associated weight gains, genetic determinants of metabolic complications in people living with HIV, reversibility of metabolic effects upon ART switch. So these are some of my key take-home messages. Metabolic syndromes and diabetes are significant comorbidities in modern HIV care, driven both by HIV-related inflammation and ART-specific effects. INSTIs, while first line for biological efficacy, carry metabolic trade-offs like weight gain and potential diabetes risks, especially in women and African populations. Mechanisms are multifactorial, both weight-dependent and weight-independent pathways. 2024 guidelines emphasize monitoring lipids every 6 to 12 months, lifestyle counseling, CVD risk management rather than routine ART switching. Individualized care is essential and do not sacrifice biological control. That is, current evidence does not support switching effective ARTs solely for metabolic concerns. So when it comes to clinical implications for Indian practice, it is important that screening recommendations, lower BMI thresholds for metabolic syndrome screening, earlier screening begin at ART initiation, not just at follow-up, aggressive lipid monitoring, HOME-IR calculation for high-risk patients, therapeutic considerations, these are just considerations, avoid D40, AZT when possible, we don't do that, prefer TDF over TAF in patients with metabolic risk factors.
Naval, time is up.
Yeah, this is my last slide, I'm finished. Sir. Doravirine may be preferred, NNRTI, lipid neutral. We heard a lot about doravirine yesterday for our patients, especially those who are morbidly obese. And statins, we have atorvastatin, which can be, given in our set of patients. So the ideal goal is not just viral suppression, but healthy aging with HIV. Thank you, one and all.
Thank you. Thank you, Dr. Navachandra. Very nicely covered about metabolic syndrome. Universally now the metabolic syndrome is a more problematic condition, especially increasing more with HIV. Very well covered HIV and HIV drugs complication due to metabolic syndrome. Now we'll go to Amit David. He'll speak on neurogenic disorders.
Thank you, Gilada sir. Thank you, Trupti. Thank you, ASICON staff for inviting me and asking me to speak on this very complex topic, which if I start going into theory, will put everybody to sleep in the next 15 minutes. But I'll keep my topic very, very practical and as to the problems faced by clinicians in practice as of now. So it's very clear now with effective antiretroviral therapy, PL-HIVs are living longer. Neurocognitive impairment is seen in patients who are virologically suppressed. And these disorders are collectively called as HIV-associated neurocognitive diseases or HAND. It occurs in around 20 to 50% of patients, even with viral suppression. Severe dementia is now rare, but mild cognitive impairment is frequent. If we start doing HIV dementia scale in all of our patients, we will soon pick up some amount of dementia in around 20 to 50% of our patients as well. Sadly, it is not done. The neuro is one of the neglected aspects in HIV as of now. Modern ART has effectively suppressed HIV. It has restored T-cell immunity. However, it is inadequate to completely remove the CNS reservoir, and hence persistence is there. As soon as you stop your ART, there will be a rebound, and hence we need consistent adherence for over almost decades together. Initially, we believed that the CD4 cell, the resting CD4 cell was the reservoir, but now it is clear that lymph nodes, bone marrow, gut, and CNS is also a reservoir for HIV, and it remains detectable in the brain even on suppressive ART. So once we want sterilizing cure for HIV, we need to go through the brain. Unless we sort this out, we will not be able to cure the people of HIV. Why is the CNS the perfect sanctuary site? It is because of the blood-brain barrier that partially limits entry of antiretroviral agents. It has a unique immune surveillance system because of which the immune cells can't enter the brain. So HIV actually sometimes has a free rein. There are presence of long-lived glial cells which can support HIV replication for almost 60 to 70 years. So it can just remain silent there for life and keep quiet as long as you are taking antiretroviral therapy and bounce back once there is ART misadherence. These characteristics make CNS a potential sanctuary site and an excellent reservoir for HIV. What are hand or HIV-associated neurocognitive disorders? There are three forms. One is asymptomatic neurocognitive impairment where the patient is not having any symptoms, but you end up doing the dementia scale and you find mild dementia over there. Then there is mild neurocognitive disorder where certain activities of daily living are hampered while rest of the thing patient goes on. While the most severe, which we used to see when the patient was not on antiretroviral therapy, was HIV-associated encephalopathy or HIV-associated dementia, which has now gone down drastically, but milder forms are still common with antiretroviral therapy. What are the risk factors? Older age, low nadir CD4 count. So if you start late, there is a high risk that your patients will have neurocognitive impairment on antiretroviral therapy. People on long duration of HIV infection. So people today are now 20 years on antiretroviral therapy, 25 years on antiretroviral therapy. The whole cognitive reserve is going down because of which neurocognitive impairment can happen. Cardiovascular risk factors, substance abuse, depression, hepatitis C co-infections are other risk factors for neurocognitive impairment. Why does it occur despite viral suppression? We say viral load is suppressed, but patient says, I have imbalance during walking, slowing, working. I don't have the same cognitive reserve. My boss is threatening me to fire me because my work output is not good. Why is this happening? Because there is persistent low-level CNS replication, and I'll come to it when my CSF escape slides. There is chronic immune activation in the brain. There is neuroinflammation. Now it is very clear that dolutegravir also has some amount of neurotoxicity. People are aging. Today's HIV positive who is 50 is cognitively 70. And there are comorbid conditions like Hep B and Hep C, which can also lead to neurocognitive impairment. So it is a reality. What is the impact on patients? Medication adherence is a problem, daily functioning is a problem, employment is a problem, quality of life is a problem, increased morbidity is a problem. So it hurts people silently. People will not tell you, but few patients have come to me saying, sir, mera job khatre mein hai, but my boss is saying that that output is not there anymore. I am considerably slowing. So why does this happen? Is because HIV is detected in the CSF at the time of acute HIV infection. So brain seeding of HIV occurs when the HIV enters the body per se. Then it starts attacking it is T5 tropic, so it attacks the T cells and gradually goes on to become a macrophage tropic virus in the brain. Once it starts entrenching in the brain and becomes macrophage tropic, that is the time you have greater pool of infected cells. There is a slow decay of HIV even after starting antiretroviral therapy. There is increased chance of viral resistance because it's a sanctuary. And there is increased chance of CSF escape, which leads to inflammation and then leads to gradual dementia. So subcortical dementia because of HIV escape, we have all seen. Thankfully, after the onset of dolutegravir, it has gone down. But few cases we still see even now. What is CSF escape? As I said, the benefit of ART is incomplete. In the CNS, if the CSF viral load is detectable, while plasma viral load is undetectable, it is called as CSF escape. Or CSF HIV RNA is 0.5 log higher than the plasma RNA, then it is also CSF escape. It is seen in around 5 to 20% of people of HIV on ART. If we do CSF escape for everybody, we will find a lot of asymptomatic CSF escapes, but you don't need to worry about that because they don't progress to overt encephalitis. But there are few patients who will show clinical manifestations, who will show cognitive decline, who will progress to overt encephalitis. And if the CSF escape is not controlled, it can also present with acute symptoms like seizures, altered sensorium, coma. And we have seen all these patients. It starts off with imbalance during walking. It starts off with cognitive decline. It starts off with memory loss. If you don't identify it, it progresses to seizures and sometimes altered sensorium as well. Thankfully, on dolutegravir-based antiretroviral therapy, this has gone down, but I will tell you scenarios where it can be seen and it is associated with worse neurocognitive performance. Is there data from India? Yes. I must also congratulate Dr. Atul Patel, who also has a big data of CSF escape from India. This is our data, where myself, Dr. Milind Kulkarni, Dr. Sachin Kore, and Dr. Niranjan Rathod, who are all in this conference, have pooled data for CSF escape, and it's the largest database about CSF escape in India, where we identified almost 70 patients who had neurologic symptoms on stable antiretroviral therapy and found that almost 20% of them had CSF escape. If you look at the data, you will find that majority of the patients had a Nadir CD4 count of only 76. When they developed CSF escape, the CD4 was almost 350, and they were almost 5 years on antiretroviral therapy when they started showing symptoms. Majority of the patients who started showing symptoms like imbalance during walking, like cognitive decline, were on PI-based antiretroviral therapy. Thankfully, now we have shifted all to dolutegravir-based antiretroviral therapy. Because of this, this has gone down. And also the main thing was those who had low-level viremia had a high risk of CSF HIV escape. What is low-level viremia? Your viral load is between 20 to 1000. The problem in India is we say that virologic suppression is less than 1000 copies. The US says it has less than 20 copies. Ideally, it should be less than 20 copies, because if you leave patients with low-level viremia, there is a high risk of CSF HIV escape, whether you're on any antiretroviral therapy. So we have had people with low-level viremia on dolutegravir-based antiretroviral therapy also having CSF escape. You can see here, majority of the patients were on atazanavir-based antiretroviral therapy. Thankfully, atazanavir use has gone down, but we still have patients who were on lopinavir, ritonavir, raltegravir, or lopinavir, ritonavir, dolutegravir, which were having CSF escape. That means their CSF viral load was almost 1 log higher, or they had detectable CSF viral load when the plasma viral load was undetectable. You can see the problem. We did CSF resistance testing for almost 9 of those patients, and triple class resistance was seen. So if you don't fail in the plasma, that doesn't mean you won't fail in the CNS. The CNS virus is also able to develop resistance mutations and fail in the brain, which can lead to cognitive decline. We then decided to test as to what we were treating these patients with. We had a big cohort of patients in 2018-19 with CSF escape, and all these patients were not affording for upgrade to lopinavir and dolutegravir. So we had no choice but to augment their therapy with a drug which penetrates the brain well. That was zidovudin. This was 2018, not 2025. So we decided that those patients who were just on tenofovir, lamivudin, atazanavir, ritonavir, and showing symptoms, they had never had any zidovudin toxicity in the past. We just augmented that with zidovudin because it's a cheap drug, penetrates the brain well. Try to look if it penetrates the brain well and suppresses the brain virus. Those who could afford to aggressively upgrade to either lopinavir, darunavir, or dolutegravir was done. And we found that we actually had a cohort which had zidovudin intensification and another cohort which had PI insti intensification. And we looked at what was happening to these patients. As you know, the CP score, zidovudin is the drug which penetrates the brain well. Nevirapine is the drug which penetrates the brain well. And that's why when initially the government sector was giving zidovudin, lamivudin, nevirapine, we hardly had CNS symptoms. When we started shifting en masse to tenofovir, atazanavir, these are the two drugs which don't penetrate the brain well. We started picking up these cases of CSF HIV escape. Thankfully, dolutegravir penetrates the brain very well, because of which we have a regimen which is now a good CNS penetrating regimen. As you can see here, triple class resistance was almost present in 8 out of the 13 CSF resistance testings which we performed, for which we gave PI insti intensification, while for zidovudin intensification, the patients hardly had any resistance. What we found that just with zidovudin intensification, almost 70% of the patients were suppressing in the brain. So it was just low-level viremia which was getting suppressed in the brain. Zidovudin was the drug doing the trick, cheap drug doing the trick, and suppressing the patients and making the patients symptom-free. So this is one sort of dementia, if you treat well, is completely treatable, at least partially treatable in the study population. What happened to PI and insti intensification? They also did well. So they were all alive and doing well, suppressing their symptoms, improving their life. So, and their CSF viral loads were also suppressed. So we were doing well on both accounts. Both these regimens could be used. So 24 cases, almost 75% of the patients we could completely suppress, both in the plasma and in the CSF while 25% had partial suppression. So you can see from 18% suppression in the brain, in the plasma, we went up to 81% just by zidovudine intensification, or even PI-INSTI intensification, we could reach up to 91%. So suppressing it to less than 20 copies is the mantra. It has to suppress. If it does not suppress, we'll keep getting these neurocognitive issues. Our data was then published at the Global HIV-1 CSF Escape Consortium meeting, and we were asked to submit our plasma and CSF samples, which we kindly did to the University of San Francisco. And we now published the data about what happens to the CNS reservoir, which was just published last year. And it clearly showed that the data which we had submitted, that is the Pune data, having all CSF escape, was a highly diverse kind of data, diverse kind of virus. That means that virus was well entrenched into the macrophages, well entrenched into the microglia, because of which eradicating it from the CNS, especially from our cohort, was very, very difficult. We could only suppress it, and changing the antiretroviral therapy actually suppress the virus in the brain as well. What happens to highly diverse population in the brain? It causes more inflammation. It causes more CSF cells in the, and then worse neurocognitive outcomes. So because our patients of low level viremia are not suppressed to less than 20 copies, we don't give so much importance to having undetectable viral load. This can happen, that a highly diverse virus can wake up in the brain, cause CNS inflammation, high CSF lymphocytes, and high CSF neurologic biomarkers, which can lead to worse neurocognitive outcomes. So this is what has happened. In the US, they immediately change antiretroviral therapy, while in India, sometimes we keep on going with low-level viremia, which can have these issues. So more CNS inflammation, more CSF diversity, worse neurocognitive outcomes. Thankfully, optimizing antiretroviral therapy did help, but I don't know if starts failing again, what is going to happen. So this is what is seen in our population. We then went on to give some recommendations. As you know, we have only asymptomatic neurocognitive impairment, mild neurocognitive disease, and HIV-associated dementia. That's it. So we were authors for this paper, and we gave that we need to now change our approach to neurocognitive impairment in HIV-positive people. We need to know that it is not HAD, it is HABI, HIV-associated brain injury, because now there are other factors also causing brain injury. There is hepatitis C, there is alcohol, there is depression. All these can cause brain injury. So we suggested, it's not recommended, we suggested that HAD should be labeled as HIV-associated brain injury. We should stop doing just neurocognitive tests for the heck of it, because telling the patient that he has a symptomatic neurocognitive impairment or mild neurocognitive disease actually causes a lot of anxiety. So you should have symptoms, you should have neurocognitive impairment on test, and there should be a treatment available. Only then recommend. Otherwise, whatever is happening in the priority sector is fine. The patients are doing okay. Keep it. Don't give them a diagnosis which they struggle to understand and causes more anxiety. So these are all risk factors which can cause brain injury, and the patient needs to know that it's not just HIV. It could be TB, it could be crypto, it could be toxo, it could be cerebrovascular disease. So many of our patients are coming with stroke, traumatic brain injury, substance abuse, alcohol, and even antiretroviral CNS neurotoxicity. What are non-pharmacological managements which we can do? Cognitive rehabilitation, treatment of depression, control vascular risk factors. Sir initially talked about pitavastatin, atorvastatin, which can help. Physical exercise and healthy lifestyle can help in neurologic rehabilitation. What about prevention strategies? Early HIV diagnosis, early initiation of ART. Once we initiate ART early, sir, last slide, it won't penetrate the brain so easily. It won't entrench itself into the microglia. It won't cause a reservoir which can later trouble you. So early antiretroviral therapy helps. Good adherence, regular neurocognitive screening, and ensuring that your viral load is always undetectable, not 20 copies, 30 copies, 100 copies, because that is an invitation to trouble. Even this small viral load is an invitation to trouble. So what are the take-home messages? Neurocognitive disorders remain common in virally suppressed PL-HIV. Mostly mild cognitive impairment now, but if we shift to PI dolu for a longer time and the virus low-level viremia increases, we might have some issues later. Early screening is important. Management requires ART optimization and supportive care and suppressed viral load, both in the plasma and in the CSF. And finally, the road to HIV sterilizing cure runs through sanctuary sites like CNS. Until that is cracked, we won't have a sterilizing cure. Thank you.
Thank you, Dr. Amit. Excellent work and very excellent presentations. Possibly this will give the different way to treat the patient of the CNS escape and Next presentation by Dr. Kristen Barber from UK. Fatality and accelerating aging went to when is
Swagatam. Welcome
50,
Dr.
70.
Kristen Barber to ASICON 2026, Mumbai. Our
Hello, my name's Tristan Barber. This talk is entitled Frailty and Accelerated Aging. When is 50 actually 70? Really in the context of living long with HIV. These are my disclosures. So when we think about someone with HIV who's getting older, what commonly happens is that they start to fall between the cracks of multiple different services. We see people struggling with their mental health, with issues around polypharmacy, of course with issues around HIV itself, often with issues around basic needs and access to social services, having problems with multimorbidity and managing complex comorbidities, accessing primary care, and also sometimes having to access multiple outpatient appointments. Very often people with HIV report that their HIV service is the one that they trust the most and where they'd like to see their services coordinated. But for HIV providers, this can be difficult. They may not always have the expertise to manage all of the complex problems that an older person with HIV is experiencing. We know that around the world, the number of people living with HIV who are aged over 50 years is increasing. In 2016, it was estimated there are around 5.7 million people with HIV who are over 50. And this proportion had increased substantially from 8% in 2000 and went up to 21% by 2020. In 2016, 80% of the people living with HIV who are over 50 lived in low and middle income countries. While the proportion is greater in high-income countries, LMICs have higher absolute numbers, and this is expected to continue to increase. From 2000 to 2016, the proportions doubled in Eastern and Southern Africa, Eastern Europe and Central Asia, and Western and Central Europe and North America, but tripled in Latin America and the Caribbean, and quadrupled in Asia and the Pacific regions. Older people living with HIV, we know, experience higher rates of key comorbid non-AIDS events. We can see here in this graph how the proportions are expected to continue to increase in LMICs in particular, with a steady increase in high-income countries in addition, shown here in blue. If we don't take action today, we know that quality of life and actual lives may be lost. Many will struggle coping with multimorbidity and other chronic health conditions. You can see some of these listed here, including cognitive impairment, depression, social isolation, chronic pain, frailty, sleep disorders, disability, loss of energy, loneliness, and multimorbidity. Sometimes I think as HIV providers, we can feel we're unable to cope with the huge amount of problems people may experience as they get older. But I would argue that just by taking a little bit more time for those who are older and most complex, taking a full medical history rather than just focusing on HIV, we can often identify issues that it's relatively easy for us to help support or signpost people for further support with. We also know that people who are getting older with HIV may experience ageism in addition to HIV stigma and other forms of stigma and discrimination. So what is frailty? Well, frailty is defined as a state of decreased homeostatic reserve resulting in an increased vulnerability to endogenous and exogenous stressors and an increased risk of negative outcomes. What this really means is that people who are frail have less ability to cope with environmental insults or other illnesses. So if you develop a cancer, if you have a fall, you may be less able to recover than someone who is not frail. Most of the research that has happened in this context relates to older men. We see here a man across the life course, and I think it's very important to remember that in women there are additional factors that can lead to premature frailty, including in the context of HIV, premature menopause. We must also not forget people who acquired HIV perinatally. These individuals, although their birthday age may be relatively young, can have been living with HIV for many years. So if you acquired HIV perinatally and you're now 30, you can be the same as someone who acquired HIV horizontally at age 40, but is now 70. And this leads me to thinking not only about your chronological age, but also the length of time you've been living with HIV infection. When I'm thinking about what I'm talking about with regard to aging in the context of HIV, and when I'm thinking about an individual person with HIV in front of me, I tend to split people into 4 categories. Now, I'm using here the date of HIV diagnosis as a surrogate marker for the date of HIV acquisition. So if you were born before 1996, and of course these cutoffs depend on what country setting you're in and when you had access to antiretroviral therapy, but thinking of the UK setting, before 1996, this is when people didn't have access to successful triple combination therapy. You may need to adapt these dates according to your own setting in India. But for me, someone who was diagnosed before this date is someone who will have been told to stop work. They will have been told they might have a 3 to 5 year life expectancy. They may have had an AIDS-defining condition. They'll certainly have had a long period of time of exposure to untreated virus and to immunosuppression. They'll also have suffered bereavement. They may have some post-traumatic stress disorder, and their entire life has very often been affected by their HIV diagnosis. In 1996, at the Vancouver World AIDS Conference, we saw the presentation of successful triple antiretroviral therapy. Now, in the latter part of the 90s, there was therefore optimism about the success of treating HIV and giving people a better life expectancy. But nonetheless, treatments were complicated, often involving multiple pills. They had multiple toxicities, and some people still had a legacy of resistance from suboptimal treatment before triple therapy was available. And actually, in the early noughties from 2000 to 2005, some of this optimism went away as we saw an increase in triple class resistance, and we were worried that we were starting to run out of successful antiretroviral options. So again, this group have been heavily affected by their HIV journey. As a consequence of the toxicity of antiretroviral therapy, guidelines were recommending that we waited to start treatment until a CD4 count of 200. So again, these people had prolonged exposure to immunosuppression and untreated viral replication. From 2005 to 2015, we had more successful treatment. We saw drugs that could treat resistance that had developed that could treat virus that had developed resistance previously. And we also saw much better tolerated triple therapy, including the first single tablet regimens. Now, as treatment was better tolerated, we saw a recommendation in guidelines that we moved up to a CD4 count of 350 for initiating treatment. From 2015 onwards, we've had the START study, and we've known that it's the right advice to recommend that anyone with HIV starts antiretroviral therapy regardless of their CD4 count. Now, I think you can see that you can be 70 and have been diagnosed in 1990. You can be 70 and have been diagnosed in 2020, and these are very different individuals. Their pattern of aging with HIV and the impact HIV has had on their aging are going to be incredibly different. And it's for this reason I recommend we don't only think about chronological or birthday age, but we think about HIV age in addition and how this plays into someone's risk factors for developing frailty or premature comorbidities. What's actually happening in terms of pathogenesis? Well, there are a number of factors in people with HIV that can feed into premature aging and premature frailty. We see issues with genetic variants, we see DNA damage moving around this clock, if you like, here. We see mitochondrial dysfunction, we see abnormal protein metabolism, we see abnormal cell metabolism, we see premature senescence, we see an impact on people's immune system, and we see chronic inflammation in addition. We know that HIV can affect the gut. We may see altered gut microbes. We may see altered gut permeability. We know that environmental factors like diet, alcohol, sedentary lifestyle, drug use, and smoking can, of course, impact on someone's aging. And we know that some of these things are more common in the context of HIV infection. And then finally, in red, of course, we see the direct impact of antiretroviral therapy and of HIV itself. HIV proteins may promote premature aging, and some older antiretrovirals in particular may contribute to a premature aging process. This is just a schematic to look at what we mean by chronic inflammation. We know that persistent inflammation and immune activation, which may be triggered even by very low-level viral replication below the limit of detection on standard assays, have been linked to the increased frequency of age-related conditions in people living with HIV. In addition to lifestyle factors, this can contribute to persistent inflammation and may lead to the premature comorbidities we see listed in the yellow blocks on the right-hand side of this slide. When we think about frailty and how someone might appear with frailty, this is the so-called frailty phenotype. So we see an individual on the left who's robust. As someone becomes pre-frail, they may develop reduced muscle strength. They may have lower energy than someone of the same age as them. They may get exhausted very easily. And as they accrue more of these phenotypic identifiers, we see that people have a slower walking speed. They may have unintentional weight loss, and they're accruing more factors that allow us to label them as frail rather than just pre-frail or robust. And this can help us with screening for frailty. This is the modified Fried Frailty Phenotype score that we use at the Royal Free Hospital where I work in our annual screen to try and identify people early with frailty or pre-frailty. So we ask people in the last 12 months, have you noticed any of the following? An inability to grip with your hands, unexpected decrease or loss of weight that's worrying you, a slower walking pace than usual, not feeling full of energy for most days of the week, and this is a complicated one, being less or much less active compared with someone who spends 2 hours on most days on activities such as walking, gardening, household chores, or do-it-yourself projects. And people can indicate on here if they're experiencing any of these symptoms. Now, the limitations are that this score is subjective, it's not objective, and doesn't include objective measurements such as gait speed and grip strength. It also doesn't consider the broader elements of frailty such as cognition and psychosocial functioning. But nonetheless, for us, if someone scores 3 or more on this score, it's an indication that we need to do a more in-depth assessment. We also have the Rockwood Clinical Frailty Scale. This is a visual scale where we can try and identify people's stage of frailty. Essentially, those who are in category 1 or 2 tend to be quite well. Those who are in categories 3, 4, or 5 tend to have mild or pre-frailty, and those in the higher categories 6, 7, 8, and 9 are frail by definition. And these are people who it's much more difficult to manage because reversing true frailty once it's occurred is much more difficult than trying to reverse the minor impairments that occur in pre-frailty. As I've alluded to, frailty doesn't need to be permanent. We know that frailty can progress, but if we intervene in the early stages with simple interventions, we can reverse pre-frailty and we can keep people well, independent, out of hospital, and with a better overall health-related quality of life. So again, I think sometimes we can feel quite hopeless, but what small practical steps can we do to reverse or manage pre-frailty? One of the first is improving physical function. So getting people to exercise, even if it's just walking, is incredibly important. We know that actually weight training as people get older is probably more important than cardiovascular exercise. And that's really because retaining muscle mass and muscle strength is incredibly important for older people. It's very often neglected, but even simple weightlifting, like using household objects, can help maintain lean muscle mass and avoid the development of frailty. We can also try and improve people's nutrition, and we can manage mental health problems, including mood disorders when they arise, as we know that people who are more motivated to be proactive about their physical health are better at avoiding frailty. We need to identify physical deficits. We need to identify comorbidities and other medical conditions and treat them when we find them. And where possible, we need to improve people's physiological reserve. These are some of the potential targets for intervention. I won't go through these individually. Some of these are probably harder to treat than others. I think loneliness and social isolation can be particularly hard for us as HIV clinicians. But identifying things like poor vision mean we can recommend people get simple eye tests. Just correcting their vision with regular glasses can be a huge benefit in terms of improving and avoiding frailty. For us in our dedicated frailty service, we've also found asking very simple questions about bowel or bladder continence can lead to very simple referrals to continence specialists who can help people manage their incontinence, recommend surgical intervention if necessary, but also recommend simple lifestyle modifications that can improve these symptoms, and this massively improves overall health-related quality of life. We also see studies now that are looking at avoiding some of the comorbidities people with HIV may develop prematurely as they age. The Reprieve study, presented now 2 years ago, showed us that abacavir can be associated with an elevated risk of cardiovascular events, but in addition, that treating people with statins or offering statins to everyone over the age of 40 can be associated with a reduction in major cardiovascular events, including heart attacks. Abacavir very rarely adds benefit to an antiretroviral regimen over and above the risks it may cause, so we're starting to see these trials that allow us to help people avoid comorbidities as they age with HIV. And I expect we'll see more trials looking at avoiding these chronic comorbidities as we move forward with further HIV research. Other therapeutic interventions to avoid frailty may also be useful. We're seeing an increased use of GLP-1 agonists in certain country settings, and avoiding obesity may be something that also may help people avoid frailty, although of course we do know that GLP-1 agonists may mean that people lose muscle mass in addition to fat. And there are other pharmacological interventions that may be associated with a reduction in comorbidity burden, including metformin, potentially other novel anti-inflammatory treatments, specific treatments looking at reducing the effects of aging. But I would say, apart from pharmacological intervention, the best overall treatment to avoid frailty is regular exercise, and that must include some weightlifting to maintain muscle strength, not just cardiovascular exercise. In terms of antiretrovirals, I think we need to use antiretrovirals with the least potential for drug-drug interactions. We need to review older patients in terms of their co-medications and avoid complications of polypharmacy. And we need to bear in mind that with new medications, both for HIV and for other comorbidities, drug-drug interaction studies may not yet be done or may not be very clear. So we always need to be aware of the potential for drug-drug interactions. What we're really trying to aim for is good health-related quality of life. This is my terrible drawing here on the right-hand side. But we know, for instance, in the UK that 97% of people living with HIV have viral undetectability. We're now looking beyond viral load alone to make sure that we're providing quality healthcare in addition to viral suppression. And service delivery should always promote wellness rather than just survival. And this has been called the fourth 90. I would argue now it should be the fourth 95, but we're trying to ensure that as many people as possible with HIV have good health-related quality of life over and above viral suppression. So simple steps we can do in clinic. We often feel overwhelmed. We may not be able to do a frailty assessment in a very busy clinic, but what we can do is talk to people about their physical function and about their activities of daily living. We can do simple things like measuring and recording body mass index and waist-hip ratio. We can chart these changes over time, and we can share data with colleagues to see what's happening with our older patients. And we can give simple lifestyle advice, in particular around exercise and diet. So in summary, frailty and accelerated aging do happen in the context of even successfully treated HIV. I think the HIV age matters just as much, if not more, than the chronological age. We know that inflammation may be a driver for age-associated comorbidities and for premature frailty. And we know that simple screening and interventions can reverse or avoid progression, helping to maintain independence and good health-related quality of life. What some people really need is some help with care coordination, and if possible, this is crucial if comorbidities cannot all be managed within HIV services. Just checking that someone's able to attend all of their appointments, trying to co-locate blood tests within one drawer if possible, rather than people having multiple blood draws at multiple different locations, can really help with overall health-related quality of life and help with care coordination. We all deserve age-friendly and age-affirming information, care, services and support that considers not only the impact of our HIV status, but also our gender identity, sexual orientation, race and ethnicity. I think this overarching statement really gives us something to aspire to in terms of caring for older people with HIV. I didn't have time to cover it here, but I just wanted to highlight a fantastic session that was undertaken at CROI by Shibani Mukherjee from Massachusetts General Hospital in Boston on cognitive aging and assessment in HIV. If you have access to the CROI website or you ever get the opportunity to hear Shibani talk, this was a really, really wonderful session. Finally, as I'm here representing the British HIV Association as chair, I wanted to highlight that we do have international membership available for BIVA, which does offer benefits to those around the world, particularly in LMICs. Our current annual rate is around 3,000 rupees if you did wish to join from India, and further details are available on the link at the bottom of this slide. Thank you very much indeed for your attention, and I look forward to taking any of your questions on this talk in our discussion session.
Thank you, Dr. Barber. We can get 2 or 3 quick questions. Before you ask, I have a question to Amit. We are treating these patients since almost 1995. Around 200, we have the regimen like a TLN, or we have got ZLN. That regimen is still available, I think. At least different, not combination, not available. Can you go for the ZLN if patient has a CNS escape with some mild symptoms or symptomatic patients? Can you shift the patient to the TLD to the TLN, ZLN?
I'm so sorry, apologies, I couldn't hear your question fully.
Question is for Dr. Amit.
So the question is not for you.
Sorry.
As I said, CSF escape is determined by 2 factors. Number 1, how much is the plasma viral load? How much is the CSF viral load? And what are the resistance mutations in the CSF? And what is the penetration of your antiretroviral therapy? Zidovudine has excellent penetration, but we are seeing more and more nevirapine efavirenz resistance. We don't use it anymore. So what we did was, patients who were on tenofovir and atazanavir, who were suppressed in the plasma, failing in the brain, and not affording for escalation to dolutegravir, we just added zidovudine. And that's what did the trick for almost half of the patients. The rest of the half, who were failing zidovudine in the brain as well, they did not get any benefit with zidovudine. For them, we had to escalate to dolutegravir, lopinavir, darunavir, and then they got a difference. So I would not hazard to go back to ZLN for CSF escape now. What I was talking about was, when we had ZLN in the pre-ART sector, that time neurocognitive complaints were less because we had 2 drugs penetrating the brain excellently, but they were causing so much side effects in the periphery that we had to shift the patients because of anemia, lipohypertrophy, all other issues. So everything has a pro and a con. This is a trade-off, but zidovudine penetrates the brain.
Probably at that stage, when we were looking at all the side effects of zidovudine externally, we really did not look at this component of the CNS penetration related side effects and so forth.
Actually, if we go and read Harrison sections in the past, Zidovudine is given as a treatment for HIV-associated thrombocytopenia also, because it penetrates the bone marrow well. So all these sanctuary sites is where Zidovudine penetrates very well, but maybe that is the reason why it was causing more toxicity also. So going back to Zidovudine is not an option now, because we have better options available now. This was an option in 2018, 2017, when the rollout of dolutegravir was not so comprehensive. And now darunavir rollout is also comprehensive in the free RT sector. So we have two good drugs, darunavir, dolutegravir, which will suppress the virus and penetrate the brain well. So now it is not relevant. But still, if you have an option, and you might need in a scenario where there is CSF escape on darunavir, dolutegravir, you might try this.
And what uh, Naval was saying, that Zidovudine will cause mitochondrial toxicity. Yes, we know that. And best drug was Indinavir. Indinavir is withdrawn from the market. So the moment Indinavir was withdrawn, a couple of our patients died. And we had to reintroduce them on Zidovudine. So sometimes if they've forgotten, taken, and they come back with neurocognitive problems, we have to restart Zidovudine. So I think Zidovudine has a role, at least particularly for PML people, where we have nothing else better than that.
Developed CSF escape 3-4 years back, and we put them on ZLD, and it has worked very well for them. So both Zidovudine and dolutegravir have very high CNS penetration, and short of using darunavir, if you don't want to use a PI, Zidovudine, lamivudine, dolutegravir is an excellent empirical choice for CSF escape. Thank you.
Absolutely agree.
Are there any questions for Dr. Barber? He's waiting online for us.
Can I make a couple comments, if I may?
Dr. Barber, that was a great talk. And I'm sort of thinking you're actually a geriatrician who's, strayed into HIV medicine. But one of the things that we struggle with, particularly in older people, is the effect of polypharmacy. Benzodiazepines, gabapentinoids, antidepressants. And I think that people have underestimated, forget about HIV, even in the general geriatric population, the effect of polypharmacy and accelerating frailty and frailty-associated injuries. Your comments?
Thank you. I agree completely about polypharmacy. We're lucky that we do have a geriatrician work with us within our department. He's very good at de-prescribing medicines that are no longer required, which is something I often don't feel I have the confidence to do in areas that are outside of my own specialty. But I do think we have to review people's co-prescribing all the time and see if we can take medicines away that are causing harm rather than benefit. I just wanted to reflect on some of the earlier discussions about injectable agents. Of course, I appreciate access is not there yet in India, but I think injectables can really help avoid the risk of drug-drug interactions with certain individuals. And I would say that the risk of failure and resistance overall is very low. One of the things we've found very helpful about injectable ART in our own service, that people are coming in every 2 months. They have a light touch approach with our nursing staff, and actually they can bring up problems, discuss new medicines more regularly than when they just come in for a 6-monthly appointment. So for some very complex patients, actually they can offer an advantage, but obviously they're not going to be the right treatment for everyone. So yeah, polypharmacy and co-prescribing needs review at every visit.
I have a simple question. It was a nice talk where you sort of showed us how they evolve into the frailty status. My question is, the fourth 90 that you showed is related to quality, health-related quality of life. Now, do you routinely assess it in your clinical practice? And if so, which tool you use?
It's a fantastic question. So we should be measuring quality of life, usually using a patient-reported outcome measure. That is in the British HF physician standards, but at the moment we're not doing it routinely. When we piloted it in our own group, we found that many individuals found it frustrating. They didn't want to be asked questions every time they came in. They got tired of completing questionnaires. And some people found it brought up issues they didn't want to think about. So are we doing it routinely? No. Should we be doing it? Yes.
I think we'll wrap up the session now. We are already late. Thank you very much.
Thank you very much indeed.
Thank you, Tristan, for joining us. It was really a pleasure having you. Can you stay there for the picture, Tristan? एक बार वो zoom लगाओगे, please?
Thank you very much. I'd like to call upon our chairpersons to felicitate our speakers with a memento.
Recording in progress.
I'd also like to call upon Dr. Satish Rao to please felicitate our chairpersons for this session. We'll now be starting with our next session titled Oncogenic Viruses, chaired by Dr. Prakash Bora from Mumbai and Dr. Diwakar Tejasvi from Patna. We will now be handing over the session to our chairpersons. Thank you.
Thank you. I think caffeine level is still on and pre-lunch session. So we have 4 very good lectures here. And I think caffeine level will keep you alert because the peak time is coming, 1 hour. First lecture, oncogenic viruses, and first lecture, Professor Christian is here. I request Professor Christian, and then we have Dr. Franco, Dr. Sahasar.
Suswagatam, welcome Professor Christian Schultz to ASICON 2026, Mumbai. A distinguished expert from Germany, he plays a pivotal role in advancing the management of infection-associated cancers in immunocompromised patients. Today, he speaks on infection-associated cancer in immunocompromised patients. Surveillance is the key.
Okay. So, okay, first of all, I have to thank the organizers, Dr. Jalal and all the team to invite me. I feel honored to be here. It's my first time in India, and despite the escalating conflict in the Middle East, I made it. I had a direct flight here, and so I'm happy to be here with you. And I guess our thoughts and our prayers have to go to the people living in the Middle East, hoping for a fast end of this conflict. So let me go into, I'm a little bit a hybrid person. I'm working in ID in the Munich University, but also I'm a gastroenterologist. So I have both path in my life, and I will try to guide you a little bit about new concepts of infection-related cancers driven by the International Agency of Research in Cancer, by the WHO, and I will discuss with you a little bit about the concept of surveillance and also prevention. I'm aware that there are so much interesting talks following mine that I can a little bit neglect the HPV carcinogenesis because Dr. Bona Joy will talk about this following this talk. At the end, I will talk about the concept of infection-associated cancer, about cancer in immunocompromised patients, immunosurveillance, and immunocontainment. This is a very interesting new concept, and I will try to utilize this with you because this is interesting to see the data and to think about this. And the prevention versus screening concept, because we have to be aware of what means early detection, what means prevention, what means screening. This is different terms, but everybody is using this with a maybe different understanding of the same. So it starts early. It starts in 1957, where this guy, a British guy, talked about the concept of immunological surveillance. When we think this is a legitimate concept, then we have to think about which conditions can influence the immune systems when we develop cancer. And this guy also talked about other origins, so should increase the likelihood of cancer. And this means we have to talk about infections. And if we have a look to these different cohorts shown here, you can see we have different cohorts. We have the people with primary and secondary immunodeficiency, what means also, which includes HIV-infected patients. We have people after hematopoietic or solid organ transplant. And you see this is a cohort with an increase of risk to develop cancer. Over after 20 years, roughly 15% of these people develop cancer. And we have also other patients under immunomodulating therapies like anti-TNF, like JAK2 inhibitors, but these patients have not such an increased risk to develop cancer compared to the groups I mentioned before. So it starts early. It starts in the mid of the 60s, where the IRC defined the first group 1 carcinogenic pathogens. And you can see on the left-hand side, it's one bacterium, Helicobacter pylori. It's 7 viruses, HPV, hepatitis B, hepatitis C, Epstein-Barr, Kaposi sarcoma-associated herpes, human T-cell, HIV, and there are 3 more parasites. So we have 11 class 1 carcinogens defined by the ERC, which can cause cancer. And that this is a relevant problem as is shown in the data. But if you have a look to the oncogenic viruses, it starts, as I said, in 1964 with the first description of the Epstein-Barr virus, and you see a lot of footprints of the virological colleagues showing here. I underlined this in red, and in 2008, the guys who developed Epstein-Barr virus were honored with a Nobel Prize. And you can see there are a lot of cancers linked to oncologic virus infections. And this is, I guess, a very important issue to discuss with you today. When we have a look to infection-associated cancers independent of the immune status, then you can see there is a huge amount. There's more than 2 million cases per year all over the world. What we define as an infection-associated cancer. For gastric cancer, we can say more than 90% of gastric cancer cases are related to H. pylori infection. But we can also say that a huge amount of cases is related to HPV infection and others. And if you can see here the data from India, roughly 200,000 cases per year are infection-associated cancers in your country, independent of the immune status of the patients. And if you have a look, you see here the colors. It shows us that it's a strong correlation to the socioeconomic circumstances of people living. So if you live in a more developed country, the risk is lower. If you live in a very low developed region, you have a higher risk to develop infection-associated cancer, and the cancer burden is very high, as I showed you before. When we start with the relevant group in this conference, cancer in patients living with HIV, then you can see that we have a strong correlation between the CD4 cell count and the risk to develop AIDS-defining cancer. Very nice shown for Kaposi sarcoma and non-Hodgkin lymphoma. But we have also elevated risk to develop not infection-related cancers. And this data came from the Swiss HIV cohort. It's a very nice characterized cohort of more than 30,000 patients from a small European country. And please note, all the cancers found in this HIV cohort in trachea, lung, and bronchus, and also in lip, mouth, and pharynx were only detected in smoking patients. There were no patient non-smoking with HIV developing this kind of cancer. So we have also other risk factors despite infection pathogens. So if we have the frequency, this is data from the US, you can see that the standardized incidence ratio is very high for Kaposi, is very high for non-Hodgkin lymphoma, and you can see here the numbers. And this leads us to select patients who needs screening for this cancer disease. And you can also see from the more historical perspective, I see here a lot of experienced persons in the room. When it starts that we have a very efficient antiretroviral treatment, then dramatically decrease in cancer cases in this people living with HIV group was detectable. And that means the first point of this talk is very effective and successful antiretroviral treatment leads to a reduction of cancer risk in the people living with HIV. If you have the question when we should start with surveillance, then this is our data from a transplant cohort, and I will show you we have solid organ transplantation, lung, heart, liver, kidney, and the overall cohort. And if you can see here, the lung cancer, the lung transplant patients develop non-Hodgkin lymphoma in the early phase, so up to 1 year after transplantation. That means the time point of elevated risk to develop cancer is not the same in each cohort. We have to discriminate different risk cohorts and to decide when we should start with cancer screening in different cohorts. And you see in this cohort, at least the lung transplantation cohort has the highest risk to develop cancer compared to others. And if we jump forward, then I'd like to introduce this new concept because I really like it, because we are talking about in a HIV conference, in an AIDS conference of India, about patients living with HIV. And this is a group let me say, we can assume that they have a disturbed immunosurveillance. These patients are not longer able to deal with virus-related neoantigens. These people are not in the same way able to deal with other neoantigens, and so they have a higher risk to develop cancer, and precancerous lesions cannot be, let me say, destroyed from the immune system in the same way as in immune competent patients. But if we have a look to the right-hand side, we have also the concept of immunocontainment. That means people with a established cancer diagnosis have a more worse diagnosis compared to these patients with a, let me say, undisturbed immune system. And if you have a look to the data, if we go to the patients living with HIV and after organ transplantation, the immunosurveillance is disturbed. And these patients, you see the red market, develop in a higher frequency cancers with infectious origin, like Kaposi sarcoma, like anal cancer and all the others. But if you have a look also to cancers not related to infections, then you have to look to the immunocontainment side. Then you can see this patients have a more worse prognosis. When a cancer is established in these patients, you can treat as the same way. But in the patients living with HIV and after organ transplantation, we have a lower amount, a lower tumor mutational burden, which means the immune system is less active in these patients. And all the concepts we have in a modern oncology concepts integrated, like immune checkpoint inhibition, doesn't work in the same way, because in this group, we have a higher group of, let me say, immunological cold tumors with a more worse prognosis. The patients die earlier than patients with a working immune system. So this is another concept, but the immunocontainment concept, I think it's worth to discuss. But if we are talking about prevention and surveillance, then I guess the first step has to be, we have to define populations under risk. And I did it before introducing the data about patients from after organ transplantation and living with HIV. But in the second part, we have to talk about prevention measures, because it's not only surveillance and screening, it's also prevention. And there are other talks in the sessions, and I learned a lot yesterday in the talk about organ transplantation and HIV, and also other talks given here in this very, very interesting conference. But you can see the most important thing, prevention, to prevent people living with HIV for cancer, is the sufficient antiretroviral treatment. The second one is we have to talk about vaccination, but there are other talks in the sessions. And we have also talked about lifestyle modifications to reduce the cancer risk, because we have to add the immune compromised situation to all the other risks from the general population. And I introduced it before, smoking is one of the most relevant. Let me talk about screening. When we are talking about screening, we have to discriminate between the general population, all of us, and we have to talk about the population with increased risk, as I introduced before. And we have to discuss, is risk stratification more important than a one-fits-all empiric concept we roll out about all patients, when we should start, how we should embed our screening measures, and how we can exclude subjects without risk to save our resources. And to introduce the concept, we have some barriers identified. There are nice publications about, at least in the Western countries, we have a fragmented care system. There are people, experts like you, working with infectious diseases, there are oncologists, there are transplant specialists, and there are primary care doctors. And we need a network that the concepts will be integrated in all of this. And we have a lack of specific guidelines all over the world in different healthcare systems. We have limited resources and limited access, and also limitations in reimbursement of things. And as I learned yesterday, also in India, and it's the same in Germany, the access to anoscopy is very, very low. So also in Germany, we have a low number of hospitals and persons they are trained in anoscopy, so we can recommend it in our guidelines, but nobody can do this because we have not the resources. And there are also some other factors like competing health priorities by the patients. So if we have a look to the recommendations, which cancer, for which cancer should we screen in general, we have colorectal cancer, breast cancer, we have prostate cancer and lung cancer in patients under risk. But at least I want to point out the story about hepatocellular cancer. And I really want to recommend, there's a nice case report presented by Dr. Kane in the section, in the poster section. I can really recommend this to read. What does it mean to detect hepatocellular cancer in a very late advanced stage with a non-curative approach? And this is a special group, co-infected patients in the people, patients living with HIV cohort. But if we are talking about population with increased risk, we have to define the groups, and we have to look for specific cancer types, as I showed before. And I guess the next talk will give us a deeper insight into screening methods and screening measures for cervical cancer, anal cancer, and skin cancer. And let me come to an end. This is a European recommendation for hepatocellular cancer screening in people living with hepatitis B virus infection. And as you can see, the recommendation is very strong, every 6 months. And you should also use a successful treatment, treating both viruses, HIV and HPV. But you can also use, in the daily clinical routine, I don't know much doctors using this, but you can also use some scoring systems evaluated also in HIV, HPV co-infected subjects to calculate the individual risk to develop hepatocellular cancer, age-related, and then you have a distinct amount of points, and then you can decide, okay, this is a patient with a higher risk. But we not use this, but it's a possibility to reduce the number of patients need screening, but at least you can go this way. And coming to an end, there are not only cancers with elevated incidence in patients with HIV or after transplant, we have also a huge group of cancers not influenced by this. And this is interesting, at least for me. There are some other cancers like ovarian cancer, prostate cancer, testicular cancer, brain cancer. They are not influenced by the immune system. So we can exclude this type of cancer from screening and surveillance, and we should focus on the cancers I've try to show you which elevated incidence. And so let me conclude. It's a predictable risk for the patients living with a compared immune system, and we have to identify the specific patients. Surveillance and screening should be integrated earlier and more intensified and subject under risk compared to the general population. But we have to have in mind that the risk from the general population, like smoking and all the others, are additional to the risk of compromised immune system. And the concept of combining prevention and targeted screening should be the way we have to go in the future. So let me thank you. That's our hospital in Munich. Thanks for the invitation. Thanks for being with me. Thank you.
Thank you, Professor Schultz. The takeaway message from his lecture is, one thing is that preventive measures like heart therapy, lifestyle changes, that is very important, and basically immunosurveillance with a very and immunocontainment. These two concepts he has put forward, and I think we need to follow that. Now we have Dr. Guha, who will be speaking on hepatitis B and hepatitis C co-infection.
Suswagatam, welcome Dr. S.K. Guha to ASICON 2026, Mumbai. A respected clinician from Kolkata, he plays a pivotal role in managing hepatitis B and C co-infections in people living with HIV. Today, he speaks on treating two viruses at once, HPV and HCV in HIV.
Good afternoon. All of us are aware of the commonality in transmission mode of HIV, hepatitis B, as well as HCV. So there is significant overlap amongst the diseases. And depending on the patient population, age at which the infections are acquired, and the risk factors practiced, there are varying degrees of co-infections. I'm not going into the detail because of the time constraint. I'll go straight into the treatment issues related with HBV, HIV, as well as HCV. Yes. So we all know that HBV DNA gets integrated into the hepatocyte DNA to the covalently closed circular DNA, of which is with the currently available drugs, it's not possible to get rid of them. So the objective of treatment with nucleoside analogs in case of hepatitis is to prevent the liver disease complications by sustained suppression of the HIV replication. Whenever a HIV HBV co-infection patient is seen, it's very important to assess him or her clinically for evidences of cirrhosis of liver or decompensated cirrhosis of liver, or either compensated or decompensated, and also to look for evidence of other features like portal hypertension. And you order a battery of tests, including LFT, hemogram, PT-INR, USG, whole abdomen, alpha-fetoprotein for like screening for HCC, and the non-invasive techniques for assessment of fibrosis of liver, either through FIB4 or EPRI or through fibroscan or fibrotest, etc. These days, liver biopsy is hardly performed in such patients. And HBV markers, seromarkers like E antigen, anti-HBe antibody, hepatitis core antibody, either total or IgG, as well as anti-HBs antibody should be measured. And then by a sensitive technique, HBV DNA quantitative assay has also to be done. All such co-infected patients, whether HIV, HBV or HIV, HCV, they should be counseled about abstinence from alcohol, since alcohol is known to enhance fibrogenesis that leads to faster progression to cirrhosis, safe sex practices, harm reductions, particularly in case of people who inject drugs. So indications of HBV monoinfection depends on basically E antigen status, HBV DNA, ALT elevation, fibrosis, presence or absence of cirrhosis, decompensation, etc. But in co-infected patients, the indication is very simple. All co-infected patients are candidates for HBV treatment, regardless of their E antigen, HBV DNA, ALT, F3 score, or presence or absence of cirrhosis and at age. Now, certain guidelines regarding usage of ART in HIV HBV co-infection. There are certain dually active NRTIs like tenofovir disoproxil fumarate, tenofovir alafenamide, emtricitabine, as well as lamivudine. Now, lamivudine and emtricitabine, they should not be used as a single or sole HBV active agent in a case of HIV HBV co-infection. The reason is that there is very fast emergence of lamivudine resistance against HBV at 1 year by 40% and by 4 years up to 90%. So they should always be combined with either TDF or TAF. So the preferred NRTI option is TDF or TAF plus either 3TC or FTC. Now, entecavir is a potent anti-HBV drug, but it has also some anti-HIV activity. So if someone is inadvertently co-infected patient is treated for HBV with entecavir, then there will be a little diminution of HBV viral load, but that might also lead into the emergence of M184V mutation, which is selected by 3TC and FTC for HIV treatment. So entecavir can only be given on a fully suppressive ART regimen. Now, it has been discussed yesterday and today also that sometimes TDF and TAP cannot be used or has to be taken out because of side effects and toxicities. So what do we do in such cases? There you need to add entecavir on top of that. But know that if the patient is failing on that regimen in terms of HBV DNA is unsuppressed, there is likelihood of emergence of lamivudine resistance, which is 204 M204L or I. So that mutation has got partial overlap with the entecavir resistance. So entecavir dose has to be increased from 0.5 milligram to 1 milligram daily. When one has to be cautious, there is the possibility of entecavir failure as well. Now, discontinuation of HBV active drugs from the ARV regimen may lead to HBV reactivation and reactivation associated hepatitis and significant hepatocellular injury, particularly in patients who have got diminished liver reserve, like say end-stage liver disease patients or Child-Pugh-C patients. While switching or modifying such ARV regimens in such co-infected patients, the HBV active agents like tenofovir lamivudine or tenofovir emtricitabine, that should ideally be retained. Or if in any case they can be retained, then you need to add entecavir at a higher dose. And we need to also remember that for HBV reactivation may occur in patients with prior exposure to HBV. And this patient, the surface antigen is negative, only the core antibody total may be positive. Plus minus, there might be anti-HBs might be positive. In clinical practice, we look for HBs, AG originally. Mostly, we don't look for these antibodies, but these are the patients which might later on present with reactivation hepatitis. And we'll be discussing in the next section that in HBV and HCV co-infected patients, when they are these days treated with DAS, directly acting antivirals for HCV, there might be HBV reactivation as well. Now, raised ALT during ARV treatment is seen commonly in HIV, HBV co-infection. At times, providers are at a loss what to do. Now, drug-induced liver injury was seen most with the first generation drugs like nevirapine, tipanavir, full dose, ritonavir, etc. But the drugs that we use nowadays, darunavir or even dolutegravir, they are also have some little bit of hepatotoxicity. And the other factors that one should look into is HCV co-infection, hepatitis delta virus co-infection, which is practically not screened, and a concomitant alcohol use and non-alcoholic fatty liver disease, and also some other drugs that are hepatotoxic drugs used to treat OIs. But one thing we need to remember, it could be certain rise of HBeAg could be the harbinger of HBe seroconversion, which is good for the patient. So instead of stopping the ART, you just look for HBeAg, anti-HBe, and check the HBV DNA. If the EAG is lost, anti-HBe has appeared and the DNA has gone down significantly. So continue with that regimen, even if the ALT and AST are high, even grade 3 or grade 4 elevation. Now, I just have put one trial of randomized trial in HIV, HBV patients, since these are the two important drugs that we use. One is then Biktarvy or Bictegravir, tenofovir, alafenamide, and emtricitabine. Another is the dolutegravir, tenofovir, disoproxil, and emtricitabine. It's a small number of patients were enrolled in this study. The study was double-blinded, randomized. It was multi-centric, but most of the centers were in Asia. Around 80% patients were from 3 countries, China, Malaysia, and Thailand. And overwhelming majority, more than 92% were actually male. So these were certain drawbacks in this trial. They had 2 co-primary endpoints, like an RNA, HIV RNA less than 50 copies at 48 weeks and 96 weeks, and HBV DNA suppression below 29 IU at 48 and 96 weeks. So the result clearly shows that 48 weeks, while the HIV RNA was comparable in both the drugs, Bictegravir versus dolutegravir based regimens, HBV DNA suppression rate was significantly higher. And at 98, 96 weeks, both the HIV RNA suppression and the HBV DNA suppression became almost similar. However, HBeAg loss and appearance of anti-HBe. So that means that was statistically significantly better with Bictegravir arm. So there is a notion that probably, and these were just 2 years follow-up. This study was stopped over there, but we really don't know whether with prolonged exposure with the same regimen, Bictegravir-based regimen, whether there will be much more surface antigen loss and anti-H seroconversion. Now, moving to the issue of HIV and HCV co-infection. Now HCV, we have moved from the interferon ribavirin era to the directly acting antiviral drugs. With HCV is now curable. There are plenty of well-tolerated drugs which can cure HCV with sustained virologic response rate at 12 weeks consistently above 90 to 95% with most of the pan-genotypic potent regimens. So basically nowadays we try to achieve cure of HCV even in the context of HIV. And interestingly, the response rate in HIV HCV co-infection, the HCV cure rate is similar to HCV monoinfection. And the indication to treat HCV is any level of detectable HCV RNA, regardless of its genotype. We know that there are 6 genotypes, 1 through 6 of HCV. Regardless of genotype, they can be treated. Now, assessment of HIV and HCV co-infection, we are all known that initially the viral antibody has to be tested by a sensitive assay. If the antibody is positive, then go for the HCV RNA quantification, and ideally, if possible, then go for genotyping. But it's not mandated in the national guideline. I will come to that later on. So, and for those who turn out to be negative, we need to remember that HCV has got a relatively longer window period. So if there is a suspicion of HCV infection, the serology may have to be repeated, particularly those who are continuing with the risky behavior of injection drug use, etc. There you need to continue with that annual screening for HCV antibodies. And like hepatitis B, here also, you need to counsel them to avoid alcohol, practice safe sex, and all those harm reduction for injection drug use. Now, these co-infected patients should also be screened for active and prior hepatitis B HBV infection. As I was telling earlier in the HBV section, because there is an issue of reactivation of prior HBV infection. So ideally, hepatitis B surface antigen, anti-HBC total, and anti-HBs with titer should be seen. If the anti-HBs is negative, vaccinate against hepatitis B. Western guidelines also mention that you vaccinate against HIV. If the HIV IgG is non-reactive or negative, you also give hepatitis A vaccine. Now, ART has to be started in co-infected patients as usually, but one should consider the drug-drug interaction and overlapping side effects of some of the DAS along with the antiretrovirals that we use in these days. So in concomitant active or prior HBV infection, as I was telling earlier, start TDF or TAF plus 3TC or FTC containing ART, usually either with bictegravir or dolutegravir, and treat that start ART fast. So once the HBV is controlled, thereafter you start DAS. Now, drug-induced liver injury is common in HCV co-infected patients as expected than HIV monoinfection. So after starting HCV ART, the transaminases need to be monitored 4 to 8 weeks after starting ART. Now, coming to the issues of the drugs that we available, these are all known to you. I'm not going into the detail. So we have got the protease inhibitors, NSC4A protease inhibitors, and I think slides have moved some. Some of these drugs are now available in our country, and most of them have got a high potency, and some of them are actually pan-genotypic. And their genetic barrier is high with sofosbuvir, and others genetic barrier is low. And with protease inhibitors, I mean HCV protease inhibitors like glecaprevir, or gazoprevir or voxilaprevir. These drugs often causes late rise of transaminases. So once these patients are put on these combinations, if the preferred combinations that we use, sofosbuvir and velpatasvir, that for 12 weeks, and the others are glecaprevir and preventosvir, as well as the grazoprevir with elvasvir, all for 12 weeks. These are the three preferred pangenotypic regimen. In addition, we have got daclatasvir in our country, and daclatasvir is a preferred one according to the national guideline, National Viral Hepatitis Control Guideline. It mentions that all chronic hepatitis C patients without any evidence of cirrhosis of liver should be treated with SOF-DACLA combination for 12 weeks. And those with compensated cirrhosis, that means Child-Pug A, they should be treated with SOF-VELPA for 12 weeks. And for decompensated cirrhosis, Child-Pug B and C, options are two, either SOF-VELPA plus ribavirin for 12 weeks or SOF-VELPA for 24 weeks. And for patients who fail the rare patients who fail the sofosbuvir-based first-line treatment, they should be retreated by SOF-VELPA and voxilaprevir. This is also a triple combination drug that is available, so that can be given for 12 weeks. So overall, the response rate is pretty high with the DAS. And how do we monitor such patients? LFT and renal function tests should always be looked into. But and you need to look for the drug-drug interaction also. I was mentioning about this drug interaction with these drugs, particularly when you were used daclatasvir, you need to be a little cautious. We don't use efavirenz, but if it is used with efavirenz, DACLA dose has to be kicked up to 90 milligram from the usual 60 milligram. And if you are using with daclatasvir with atazanavir ritonavir, then the dose has to be reduced to 30 milligram. And SOF-VELPA does not go with either nevirapine or efavirenz. These are the common side effects, common drug-drug interactions that we need to look into. So to summarize, I would say that all people with HIV should ideally be screened for hepatitis B and HCV through serological tests. And if possible, hepatitis A should also be screened. Vaccination, we are discussing this issue since yesterday, that vaccination for those who are susceptible to HAV as well as HBV, they should be vaccinated appropriately, particularly adults. Because children are getting hepatitis B vaccination routinely as the immunization program. Prevention counseling is of utmost importance. HBV specific NRTI backbone is preferred in ART regimen, tenofovir, TDF, TAF, or plus either lamivudine or emtricitabine. HBV reactivation should be considered, and seroconversion should be kept in mind when there is a transient rise of HBV, the serum ALT. So before stopping ART, one should try to assess whether this is a case of seroconversion or not. Otherwise, it might be come back. And regarding directly acting antivirals has now made easy the treatment of like even for primary care providers can also treat HCV infection with guidance. Thank you for the kind hearing.
Thank you, sir. Can you take seat for the elaborate discussion on HPV, hepatitis B, C, and ART? And now we are running late. I request next speaker, Dr. Harshad. He will be telling about shingles vaccination.
Suswagatam, welcome Dr. Harshad Limye to ASICON 2026, Mumbai. A respected clinician from Mumbai, he plays a pivotal role in advancing adult vaccination strategies, particularly in people living with HIV and other high-risk groups. Today, he addresses shingles vaccination.
Hi. Good afternoon to everyone, and I thank the organizers for having given me this opportunity to speak in front of this crowd. I know this is the session on oncogenic viruses, but I'm going to talk about shingles and its prevention in immunocompromised individuals. So without much ado, we'll start. What is the impact of shingles on patients in general? That is what I will describe in the first half. Then we'll talk a little bit about the vaccine itself and the journey of the vaccine through its clinical trials and the approvals and recommendations. And in the third part, we'll just talk quickly about how you implement this vaccination in your clinical practice. So to begin with, all of us know that the entire population by around 50 years of age is usually infected with varicella zoster virus. And by that virtue or by that issue, they are at the risk of developing shingles in future. So primary infection with varicella virus, as all of us know, is it's chickenpox, and it is typically presents itself as a viral exanthem in the child. Then the virus gets latent and it stays in your dorsal nerve root ganglia. And at a later opportune moment, it will definitely reactivate at some point of time, causing herpes zoster, which is a dermatomal eruption. And 1 in 3 people in this world are known to reactivate during their lifetime, causing zoster. So what is the typical presentation? As all of us know, it is usually unilateral dermatomal vesicular rash, more often than not associated with excruciating pain. And apart from that, there could be various complications that can also come up with this shingles. The recurrence rate is typically documented at around 5 to 10% of patients. And the herpes zoster symptoms as well as its complications are known to be more prolonged as well as more severe in patients who are immunocompromised. What are these complications? Typically, post-herpetic neuralgia is the commonest thing, which is seen in up to 30% of people with shingles. Secondary bacterial infections are the next commonest complications. Herpes zoster oticus and herpes zoster ophthalmicus, all of us know how debilitating those can be. And then there could be some vascular complications in terms of stroke or myocardial infarctions in around 4% of the patients. Some neurological complications like encephalitis, aseptic meningitis or GBS, etc., in around 1% of the patients. So what is the incidence of this herpes zoster in general population level? Worldwide, we have figures of around 3 to 5 per 1,000 person years. But in India, we don't have population level studies, though we know that the incidence of this particular condition is quite high. And all of us keep on seeing these patients both in indoor as well as OPD practice. And comorbid conditions definitely do predispose to the present reactivation of zoster virus and the herpes zoster. So what is this immune compromised population? Obviously, I'm talking in the HIV conference, so human immunodeficiency virus is one of the major factors which can cause reactivation of this zoster virus. Along with that, some malignancies with their treatments, which are immunosuppressive, they can cause reactivation. Solid organ or hematopoietic stem cell transplant recipients are always going to be at risk for herpes zoster. And there are various other conditions, including even diabetes, which predispose for reactivation of the zoster. So how does it differ in immunocompromised set of people compared to normal individuals? The lesions can evolve over more prolonged period of time. They can be larger and numerous, and sometimes that they can even turn hemorrhagic. In addition to that, they can be multidermatomal and sometimes atypical distribution, which almost mimics varicella. All of us have always seen in these immunocompromised patients. The complication rates are also high. Pneumonitis, hepatitis, or meningoencephalitis, these are the common complications all of us see. Even post-herpetic neuralgia is more in immunocompromised people compared to the normal people. And they are also likely to develop recurrent herpes zoster more commonly as compared to the general population. These are the few photographs where the left side shows you the multidermatomal presentation, and then there is some the picture with the necrotic lesions on the right. They are really debilitating. This is one study mentioned in BMJ Open in 2018, which tells you about the population level incidence of zoster. And if you'll see the top column, top row, it will show immune compromised free cohort, where the incidence is around 6 per 1,000 person years. Go to the hematopoietic stem cell transplant population and the incidence jumps to directly 42. And then if you will see the renal disease or solid organ transplants is right up there along with HIV, where the incidence is almost double that in the general population at around 12 per 1,000 person years. If you will see this continuation of the graph, you will see that the percentage of people or the person year incidence in HIV is more common in younger age group of 50 to 64 that compared at with more than 65 years of age. With that background, I think we should talk about the vaccine itself. So Shingrix is a recombinant zoster vaccine. Earlier, a zoster live viral vaccine, attenuated vaccine was available. Since last 3 to 4 years in India, we have got this vaccine called Shingrix, which is a recombinant zoster vaccine. And it is typically used for patients more than 50 years of age in general population. And in some few indications, it can be even used for patients who are between 18 to 50 years of age. This vaccine called as Shingrix is made up of two components. The active component is actually glycoprotein E, which is the key antigen for viral replication. It is also a primary target for VZV specific immune response by the body, and it's wonderfully well expressed on the surface of the cells, most of the antigen presenting cells. And that is the reason why this is an ideal candidate to be one of the important components of the zoster vaccine. And then it is combined with an adjuvant. As always, we know that adjuvant typically what it does is that it induces a more lasting and robust immune response. And that is the reason why the adjuvanted vaccines fare better than the normal vaccines. So this adjuvant has got two parts, MPL and QS21, and individually each one of them will boost the B cell and T cell mediated immune response against the zoster. This particular vaccine was tested thoroughly in these two large pivotal clinical trials, phase 3 clinical trials. The experimental design, as you can see, was randomized, observer blinded, double placebo-controlled multinational study. They had two groups, ZO 50 and ZO 70. ZO 50 enrolled people with 50, and there were people who were more than 70 also in that group. And ZO 70 had people only who were more than 70 years. And both of them were given 2 doses of Shingrix vaccine, and then they were followed up for a period of time. And then the primary objective was to test the efficacy of this vaccine at the end of decided period of time. The intelligent thing that the trial people did, what they had a pooled analysis for patients who were more than 70 years of age. And so they could get more data and more smartly for people who were more than 70 years. And what did they find? The vaccine efficacy was found to be excellently in exceeding 95% in patients who were from 50 to 70 years of age. And when they got the data from pooled analysis for people who were 70 years or more, still the vaccine efficacy was seen at more than 90%. So these are excellent numbers as compared to the zoster live viral vaccines, where the protection rates were not more than 50 to 60% at best. Now, they also checked for the efficacy of this vaccine in preventing post-herpetic neuralgia, which also you can see is around 90% for both individuals at around 50 years of age or those who were even more than 70 years of age. And the complications of herpes, including zoster neuralgia, were also prevented with the efficacy of more than 90%. They did not stop over there. There was a long-term follow-up study which was done over a period of few years after having immunized these people along with the placebo for a long period of time. And they found that the vaccine efficacy stayed at around 85% at the end of 4 to 7 years. And the efficacy was still around 80% at the end of 10 years, which was not imaginable with the previous vaccine that was there. The efficacy would wane off in 3 to 5 years. Now, this vaccine at the end of 10 years, if it is giving 80% efficacy, that's the reason why probably the booster doses are yet not advised, and only 2-dose series, which is given initially, is considered to be sufficient enough. What about the side effects of the vaccine? Obviously, because it's a component vaccine, there are not many side effects except the local reactions, which you can see over here. And most of them being pain, redness, swelling, etc. And a few systemic reactions like fever, myalgia, headaches, and stuff like that, but nothing major. This vaccine then was also studied in some immunocompromised patients. To our interest, maybe we can talk about the trial which was done in HIV patients for the zoster infection, zoster reactivation, and autologous bone marrow transplant, because the only immunocompromised cohort where a vaccine efficacy was evaluated was the autologous bone marrow transplant recipients. Rest, all the trials, if you'll see in immunocompromised cohorts, these trials are meant for immunogenicity and safety. They are not efficacy trials. So quickly going through the bone marrow transplant autologous recipients, which was a placebo-controlled trial, it was 67.3% efficacy. So if you'll see, the efficacy in general population was 95%, in autologous bone marrow transplant recipients 67. But please remember, these are heavily immunosuppressed people with lot of immune dysregulation going on in their bodies, and 67% is not a bad efficacy at all to have in these populations. If you'll see, the grade 3 symptoms of side effects were hardly any compared to the placebo. So quite a safe vaccine, even in immunocompromised patients. Then we will talk a little bit about this trial, which was done in HIV population. So the background was, it was a phase 1 or 2A randomized controlled trial. Placebos were also involved. And then they were given 3 doses of zoster vaccine, recombinant zoster vaccine, instead of 2. Because the investigators postulated probably the response to vaccination may not be as appropriate with 2, and hence they wanted to give a 3rd dose also. So the doses were given at 0, 2, and 6 months, and then the immunogenicity as well as safety was recorded. So what happened is that, if you'll see, after the 2nd dose of vaccine, on the y-axis, you have the antibody titers against glycoprotein E, and those have a sudden jump as compared to what it was after the 1st dose. So the 2nd dose is acting as a booster. But when the 3rd dose was given, they transiently went up, the titers, but then eventually came down over a few months after the 3rd dose. And so a 3rd dose did not provide any additional protection. In cell-mediated immunity, which is obviously much more important arm of immunity against the zoster, if you'll see that the peak levels which were achieved for the cell-mediated immunity, again, were no better after the 3rd dose as it was after the 2nd dose. And so the 3rd dose was quite not mandatory or required as per the information what we get from over here. They also tried to check for the changes in HIV viral loads or changes in CD4 cell counts in various cohorts of HIV positive individuals in which this vaccination was given. And you will see that ART naive or those people with low CD4 or high CD4 counts, they did not have much change in their HIV viral loads or CD4 cell counts. So what was inferred was that it was a generally well-tolerated vaccine with no impact on HIV or CD4 counts in this population. And there were no potential immune-mediated diseases or fatalities which were noticed in this HIV cohort who was tested with herpes zoster vaccine. So with that, I think we will go to what all countries it is approved and recommended in. Our very own Indian subcontinent, it is possibly approved in all the countries. In India, the approval has come up in last 2 years. It's typically meant for people who are more than 50 years of age, and it's a 2-dose vaccine series to be given intramuscularly. And there are additional, so many countries who have included in their national recommendations. Not only the countries, there are various societies which have recommended this vaccine and used or endorsed the use of this vaccine, including the CDC, then Advisory Committee for Immunization Practices in US, ADA, GOLD, our country's very own different bodies like Association of Physicians in India, RSSDI, the Diabetic Society, Indian Society of Nephrology. And then there is definitely last year, the adult immunization guidelines which were released also have recommended the use of this particular vaccine in people who are more than 50 years of age, but people who are immunocompromised in that cohort, even more than 18 years of age, this vaccine can be used. So that is something which our guidelines have also confirmed. Going forward, I'll skip these few slides, which are not very important. There is something interesting that when should you give this particular vaccine in certain patients who are immunocompromised? Like for example, HIV, where we are talking that is it good to give this vaccine at any point of time after the diagnosis of HIV? So that's what the current recommendations are, that in HIV patients, you can, once you have diagnosed, you can give it irrespective of the viral load and CD4 cell counts. But some authors prefer to wait till the time you boost the immunity of the patient, get his viral load in control, let the CD4 counts rise above 200, and then you give the first dose of zoster vaccine. The only purpose being the patient develops an immunity which can respond to this vaccine, and the efficacy of the vaccine improves if it is given after CD4 cells count cross 200. Otherwise, the vaccine may fail. But finally, the people who are more who are having CD4 count less than 200, they are more likely to suffer from a zoster reactivation. So you have to balance your act between delaying the vaccination versus giving it immediately. As compared, as it comes to the other immunosuppressive therapies, generally we are okay to give this vaccine while people are on other immunosuppressive therapies, except two things, rituximab and steroids. So whenever somebody is on steroid dose, which is more than 20 milligram, try to get it down towards less than 20 or preferably towards 10, and then your vaccination efficacy and response rates will be better. Rituximab, please vaccinate only 5 months after the rituximab dose is given, last dose of rituximab is given. There are so many indications where we keep on seeing that, specifically neurological patients, I keep on seeing that they are giving rituximab every 6 monthly. So there may never be a period when you will get 5 months after the last dose of rituximab. In that case, it's advised that it is to be given 4 weeks prior to the last dose of, to the next dose of rituximab. What after somebody has already suffered from zoster? What do we do in those patients? So there are two thought processes. The American guidelines say that vaccination should be delayed until only the acute phase resolves, and after the acute phase resolves, you can go ahead and vaccinate people, because as you know, 5 to 10% people can have recurrence. The recurrence rates could be even more in people who are immunocompromised. Vis-a-vis Canadian guidelines say that you wait for a year, and because you already have some form of immunity, and so you can just give the second dose of vaccine. You will give the vaccination series only after 1 year is over, after the reactivation of zoster. What's more important here is that the maximum recurrences of zoster typically are documented after 1 year, but before the second year gets over. So that is the time when your herpes is likely to get another episode or a recurrent episode. So I would suggest that yes, you can give the vaccine at the end of 1 year, but don't delay it further. Otherwise, you might suffer from one more episode of zoster. That brings me to the last part. So how is the Shingrix vaccine given? It is a 2-dose series. It is given 2 months apart. And for the flexibility, it can be given even after, second dose can be given even after 6 months after the first dose. In case if suppose somebody cannot take that and he takes it at 8 or 9 months, currently we do not advise that it should be, the vaccine series shouldn't be reinitiated. You can just still give only the second dose. This particular vaccine comes as 2 vials. One vial is a powdered antigen and the second one is an adjuvant suspension. So you just dissolve the powder with adjuvant suspension to make a 0.5 ml solution and then give that intramuscularly. That's it. You can give the second dose after 2 months. Shingrix should be refrigerated, should be kept in the refrigerator, but you don't need to freeze the vaccine. Keep it at 2 to 8 degrees Celsius. And if you have reconstituted the solution, but there is a time gap of around 6 hours before you inject it, it's still okay. You can use that reconstituted vial for up to 6 hours, but not after that. It is meant only for intramuscular use. Shingrix is not indicated for the primary prevention of varicella vaccine or varicella infection, or it's not meant for prevention of chickenpox. Though there could be some interesting immunological phenomenon and certain clinical indications where people actually have used Shingrix off-label, obviously, for prevention of varicella infections. So maybe we can talk about it if we have time. But primarily, it's meant only for prevention of shingles and not for primary varicella infection. Can it be given with other vaccines? yes, influenza, pneumococcal, and Tdap, all three vaccines can be given along with this particular Shingrix vaccine. The co-administration is generally well tolerated. There are no safety issues and there are no immunological interferences. So with that, I think I'll stop here, and I thank you once again all for your time. Thank you. Thanks a lot. Happy to answer if any questions. I don't know if anybody has.
We have come to the end of the session. Online is there?
Shruti sir wants to ask.
Thank you. Thank you for your very nice, wonderful, elaborate presentation. You had mentioned that 3 to 5 per 1,000 patient years. Yesterday, we had the population of Mumbai city to be 30 million. So if you say 3 to 5 per 1,000 patient years, that means 3,000 in a million will get reactivated, which means 30 into 3, 100,000 persons per year will get reactivated. Are you seeing that many in Mumbai city?
No, sir, definitely not. I think.
No, I'm saying, why I'm saying this is, these are pooled data. Yes. You must present age stratified data. If you present age stratified data, it would be easy. Like, for example, when Dr. Kumarswamy presented total pool data, 1.7 per 1,000 person years, okay, then you can calculate, number one. Number two, they're preventing only post-herpetic neuralgia. Had any patients dying of herpes zoster? You know, nobody dies of herpes zoster reactivation. What I'm coming to is, your price is too expensive. If I have to give it for adults, if my wife and I have to get it, I spend 20,000 plus 20,000, 40,000. My wife also will have to spend 20,000 plus 20,000.
Yes.
That's, No, I'm not comparing. The best vaccine that has come out into the world, no doubt about it. And congratulations, GSK, for having brought it. I have no doubt about it. But I'm looking at the practical use in my HIV population. My population is 19 to 50. Yeah. Your data is 50 and above.
Yes.
So I don't know when to give that.
Yeah.
If I've got some money, I would first give for pneumococcus. I would give some for influenza.
Yes.
I would give some for, of course, Tdap doesn't need, because that's not a big deal.
Yeah.
But it's a wonderful vaccine. Yes. So thank you very much. And
Yes,
also to Dr. Guha, sir, one question. Now, if the world changes or the community practice changes to the dual drug regimen and tenofovir is eliminated in the dual, which of these tests would you recommend? I'm not, if I would to rule out HPS, that is hepatitis B. My teaching and my recommendation would be do only the HBS antigen, HBS antibody, HBC antibody. Only those three. I don't need to do HPE. I don't need to do HPV DNA.
To know susceptibility.
It'll add to my cost.
No, what I want to tell you, there are two issues. One issue is when you try to ascertain whether a person is susceptible to hepatitis B, there you look for surface antigen, anti-core total, and anti-HBS. Here you don't require E antigen or E antibody. But in a known case of HIV, HBV co-infection, when you evaluate them, you need to look into E antigen status and anti-HBE. Because unless you know if the patient is E antigen positive at the outset prior to initiation of treatment, whether is seroconversion taking place or not, that you can't document.
Because I only want to rule past infection also because
No, for past infection is not required, only HBC. At times you will find there are cases which are HBsAg negative, only isolated HBC total positive, may or may not be, the DNA may be low positive or may be absent also.
Good presentation. Actually, herpes zoster used to be a marker for HIV. Those patients who have suffered from herpes zoster, we used to do HIV. I'm seeing the HIV patient since last 30 years. And that we used to be more often correct than not that these patients were suffering from HIV. And those were asymptomatic mostly after that episode of herpes zoster. And rest of the presentation is good. Only one suggestion to you, don't call us crowd. We are not crowd, we are delegates. So don't use that word crowd. It is hurting to all of us.
I'm very sorry for that.
So we have come to the end of the session.
Thank you so much. I would request the chairs to please felicitate the speakers.
We now know how to deal with the smarter guys. Viruses are smarter and we need to be more smart than the viruses.
So we have one talk which was in this session, which was Dr. Franco. What we will be doing is we'll break for lunch. It's a online talk. So that talk will be played at 2:15 and the rest of the sessions can start at 2:30. So we'll break for lunch, try and meet at 2:15, hear Dr. Franco together and then get into our sessions. So the lunch is right behind here. It's not out. We did realize that it was really hot outside yesterday. So the lunch is all indoors and you can take your plates and you can come and sit here. I'll request Dr. S.N. Moti to please felicitate our chairs.
Suswagatam, welcome Dr. Franco Bamburo to ASICON 2026, Mumbai. An esteemed expert from Italy, he plays a pivotal role in advancing research and screening strategies for HPV-related and opportunistic cancers in people living with HIV. Today, he speaks on opportunistic cancers in PLHIV, anal, cervical and HPV-related cancers screening beyond guidelines.
Being with you in Mumbai, but unfortunately we had some problem in the flight for the flight. So my presentation will be on opportunistic cancer in people living with HIV, and in particularly the screening for HPV-related cancers. Okay, so this is a part of the screening of HPV related cancers in HIV patients is actually part of a larger program for the WHO, and in particularly is for the prevention of the cervical cancers, given that it is a very critical disease. It represents one of the most relevant cancers in humans. One woman dies of cervical cancer every 2 minutes, and cervical cancer is largely preventable and treatable when detected in early stage. Women living with HIV are 4 or 5 times higher risk of cervical cancers. And essentially, the HPV-related cervical cancer is highest worldwide attributable fraction so far reported for a specific cause of any major human cancers. And so this is why all the attention is on these cancers, which is the second one for incidence in women, but is the first one actually for mortality. So the global program of WHO is to get the 90-70-90 program, so meaning 90% of vaccinated women, 70% of screened, and 90% treated effectively with new treatments. And the targets for 2030 is a 90-70-30, where the 30 is 30% reduction in mortality from cervical cancer. At the moment, there is a very big difference among industrialized countries, Western countries, and middle or low income countries, in particular Africa, given that in the Western countries we are talking about an incidence rate of 4 for 100,000 women per year, and instead in low-income countries we can reach over 40 for 100,000 women per year. So essentially the final goal would be in almost 75 years to get all countries, including India and most of the Africa, below the 4 for 100,000 women per year incidence cancer. So most of the HPV related cancers are part of the opportunistic cancer that we observe in HIV patients, in both in AIDS-defining cancer like invasive cervical carcinoma and HPV, as well as in non-AIDS defining cancer for the anal cancer and head and neck cancer, both of them related to the papilloma virus. On these two types of cancers, we see a decreasing of the AIDS-defining cancers, the cervical cancer, and an increase in non-AIDS defining cancer, mainly the anal cancers. There are also cancers with no change risk, like for breast, colorectal cancer, prostate, and some with very elevated risk but rare, like the Merkel carcinoma. What are the factors contributing to the increase in cancer cases in HIV? The fourfold increase in the HIV/AIDS population because of patients living longer and not dying of opportunistic infection, but instead developing opportunistic cancer. The rising proportion of HIV patients over the 50 years of age, the cancer incidence increasing with age, the greater earlier start to smoking in HIV, and the major increase in some cancer incidents, in particular the anal cancer, with a frequency over 29 times. And so this is the situation that we knew up to the early 2000, meaning so the increase of the people living with HIV, the decrease of the AIDS-defining cancers, the increase of non-AIDS defining cancer, and so the overall incidence, which is in any case half of what we have seen as cancers in the early years of the AIDS epidemic. But what is the current situation? So we have a report from Italy, and this is a study published last year on a cohort study of over 17,000 people. Essentially what we see is that there is still higher frequency of cancers in the younger age. In later age, they are almost similar to the general population. And the increase of cancers is with age in male and in both in male and female. It depends on the CD4 counts, meaning that for people who have less than 200, the frequency of some of these cancers, particularly Kaposi sarcoma, but in general of all non-melanoma skin cancers, we have a very early increase when the CD4 counts are low. And this is the situation in different cancers, but in particular for the anal cancer, we see a major difference in the early age between the people infected with HIV and the general population. So the conclusion is that focusing on the virus-related cancer, they are all increased in the HIV population, and in particular, the one associated with the papillomavirus, with the penile, anus, and cervical cancers. Now, I should just remind you that the papillomavirus is a large family of DNA viruses. In particular, among the almost 200 papillomavirus types, 58 are related to humans or primate mucosal cutaneous lesions, articulated in 15 species, and the two major species oncogenic are the alpha 9 and the alpha 7. Now, in these tables, we can identify rapidly the 12 HPV genotypes at high risk, the so-called high risk, and which are part of the group 1 oncogenic agents for WHO, so the one which are related sufficiently proved related to cancers in humans. And then there are others with limited or even without any association factors with human cancers. This is almost 20 years old data from our laboratory, where there is a very peculiar report. So the HIV positive women, also for low risk HPVs, they show higher frequency of advanced lesions, showing that immunodeficiency is related to higher risk of progression even for the low risk papillomavirus. And this has been reported later from many other groups. So focusing on the seventh, with the higher seventh genotypes, papillomavirus genotypes, with higher association to advanced lesions and cancer progression. So these were the basis for developing the non-valent vaccines, which besides the 7 high risk include the HPV 6 and 11, the low risk papillomavirus. And this is to prevent mainly anogenital lesions and some oropharyngeal cancer. But the distribution is totally different, meaning that for the oropharynx, essentially we have around 10% of the cancers associated to the papillomavirus, mainly HPV 16 and 18, while for the genital cancers, we have higher association to the papillomavirus, but less stringency for the two genotypes, HPV 16 and HPV 18. And so this again is the different association of the papillomavirus with the mucosal human cancers. But now we are a little bit focusing on the oropharyngeal cancers, where we were discussing about the 10%, but actually in United States, for instance, is reported that over 70% of the papillomavirus-related cancers are involved with the oropharyngeal cancer. So the oropharyngeal tissues associated to HPV are gradually increasing. So how we are doing the screening? Well, the screening in generally was originally by cytology, the Papa Nicolau test, but more recently, molecular testing has been the prevalent testing for high and middle income countries with genotyping and further biomarkers like methylation and E6, E7 expression. And other screening strategies are based on the visual, like the colposcopy or the visual acid acetic testing. So the current frequency of testing is mainly for papillomavirus, and the papillomavirus by itself or the HPV testing along with the cytology will increase for HPV negative women up to 6 years of interval among the different testing. And this is also has been reported for South Africa, for instance, where Denny reported 73% reduction of cumulative incidence in women who were tested for the HPV. Now, what is the strategy for women living with HIV? Well, then in that case, if they are HPV negative, then the testing will be done obviously not at the 6 years that we are talking about the normal population. They must be more stringent. Also because, as I mentioned before, is not only the presence of the high-risk HPV, but we have to be sure that also other papillomavirus are not involved. But anyway, so if HPV is negative, then will be done every year, and then eventually, if also the cytology is negative, every 3 years. Otherwise, quindi will be done every year, and eventually, if it's a positive, the cytology and the genotyping for HPV, then the colposcopy will be performed immediately. Also for the presence of atypical glandular cells, in that case, independently, regardless of HPV test results, they will get colposcopy immediately, just because the risk of lesions, advanced lesions, is much higher. So something else that I would like to mention is the developing or the development of near point of care test. In this case, just to reduce the number of women that we lose during the screening, is that at the point of care can be performed genotyping with different machines. This is just an example, which will give the results in less than 60 minutes. And in that case, you can immediately verify with the good specificity and sensitivity, which is very similar to the hybrid capture to the standard of technique, so that you can immediately identify the HPV positive subjects. And eventually, with the automated visual evaluation, you can do at the same time, in the same place, also the verification of what is the condition by a methodology which is very similar to the colposcopy. We should not forget anyway that the preventive strategy for cervical cancer will always include the vaccination, which is necessary to complete all the prevention program which is supported by WHO. What about the anal cancer screening? Well, first of all, we should remember that the anal cancer, as for the cervical cancer, we have both the Bethesda classification and an histological classification with the low seal, high seal, ascus, obviously, and histologically the atypia, IN1, 2, 3, and Cs and cancer. The risk factors, especially for the people for the HIV, are the history of receptive anal intercourse, history of sexual transmitted disease, for women also history of vulvar, vagina, cervical cancer, anogenital warts, tobacco use, multiple sexual partners, low CD4, high HIV titer. The anal cancer is mainly at the squamocolumnar junction, which is a couple of centimeters away from the anal verge, and 85% of anal cancer are squamous cell carcinoma. The symptoms may include pain, anal leach, bleeding, tenesmus, ulcer, and the lesions can be also external, so you can see perianal cancer lesions which are visible outside. The progression is relatively with a high frequency, so in less than 10 years, you can progress from IN to squamous cell carcinoma. What is also interesting is that the rates of cancers is relatively low in the general population for the anal cancer, is below 2 per 100,000 women or men per year, but in people with HIV positive can be 46, so from 2 to 46, and similarly for positive women. But then for male making sex with male will go above 100 per 100,000 per year. Who must be screened? HIV positive, so this is very simple, above 30 years of age, any HIV patients with HPV-related anogenital abnormalities, and the people who are requesting the screening. So this was one of the previous one, but we should focus on the newly released screening guidelines. And in this case, independently from the screening program, which could be a cytological one, or can be cytological followed by papillomavirus triage, or HPV testing alone, or HPV testing with the cytology triage. So in any case, so as long as they are negative, then you can postpone. But if there is a positive, then it must be repeated in 1 year. And if the high risk HPVs is of type 16, then should move um, um, to anoscopy, high resolution anoscopy. And this should be done if the lesion is low seals every 1 year, but if it's high seal, should be done every 6 months. And if only after the two normal results, the high resolution anoscopy will be discontinued, and it would go back to the annual assessment. So in this case, we need to increase the frequency. So every time you see some positivity for HPV 16 in particular, and high lesions, then all the controls should be done every 6 months, and only following two normal results would be discontinued. Obviously, also for male, or in particular for male, the prevention should include the vaccination, just to increase the preventivity of the HPV-related cancers, and be able to achieve the elimination by 2060 of the HPV-related cancers strategy. I would like just to mention that in one of the latest articles on infectious agent cancer, our journal, we have emphasized the accuracy of a POC testing system for HPV screening and treatment. So this is our final goal, what is the global WHO strategy. And thanks for your attention, and I wish you a successful 2026 ASICON meeting. Thank you.
We request everyone to come back from lunch. We will be starting with the next session soon.
Hello. Welcome back. We're thankful that you're back for this session. And with that, we move on to our next session, which is next generation HIV care. The chairs for the session are Dr. S.N. Moti from Mysore and Dr. Sachin Kore from Solapur.
A very good afternoon, all of you. This is immediate post-lunch presentation. So let postprandial slumber not affect your getting to connect with this session. I think we are looking into the next generation of HIV care. The first presentation is a virtual one by Dr. Andrea from Italy, who's going to make a keynote presentation on HIV vaccines, broadly neutralizing antibodies and cure, hope versus hype for clinicians.
An internationally renowned expert from Italy, he plays a pivotal role in advancing HIV immunology, vaccine research, and cure-related science. Today, he speaks on HIV vaccines, VNABs, and cure hope vs hype for clinicians.
Thank you very much for inviting me. It's a very pleasure. I'm very pleased to be here with you, even if only by internet because of technical troubles that we had. In my talk, I will present some new data and some new ideas on the problems related to HIV vaccines, broadly neutralizing antibodies and cure for HIV, hopes versus hypes. There are many points for clinicians that must be taken into consideration. In fact, despite decades of efforts, we have no HIV vaccine which has a protective effect, and trials are not really enthusiastic. The presence of broadly neutralizing antibodies is important, and there is a major scientific breakthrough, but the clinical development is not fully reached, and there are many problems that I will try to show you in a moment. HIV is very diverse from the genetic point of view, and there are very rapid mutational capacities, so this is a barrier to the vaccine-induced passive BNAbs antibody protection. In fact, BNAbs antibodies can transiently suppress viremia and can delay the rebound, but there are no long effects about that. The combination with different BNAbs is a tool, but at present there are no indications that this works better than only one BNAb per time. RNA vaccines are interesting. They offer a renewed optimism, but current human data are very early phases and do not demonstrate the ability to induce a protection in a long period. There are many cure-oriented strategies, including the reversal of the latency, immune modulation, gene editing, but again, none has achieved consistent, durable remission. The reports of functional cure often reflect short-term post-treatment control, short-term, even if in this case, in our case, we have patients who have been treated for dozens of years and all works. The antibody, the BNAbs antibody may find a clinical niche in the prevention, especially if long-acting formulations are used, but again, the system has to become feasible and cost-effective. So at present, ART remains the only reliable, scalable, and durable therapy. Which are the mechanistic overview of current therapeutic strategies. Of course, we can have the combination, as I mentioned, of different BNAbs, as you see in the slide. We can have we can use RNA-based vaccines with different parts of the virus that can be immunogen. We can have different cure-oriented strategies, such as the shot and kill, on immune therapies, immune enhancement, gene editing, and so on. We have functional cure signals. Functional cures means that you can treat patients with R for a long time, then you interrupt treatment, but in most cases the treatment interruption has to be stopped and people have to restart to take drugs because of the again the virus comes out again. We can use BNAbs in the prevention of the infection, but again the problem is the escape of the virus to most antibodies that recognize different epitopes. And finally, we have the antiretroviral therapy, which is reliable, scalable, and durable. And this is done all over the world. But which are the problems with DNA or RNA vaccines for HIV or even protein vaccine? The main problem is that we have to target rare naive B cells that are responsible for producing antibodies in the blood, and these cells are very rare and not easy to reach. Second problem is the fact that these cells have to mature and origin plasma cells that produce BNAbs, which is again a main issue. We have troubles with the sequential immunization of people, so we can have different doses, different time periods, and this should lead to the maturation of B cells and to the hypermutation of antibodies that become more and more and more specific and with a high affinity for the virus. And this is a problem because it is very difficult to go in the real world and to have a good feasibility and scalability. There is a problem of the models. We have different human animal models against the virus, I mean HIV or humanized mice or humanized other rats and so on. But the problem is that the difference between men and animals is very high, is very strong, and we do not have the same type of response, even to the same kind of vaccination. Also in the real world, all attempts were not working well. So the first attempts with the GP120, then with viral vectors, and then with mosaic immunogens, I mean different, up to 60 different epitopes in one single molecule to induce a very strong and a very good immune response. But which are the promises and the constraints of the use of BNAbs? They should work, they work well when they are present and they can block the virus for a long time, but there are big problems with the manufacturing and the cost of the antibodies. There are problems with the insufficient half-life of these antibodies because they are rapidly degraded, and every 2 or 3 months you have to inject again the antibodies to the patients. You need a combination of antibodies to prevent viral escape. I mean, you need antibodies that recognize different epitopes of the virus, and this is not always feasible and quite complex from the technical point of view. And finally, we have to understand the viral sensitivity to the testing challenges and use assays that are fast, not expensive, and clinically scalable, especially as far as the sequence of the virus is concerned. So we should improve the access to all this kind of analysis. But which is the core barrier for the vaccination and also for the BNAbs? Of course, the mutational capacity is very high because the virus changes a lot. We have a global and intra-host diversity with different clades. We have a rapid replication and a continuous mutation of the virus, so this escapes to all the immune system products. We have several epitopes which are conserved among viruses, but they are very hard to access because of the presence of glycans on the surface, on the GP120 and so on. And finally, there are many, many unpredictable and unavoidable pathways of escaping from different strategies with vaccine or with BNFs. So actually, in this moment, the passive administration of BNFs can improve the viremia, can decrease the viremia, but again, as I mentioned, the suppression is only transient, and the virus comes out again, and it's very difficult to reach a long viral control. And there are several combination antibodies that are tried now in different trials. I mean, to use different antibodies against different epitopes. But again, the problems are those that I mentioned before, that is the logistical burden, the increased problems in the manufacturing, the costs, the variability in the virus, and the limited use of assays that are able to detect the virus, even in all the smallest and most, but not so evident, I mean, mutations. So which are the cure-oriented strategies? So we have the possibility to use reversal agents to induce transcription of the virus, but this does not work in eliminating cells. There are several immune-based interventions that lead to a transient control of viremia and an increase in the number of specific CD4 and CD8 cells against the virus, but the virus, the reservoir, can persist in immune-privileged sites. We have attempts on gene editing approaches. Promises and limitations are very great. I mean, the processes are great. We can cut and paste the DNA. We can do a lot of nice things with CRISPR-Cas9 system, but the delivery in vivo is actually very poor. We have to understand how to reduce the reservoir in order to have a functional cure. And in this moment, when you stop treatment, the reservoir starts to work and you have a viral rebound. The anatomic reservoirs are often very difficult to access and very difficult to reach with different drugs. And finally, we have a strong problem with the proliferation of target cells that can proliferate and replicate the virus if the virus is not blocked. So the point is that in the reservoirs, we can have the expansion of clones that maintain the reservoir. And which are the barriers? Again, as I mentioned, we have studies with a short-term suppression. We can reach a plateau of control, but again, if you stop treatment, you have to restart again the therapy. There are people who are, as we know, exceptional controllers of the virus, like long-term non-progressors or elite controllers, but they are very rare, and we have still to understand which are the genetic protections and which are the genetic reasons according to which these patients can control the virus for a long time, even without therapy. And then we have the problem of the reaching again the reservoir with BNFs, with vaccines, or with other methodologies. So the functional cure, we know that we can reach the control of the virus with ART. We know that exceptional individuals can control the virus. We have a delayed rebound, and there is lack of durable ART-free suppression across different individuals. So every individual that undergoes a sort of treatment interaction is different from another. So the personalization of therapies, the personalization of cure is absolutely important. And so ART remains the only reliable, scalable, and durable therapy. So we can have consistent, lifelong viral suppression. We can prevent the disease. We can prevent the progression of the transmission. We have now long-acting formulations that support the adherence. And finally, we can have superior scalability and cost effectiveness of ART in comparison with all other type of attempt of treatment patients. So ART remains the main treatment of patients. And with this, I thank you very much for your attention. I apologize for not being in India, which is a fantastic place. I really would love to have been there. And I say
Thank you, Dr. Andrea, for your insightful presentation. Are there any questions, any comments from the audience? And we know for certain post-COVID times has rekindled interest in vaccine research all over again. And of course, the science of broadly neutralizing antibodies is also adding up newer dimension to our thinking. And of course, the focus needs to be on eliminating sanctuary sites and see what extent we really can accomplish a functional cure. That was a very insightful presentation, Dr. Andrea, and thanks for being with us and sharing your rich experience to the August audience in ASICON 2026. Thank you. Now we can move on to the next presentation by Dr. Vijay Eladandi from Hyderabad.
Suswagatam, welcome Dr. Vijay Yeldandi to ASICON 2026, Mumbai. A distinguished clinician from Hyderabad, he plays a pivotal role in integrating holistic, resilience-focused models into infectious disease care. Today, he speaks on the salutogenic model of health in addressing infectious disease.
He's going to make a very interesting and insightful presentation on salutogenic model of health in addressing infectious disease. Let's also give a little thought. Salutogenesis in health and disease comprises of 3 M's: making sense of the illness or the suffering, manageability of the illness, and how meaningful and how resilience-full one has to be when you are confronted with an illness and needs to get treatment. And I'm very sure when we talk about the science of HIV, I think the science of and the art of resilience and coping up with illness, and I'm very sure the philosophical insight will be provided by Dr. Vijay Eldandi. Over to you, sir.
So good afternoon, and my apologies for not climbing up there. As you can see, I have some locomotor challenges here. So, here's something that I thought we should think a little bit about a slightly different paradigm of thinking about health. Firstly, how many of you have relatives, cousins, whoever, friends, who were thrilled when COVID hit and had a wonderful experience going to hospitals dealing with COVID? Raise your hand. Nobody? Me neither. So I mean, look at what happens. If somebody has a legal problem, they're going to call a lawyer. You want to build a house, you're going to call an architect. You want to fix your car, you will call a mechanic. You have a health problem, the first place you're going to go to the internet. And COVID, I think, was the greatest example of the internet being a fountain of knowledge and wisdom for everybody about everything. And I must say that during COVID, everybody who was a cardiologist, a thoracic surgeon, a gastroenterologist, you name it, instantaneously became an expert on COVID, and in particular, the very intricate and complex immunology and epidemiology of COVID. So here's the deal, so as we all are healthcare professionals, this is what we will be dealing with. The internet, neighbors, relatives, miraculous cures, drinks, TVs, newspapers, self-prescribed drugs, and finally the doctor. Okay. And here's another part of our great competition. This actually happens to be a chain of clinics. I was amazed when I went and asked them. They said, no, this is not a mom and pop operation. This is actually a chain of Ayurvedic camps, and they have an incredible armamentarium of all sorts of potions and concoctions, and they cure everything. All right? Whereas you know and I know that the average patient, if he or she has to go to any hospital, they are just petrified. Not only are they petrified, they're confused, they don't know what to do. And frequently it is a very, very, very bad outcome. So I asked myself, because I've been training people for the last 40 odd years, I asked myself, what's the problem here? Basically, it's conceptual. We are all trained to think about health in the pathogenic paradigm, which means that we make a diagnosis, we figure out what's gone wrong, and then we have to fix it. This is analogous to taking a malfunctioning machine, trying to figure out what component broke down, and either you repair it or replace it. Now, the problem is that humans and most biologic systems are complex adaptive systems. This is a cartoon that illustrates what a complex adaptive system is. Now, what that means is within that system, there are many, many, many different agents that interact with each other, and all of these interactions are nonlinear equations. And what you end up with is a system that you cannot properly analyze or in any determinative manner predict what will happen. So there's an input, but there's an output, and inside that entire system, all sorts of nonlinear equations are there, and what comes out can be quite unpredictable. Not only that, inside that system are what we call strange attractors, which are again things that exhibit nonlinear interactions with other agents and can be thrown off completely because very minor changes can result in huge changes in outcome. So that's what a human health system is. It's a complex adaptive system. So this is another cartoon that shows us, what happens inside, say, a cell. All sorts of agents are there. And if you like Stuart Kaufman's work, he says that the mathematical way to express what life is, it is basically an equation that is both autocatalytic and autopoietic. So it has the ability to catalyze its own reactions and it reproduces itself. That's what life is. It's merely a mathematical equation. Now, the problem with that thinking is that you would think that being mathematical, it is determinative, so you can predict what will happen if you knew the equation and you knew all the components of that equation. Unfortunately, that is not true of human health. So here is something that Hahn and Birch have proposed is a better model of thinking about how health happens. What they say is that every one of us is born with certain inborn attributes. These are our biological attributes that we are born with, innate. Now, of course, you could be born with congenital defects also. And as we grow up, we acquire more through education, through growing up, interacting with the environment, and so on and so forth. Now, at the end of all of these complex interplay, if this individual with the inborn attributes, plus the attributes that have been acquired through life, interacting with the entire environment, is able to meet the demands of their life, then they are at health ease. So I also like to ask people, think about the pathogenetic model. And according to the pathogenetic model, would you consider me healthy or not healthy? Raise your hands who think that I am not healthy. Remember, in the pathogenetic model, we look at what's wrong. Here I am. I had polio as a child. I'm paraplegic. I use braces and crutches to walk. So am I healthy or unhealthy? Raise your hands who think that I'm unhealthy. You're all kind of embarrassed, aren't you? You don't want to answer. Well, look at the Mykirch model. What the Mykirch model says is, as long as I am able, with all of my attributes, both inborn and acquired, able to meet the demands of my life, I have gone to medical school, I have trained as a healthcare worker, I'm standing in front of you and presenting a concept, I have a family, I'm a grandparent, I consider myself quite healthy. Thank you very much. So now let's look at what is the problem that we have with our conventional paradigm of looking at the pathogenic model where you are going to look at the morbid anatomy, the morbid physiology, make a pathogenetic diagnosis, figure out the mechanism of disease, and then think about how to fix it. This is the reason we end up with sick care and not health care. So the salutogenic model is slightly different. Remember, pathos is illness, genesis is the genesis or creation thereof. Salute is health, so salutogenesis is the generation of health. This is a concept first proposed by Aaron Antonovsky, an Israeli medical psychologist, because he studied women who had survived the Nazi concentration camps like Dachau, etc. And a priori, he came in with the presumption that any woman who had experienced the kind of physical, emotional trauma that you went through in a Nazi concentration camp would be so scarred for life that she would be completely dysfunctional. And what he found is that 1/3 of these women who had survived the Nazi concentration camps were not in any way disabled. They were spectacularly successful. They were great businesswomen, they were great leaders, they had accomplished much in life. So he asked, what is it that contributes to the success of this 1/3 of women? So rather than focusing on what went wrong with the 70% of the women, he said, let me now focus, let me turn this around and focus on the reasons for success. And what he describes is that all of these women had what he called a sense of coherence. What a sense of coherence means is that women, these women who had survived and were successful, had very good insight into who they are. What am I? If I know what I am and I can describe myself, I know my purpose in life, I have the ability to derive support from this structure around me, my family, my friends, and society. I have the capacity to cope. And once you have comprehension and the capacity to cope, you have the capability to have a purposeful life with autonomy and dignity. So when I was a young child, became paraplegic with poliomyelitis, the first thing my father told me is, don't wallow in self-pity, go out and conquer the world. So I'm here standing in front. That's the point. The point of salutogenesis is we focus on all of the attributes that contribute to people's good health. And health is defined as the ability to meet the demands of your life. The other thing that Aaron Antonovsky said is health is a continuum. It's not a binary outcome. You're not unhealthy or healthy, you're not diseased or not diseased. It is a continuum. And wherever you are at your stage in life, if you are progressing towards having a purposeful life with autonomy and dignity, you're on the right path. So as a practicing clinician, as a practicing public health professional, that's what I focus on. I ask, what can be done to help the individual, that family as a constituent unit of the community as a constituent of the society at large, and move them towards having a much more purposeful life with autonomy and dignity. So I'm pushing towards what is contributing to success, and I'm not bogged down by dissecting and doing postmortems on all the reasons for failure. So that is the beauty of salutogenesis. Salutogenesis can be applied to an individual patient, can be applied to a patient as a constituent member of a family, to a family as a constituent member of a community, to the community as a constituent member of society at large. You can apply it to health, you can apply it to organizational dynamics, you can apply it to almost any system that you can think of that exhibits complexity. It's a complex adaptive system because here you're not bogged down with what has gone wrong. You're not trying to dissect and analyze a malfunctioning machine to figure out what to replace and what to repair. You're focusing on the entire system as a complex adaptive system and trying to move it towards what we call health ease. Health ease means going towards a purposeful life with autonomy and dignity, and the converse of health ease is disease. So that is a salutogenic model of health. Thank you for your attention.
Thank you very much, Dr. Vijay Dandi. I think it was a huge round of applause. There is so much of positivity in your message that is conveyed to all the participating delegates today. Now I request my co-chair to invite the next speaker.
So it's now pleasure to invite Dr. Dev Taneja from Navi Mumbai to give the talk on digital health and AI.
Today, he speaks on sexual wellness initiatives or fast-tracking treatment, Swift Network.
Looks like I'm on the Eiffel Tower from here. Anyway, hello, sir. Good evening. Good afternoon, ladies and gentlemen. I'm Dr. Sam. I was enjoying the AI image that was projected on the screen. You know, everything happens to be, AI projected, and then later we come in person. I don't know which is better right now. Also, 15 minutes back, I was in a T-shirt and a tracksuit, going around and meeting people around. And my colleagues were asking, what happened to you suddenly? I said, Dr. Gilada and the organizers won't let me in if I don't come in a fashion parade, with fashion. But Dr. Gilada was, I met him on the corridor and he said, you must be presentable, be it with the condom or not without a condom. And with that, sir, I stand before you. Anyway, this is such a great pleasure to have doyens like Dilip Matai sir here and present in front of you, sir. And also all the other dignitaries here, the practitioners, the policymakers, and the other ones. I'm Dr. Sam. As I said, we work in the space of HIV only. It's an NGO. We are a 50-country organization based out of Los Angeles. In India, we have been working for the last 15 years. We have 2 clinics, just 2, but we have 4,000 plus clients, as we call them. We don't call them PLHA or patients because it's a service provider. As a service provider and as a taker, we call them as a client. It's a completely free service, everything right from condoms. May I ask my colleague here? I'll come back to that. But then this is free for uptake for anyone who would like to have this kind of installations in their clinics. And again, this is free, absolutely. This is made by HLL, who does Nirod and other, condoms. And again, extra lubricated because we work from Delhi and the temperature soar to more than 50 degrees and it gets dried up, sometimes. So extra lubricated, very much popular between our transgender and MSM clients. And this is given out free for anyone. Last year also I was here, holding up the same kind of kiosk. But then Dilip sir, our clinicians don't mind all these things. I'm so sorry to say this. They think they feel stigmatized, once we have everything in place but our experience with many people are like, they're very happy to have this. And then people just come there to even pick up a condom, if not a full consultation, but then come on. And then they are also lured by the counselors into coming and taking the services. But here today, I would love to talk about, I love to talk about, I don't know whether this is working, should be working, right? Yeah. So this is what we call as a SWIFT clinic network. It's basically sexual wellness initiatives and fast tracking treatment. That is the abbreviation and the expansion of the SWIFT clinic. The reason why we are all here is, one of the reasons is this. Obviously we know that there is a syphilis explosion that's happening. Even in India, we see a lot of cases coming up. As practitioners, we know that, that's been the case. And then what are we doing about it? So we have two clinics. One is at People's Clinic, New Delhi, and JCC, which is at Kalamboli in Mumbai. So anybody who wants to, let me just put it very frankly, that there is a private practitioner and there is a client or a patient, as we call them, who cannot pay for the ART or any test. I would love to have Sister Rania, Dr. Divya Mithel. Can you just please stand up, please? And these are our doyens here, Danshri, Kavita. Kavita, can you raise your hand? Yeah. These are our team from Mumbai. You can send those clients there where they'll be given free ART treatment, OI treatment, all viral loads, RM, all your regular medical checkups and CD4s and condoms, and also tested for partner notification, etc., etc., etc. So this is a completely free service. Please make use of those kind of facilities. I would request everyone to be there. But going forward, what is SWIFT Clinic Network? We are looking at, sir, I remember those days in Vellore when you used to say that the fraternity, without the medical fraternities, total medical fraternities involvement, we are not going to reach anywhere there. So that's exactly the point. I'm sorry to say that after 2005-6, we are still coming back to the same rant. Calling out on the other faculties of medicine, or the medical fraternity in total, saying that you need to be part of this, because the plethora of infections or, manifestations can be not cutting only with, dermatologist or venerologist or HIV physicians and the general medical practitioners. It goes beyond, as everybody knows. So that's what we are trying to do here. And with collaborative initiatives, making access to sexual wellness, important. Many of the times when we look at our partners, there are, Dr. Gilada sir, we have, with your help of people like you and, events like this, there are more than 1,000 doctors who have now enrolled in this SWIFT Clinic network. Probably we should have an official partnership with now IAS and then look at how we can take it up. The model is very simple, sir. Whoever it is, across the country, practitioners or hospitals, clinics, whatever be it your center where you give the care, if you find there are nuances wherein this person would be high risk population, sometimes it could be a transient, it could be an MSM. Sometimes in our initial mindset is to not to kind of okay, that is for SACS, State AIDS Control Society and the ART Center and the ICTC Center. But here there we come in between and say, you send us those kind of details through a helpline, and then we will link that client. We are not going to snatch that client away from, or the patient away from you. But then again, give it as an added-on service to the client so that, they don't become, still infectious and then not part of the ART regime. The other reason is also, we work in 9 states. Earlier, we were working in 21 states. The maximum number of people that have come to the ambit of testing services and the positivity, sir, is more than 1.8 to 2.5% in certain areas. And with regards to national prevalence, it is 0.20, as we all know about it. So how many times? It's about 10 times the infectivity or the prevalence that we are seeing in our own testing scenario. And then, when you look at that, we did a age related, variegated analysis, and we found that most of them are 51 years and above. Sir, the best part is that it's very good because India is still sexually active beyond 51. That's a good sign. But at the same time, these are all missed cases. late presenters, as we call them, right? So, and these people, when we do the FGDs or, in-depth interviews with them, they tend to say that, I've been taking my thyroid medication or my diabetes medication or my hypertension medication, but I've never disclosed that I'm a bisexual since my age of 11 or 12 to my physician. I'm afraid that I might not be entertained anymore. So such is the stigma, sir. I mean, I'm not accusing anybody sitting here in this august audience here, but the fact of the matter is, in the rural communities, it's still a very stigmatized kind of an environment, even with physicians and other people. So let's be the leaders to kind of see how we can address this. And that's why we are coming about, with this empathy, confidentiality, transforming sexual health, which is inclusive and should be stigma-free, education, etc., etc. I mean, I can add on so many. Meanwhile, we have the condom. And just to remind all the doctors, practitioners here, please don't shy away from, talking about condoms. I have a few Love condoms here. It's named as Love. It's one of the most popular condom here. With our, most popularly used by the transgenders and it's okay. Everybody can see. Say hi to the condom. Hi, hello. Okay, great. So first of all, I think, we need to sensitize ourselves, and I'm sure that, this presentation should not be taken as serious as the presentations in the earlier time in a scientific manner. But then this is simple things, solutions that we are trying to bring to people. This is again destigmatizing sexual wellness with our own people. These are our young boys who are from the gay community and who have been with us, and then now they are, fielding it. The very first free online condom store of India. I don't know how many people know about this. There is an online free condom store by AHF. We have constituted it. We support the state governments, NACO, sometimes when there is a stock out, and anybody can call in this number or put an email. But for those people who are not comfortable receiving condoms in their homes, give us your preferred address. I'll take an example. One young lady who is wanting to have sex and then wanting to protect herself might not be able to receive the condom in her home, but she goes to a salon or a parlor where she can actually receive it on behalf of the address there, and she can go there and get collected. Very simple. We don't want your names, numbers, nothing, but give us an address where a courier person can track it. It's absolutely free, no money involved. It comes as a Flipkart packet. It will be delivered across India. You can see how many touch points are there. These are, if you look at like a flight path, from Delhi to all these centers, it becomes, the India might not be seen there. So that kind of, condom demand is there from India, but, we are ready to kind of, give us this kiosks, which you can employ there. In Mizoram, Love Brigade, this condoms are called the Love condoms. And then, we partnered with the Taxi Drivers Association, Bikers Association, Auto Rickshaw Drivers Association. We put these, in packets, in jackets, and then made it out for public, who came there, and then no questions asked. You are you're a pillion rider there, you can just leave, take the condoms and leave. Access to condoms primarily. That is the most stigmatizing thing in places like Mizoram, where there is 95% Christian community, and also the church is highly against, I don't quote me anywhere, but then that's a fact of the matter here. So we do activations like that. You can see how many bikers are there, auto rickshaws, and auto drivers, and all these, different types of jackets for different days, different occasions. So what we're doing is like, we are trying to bring the access. There is our health minister, Shri JP Nadda, sir, visiting our moonlight testing clinic. It's a moonlight testing unit where, the testing starts only, sir, after 6:30 in the night, in the evening. And it goes till 11 o'clock, sometimes 11:30, 12 in the night, where we, put these vans, testing vans with peer educators inside, transgenders, IDUs, or even MSMs, and then get, the service to the workplace, as we call it, towards cruise points and bathrooms, ISBTs, parks, wherever sex cruising is happening. And the high positivity is a very high positivity there. These are models that we are trying to showcase for NGOs, for, I don't know if there are pharma representatives here, we don't want your CSR money, but you can implement this, with your own CSR money in the field, maybe if that is exciting for you. Likewise, can you just, who's the tech person here? Can you just play this? It's a short video, 1-minute video. Can you just play that? Okay, so this is called ASAP. ASAP is as soon as possible, but then in our language, it is assisted self-screening and assessment program.
कर सकते हैं HIV और सिफिलिस का टेस्ट। इम्पल्स न्यू दिल्ली लाया है ASAP असिस्टेड सेल्फ स्क्रीनिंग असेसमेंट प्रोग्राम, जो हमारे गे और MTH यानी MSM, ट्रांस और हिजड़ा कम्युनिटी को देता है घर बैठे टेस्टिंग की सुविधा। ASAP के साथ टेस्टिंग है आसान, मुफ्त और आपके अपने हाथों में। एक आसान सा फॉर्म भरें, हम आपके दिए गए नंबर पर कॉल कर अपॉइंटमेंट कंफर्म करेंगे। हमारे इम्पल्स बॉडी आएंगे आपके दिए गए पते पर और करवाएंगे आपका टेस्ट। आसान है ना? तो आज ही फॉर्म भरें और अपना टेस्ट बुक करवाएं। सेहतमंद रहे और हमेशा सेफ सेक्स करें।
Thank you. And this is basically an initiative called ASAP, pioneered by us, sir. And then we put these kind of small, short videos in social media, dating sites, especially of gay MTH communities. And then they pick up from there because we are employing people from the community as peer educators, as counselors, and as testers. And then when they develop a relationship after that, they kind of, converge to a common place or a comfortable place where, the person asks for a test and the impulse buddy, we call it as an impulse buddy. Impulse is nothing but our network of gays in our entire program. It's nothing, sir. I mean, the same old peer educator approach, but technically or, made into an electronic model with the social media involvement. So things like that we are pioneering. Yeah, future prospects, sir, expansion across India. I would definitely look at Dr. Gilada sir's, network of our, our brethren here or our, our faculty or our, fraternity here. And again, we can definitely see how this can actually help. So, okay, this is very important. This is coming up in big way in the social media. It says Ashwagandha and Shilajit makes your life very comfortable. I totally disagree. Ashwagandha and Shilajit doesn't make you, maybe it does have some effect, but without love, elevating safety with love condoms or without love condoms, this can be very, very bad. So, these kind of very small, advertisements and, clips that we send, trying to get the information across. This is our stall here. Thanks to again, Dr. Gilada and the Gilada sir and the IAS, fraternity here. This is us. Please visit us. You can see a beautiful lady over there. That's a program run by the youth, wherein we give them condoms to make fashion dresses and then destigmatize about condoms, sending the messages. I think my time is up. I'm just about to close. Scan here and scan there, and you can get the messaging across. Thank you very much. Any questions, sir? अभी है या बाद में है? Gilada sir?
After next presentation. All right. Dr. Dev is there. Yes, welcome, Dr.
Thank you. Good afternoon, everyone. Sorry, I missed my boat. And morning, I had requested Dr. Gilda to schedule my thing little last, and ultimately it has happened the way I wanted it. So one of the most interesting things which the medical world is right now curious about to know is AI. So I am presenting my presentation on this digital health and AI in clinical care. So what is AI? AI refers to the ability of the machine to mimic human cognitive functions, such as learning, reasoning, perception, problem solving, decision making, etc. AI in healthcare enables automation of complex medical tasks, assisted in clinical decision making, or enhances diagnostic accuracy in various domains. So AI in healthcare, it is not new. Basically, it has been happening since 1960s. But since last decade, the whole thing has picked up because of the advances in the AI technology, basically. the deep learning, machine learning, etc., and then transfer models which had come around 2017. But the major impetus has come after the onset of COVID pandemic, when large data sets of healthcare data sets were used to create AI solutions. So before going ahead, let us under few terminology. They may be new to most of the crowd here basically. And like you, some 15 months back, it was new to me as well basically. So there are some typical technologies and simpler to understand basically. So one is basically the types of AI. So AI is basically, one is a narrow AI or a weak AI. Here the tool or the AI solution, it works on a very one single topic basically, and a very narrow format, but it does not have a general reasoning capacity. The next point is basically artificial general intelligence. So here in artificial intelligence, what has happened? Here the machine or the computer can mimic the human behavior as good as any ordinary human being basically. So it is artificial generative intelligence basically. And the next level is artificial super intelligence. Here what they are saying is that if the progress of the machines or computing language keeps on going, these machines will become so powerful and they will be more intelligent, the best human brains on the earth. And this is one of the dangers which most of the rationalists, they are warning against basically. The next thing is basically term is natural language processing. So natural language processing is nothing but basically here the computer or that AI program can understand the human language and also can generate a human language, the outputs of the. So here the typical utilization in the healthcare are basically machine translation, information retrieval, sentiment analysis, information extraction, and question answering, etc. Simply put, basically what is NLP? So for a human, basically when we say hello, either you will hear hello or you will spell it HELLO. But for a computer, the same thing is 40 digits, binary digits basically. So each HELLO is represented by 8 unique binary digits. So combination of this digit is hello for the computer. So in this artificial intelligence, whatever input we are giving, that is as per our human language. The machine understands it and it creates outputs which are again human-like outputs basically. And now the generation part. So one is that how that machine can understand, so that technology has been taken on. Now how the artificial intelligence is used. So it is basically a generative AI, it is a subset of AI that learns patterns from defined data sets to create new contents like text, images, codes, audio, etc. basically. In medicine, they can be used for drafting documentation like clinical notes, summaries, referral letters, imaging report, preliminary findings from X-ray or CT scan, etc. Synthetic data, these data sets are used for our research work, basically. But one important thing we all clinicians should be aware of, basically human in the loop. So all the content from the AI should not be taken at a face value, basically. You should always verify before using it. So these are the various technologies. So you must be also these days on the TVs, videos, or newspapers. So you are basically getting name of this thing. So these are the foundation models, ChatGPT, which is everyone is aware of, Claude, Gemini, basically. But then there are certain specialists, medical specialists, solutions are also. MedFarm, it is good for accuracy for clinical QA. MedGema, BioMistral, it is for bioinformatics. And then there are scribes, Bhashini. It is a government of India's model basically, where translation can be done basically. The content can be multilingual basically. You can translate whatever content into any of those languages which are available under the Bhashini program. And then there are agentic AI workflows, which I'll explain a little later. So now earlier we had a traditional AI, and with advances, we have moved on to the generative AI. So this traditional AI is that part of narrow AI, which I had explained basically. So here the core function is basically there are defined historical data sets are available based on some, it predicts those values or numbers basically based on the historical data. The problem here, high precision is required for specific, high precision is available for narrow some limited task only basically. It cannot be generalized. It is rigid. If the data set changes, it will break down. While the newer form, the generative AI, here the core function is creating new original contents like text, images, code similar to the training data basically. Here it is a creator, versatile and handles ambiguity well, but there are risk of hallucination. So these are the various types of generative models which are used in the healthcare domain basically. So there are large language models which are text to text, summarizing patient histories, discharge notes, drafting insurance appeals, clinical QA using chatbots. Then there is image to text basically. So generating radiological reports from X-ray or CT scan, answering questions about dermatology images. Then there are diffusions and GANs basically. So they can read the MRI, CT scan. They can create synthetic images also. And for privacy preservation, you see that blurring on the images. So they help there basically. And biological sequence model, they are generally used for drug diseases, basically bioinformatics, proteomics, drug discovery, etc. Then there are speech model, audio to text and text to audio basically. So here ambient clinical documentation is used basically. Analyzing vocal biomarkers for disease. So few of my friends like they have come up with models where a baby, from the cry of that baby, they can understand whether that baby is crying because of hunger or it is a disease oriented cry. Then there are certain models available. By the type of the cough, they can tell whether it is a disease of the lung or it is a routine cough basically. And real-time consultation, translation, etc. And then there are the multimodal agents. So what are the agents? They are complex region, provide complex region across labs, images, notes, so various things. And then they can perform actions also. They are not like your chat basically, that is it. So they understand the context and then they create the workflow and then they will get to the next model basically. So these are multi-agent model basically, multimodal agents basically, and they integrate decision support or your clinical workflows. So those were the technical terms. Now it is the application of AI in our routine practice for doctors. So what is important? So there are tools which are like known as ambient AI scribes. So here the key benefit it transforming conversation into a structured clinical note. So when you are basically doing counseling with your patient, at the back end, this machine will pick up your discussion basically, and it can create structured clinical notes for you. One, it helps save time, but more important, completeness. It captures nuances and details often missed in manual recall basically. So they are very good AI scribes available for this. Then this is the most important thing as a medico basically, AI powered differential diagnosis. So here human in the loop collaboration basically. So first there is a human input. We provide patient history, symptoms, diagnostic reports and other vitals, etc. data to the machine basically. Then there is a digestion of that particular information by the AI and it processes that data basically. And then it creates differential generation. So what it creates based on the data which you have provided of the patient basically, it looks into the whole thing holistically. And then there is one term in this thing AI analysis which is RAG. So it will go and find from the literature review basically how to map this particular information which you have provided basically It is mapped with index journals, all published textbook, etc. And then it will come with the ranked differential diagnosis basically. And it also highlights basically a missing test or highlights what test needs to be done basically. But this is not the thing. Now comes the doctor's main role. He has to review the AI output. He has to use his basically clinical acumen. He need not blindly follow that. So that hallucination or other thing, what had those terms have come up. So many people these days, they are basically asking Chat GPT for basically differential diagnosis. Hallucination is basically the output is created, which the machine, it is not explainable, or it sometimes the output may be a wrong basically. But RAG, so RAG is basically retrieval augmented generation. Here, basically, with output, immediately the machine at the back end, it will refer to the index databases basically. Whatever is the published indexed databases across the world. And then it will provide citations, why I'm providing this particular solution. So those references, index references are also available to you. So you have to use those things. So doctor verifies suggestion, checks for hallucination and the context why those answers are given. And after that, final decision has to be taken by the doctor, not by the machine. So here the treatment plan is authorized by the physician. AI should be just used as a second opinion companion. You are the master, AI is not the master. So here, basically, generative AI is a tool to augment, not replace clinical judgment. Over-reliance on AI in output without verification can lead to diagnostic errors. Always maintain healthy, basically, overview on that whole thing. Then in medical imaging and radiology, here it can triage, suppose there are 100 X-rays available, it will triage, suppose 98 X-rays are okay, 2 are critical, then that radiologist can have to look at. It can create structured reports. Suppose now in this X-ray test, so analysis confidence is 98.4%, 2 are critical X-rays of all the set basically, and that draft reports are ready. Only the physician need to now verify whether they are there or they can change. So ultimately, the doctor is the master always. Now, pathology and histology. This is one very interesting thing. So precision diagnostic at cellular level with GenAI. So whole slide image analysis done here basically. AI scans the GICAS pixel images and grade severity. Example, Gleason scores basically. And then there is an automated quantification. Precise counting of mitotic figures, KI, 67 indices basically. So here, suppose in this case, this is a slide of AI invasive carcinoma, confidence is 99.1%, and QC status is passed. Now, we have been trained on this traditional analog images basically, but when we involve digital slides basically with AI, then that particular image is basically scanned and it is giving you KI 67 point. KI 67 count is nothing but the mitotic figures at the cellular level. So high KI count means basically it is advanced carcinoma. Then it can help in personalized treatment planning. Holistic data synthesis of the patient can be done. Patient communication output can be created in the language or the tone he understands or what you want to in the cultural context also, because there is I had earlier told there is a sentiment analysis basically involved. A tumor board report. So suppose now a case has to be discussed among various consultants. It can create a synopsis of those reports, basically the key points, and then board can decide on those things. And then it can even suggest treatment pathways based on that particular disease. But as a doctor, we have to now verify whether it is okay or we can overrule these things. It can help in drug discovery, can help in clinical trial design and patient mapping. And this is another important predictive analytics for patient outcomes. When I went through all the topics for this conference, so I understood that there are challenges in treatment of that AIDS also. So here it is a hybrid model, what's and the why. So traditional machine learning model, it is saying there is a 85% chances of that patient will be getting readmitted. But then there is a generative AI level which creates the rationale why that particular 85% readmission prediction score. So here on JNP, they understood that patient is missing his drugs basically, and there is a weight gain of 1.5 kg. It means it can be case of congestive heart failure early stage. And it suggests basically schedule a teleconsult for diuretic review. It can help you with virtual assistant also, so you can coordinate with your patient 24/7. Surgery planning, basically you feed the MRI or the CT scan, it creates a 3D model and it suggests you the best part to avoid the vessels, and robotic surgery can be safely done. And at the end, it will create documentation based on that imaging bit which is created during that robotic surgery and the voice command being given by the doctors during that surgery basically. So it can create your notes also. This is the interesting thing now where the healthcare and AI is moving. Convergence of multimodal AI. So in future, there will be fusion of the radiology, pathology, and genomics. So why are tumors like different on MRI? Because of its cellular structure driven by genetics. And AI connects these dots basically. So the human in the loop. So in the future, basically, most of our cases, they are of routine type. Here it helps you to basically autonomous filter basically. But then in our practice, we know we get complex or ambiguous cases. Here AI helps us with their differential diagnosis basically. So in future, what is going to happen? The future of diagnostic is not artificial intelligence versus human intelligence, but a convergent intelligence. So here in the future with various history data and your diagnostic report, there will be convergence. Multimodal is the future and physician role is the pilot and integrator basically. So now it will be parallelly happening with you. You can get it immediately when you are practiced like a decision making basically. But most important now, that is this part now, what important part as a doctor. So hallucination, I have already explained. Then we have to understand from what is the data set being used, whether they were ethical, bias, fairness has been taken care of. There has to be clinical explainability on that output, basically. Clinical validation, so accuracy and patient safety concerns are there. And AI tool performance drifts over time. And prompting and reprompting. So prompting and reprompting is basically when you in the chat bot or wherever you prompt. So it is like a discussion with your colleague basically. And whatever output comes, you if you're not satisfied, you ask the same. But my only suggestion to this crowd will be basically, instead of having ChatGPT, go for tools like Elsevier Clinical Key AI basically. So it will provide you output with citations and proper references you go through. If you feel these are not right, you can re-prompt and try to get better answers as per your requirement basically till you are satisfied. So don't blindly follow their outputs. Why responsible and trustworthy AI is required in medicine? Due to black box nature as also. Doctors are accountable. AI is not accountable for patient care. Anything goes wrong, it is doctor who will be responsible. Explainable AI, whether AI tool perform as per accepted clinical practice guidelines. And you have to use, so every apps, now everyone is getting that fitness apps. They are not medical devices. Medical devices are which are registered with CDCO. So we have our medical devices are regulated. So this is a software as a medical device, whatever software. Clinical validation, so it has to be based on the clinical trial studies which are approved by AI ethics committees. You have to apply your clinical acumen while using AI out. So human override is acceptable. There's nothing wrong. It's not a, you have to accept whatever is coming. And report AI tool output if the output is inconsistent or they compromise patient safety. Remember, AI don't treat, it is doctor who treats. Now coming to this conference basically.
So Dev, can you quickly summarize? I think we can take some questions and inputs on
Yes.
the interaction.
I'll require some, if you allow, permit me, 2.5, because I like to some 3 or 4 slides, my experience with AI, which will be helpful to the audience if you permit. Otherwise, this is the last slide from my side. I am giving you its choice basically. My request, I want to show how I have used as a IA in medicine trained doctor basically.
Because we have some more
No problem.
presentations to
No
follow.
problem.
I think we can take some
No
inputs
problem.
and comments. I think
No problem.
the organizers would like to.
So this is the last slide.
Okay.
For everyone, it will be now how to get trained. So these are the free courses which are available online. And for foundation courses, doctors say you can take a photograph of this and you can add this. Thank you. Sorry.
Thank you, Dr. Dev. I think giving a overview about AI, its implication, and how doctors can effectively make use of this. And then Dr. Sam is here. I think now a few questions or comments about the last 3 presentations. Dr. Vijay Eldendi, Dr. Dev, please come this side. Is there? Okay. No, no, I think I just tell, he's asking how one can become a member, enroll in the membership. I think. You want the last slide to be?
I'll just slide there.
Okay.
So you can scan that image. So you can become the member of Indian Doctors AI community. And what we are trying to do is basically, one was the generic AI courses were conducted. Now, what is our endeavor is to improve clinical literacy, AI literacy amongst the medicos and AI advocacy. And we want, like in every clinical specialty, then build their own champions within that. So last year we have started Doctors AI courses for critical care. That is a new course. So all those intensivists and other people in critical care, they have joined hand and they are contributing it. But we want all other clinical specialty also to come forward and enrich their own fields basically by use of AI.
The whole thing is evolving big time. I think in course of time to come, I think we'll have more and more opportunities to get more educated. I think once get into it and then probably be very sure where exactly and how exactly you utilize AI as a contribution. I think we henceforth call not just AI, we call it augmented intelligence. And like now, we are probably likely to be in a time of artificial super intelligence. Time is likely to be around the corner. I think if there are no further inputs, comments, I think I profusely thank Dr. Dev, Dr. Sam, Dr. Vijay Eldendi for having made some very good presentation on behalf of my co-chair, Dr. Sachin Kore. We thank the organizers for having given us this privileged opportunity to chair this session. They will be available for you to interact during tea time. Please make use of your presence. Thank you.
Thank you so much for that wonderful session on next generation HIV care. I would request the chairpersons to felicitate our speakers. Dr. Sam, are you around? Yeah. In fact, we can all come down and do it so that we can also felicitate Dr. Yeldandi. And I also request Dr. Satish Rao to felicitate our chairpersons. Dr. Satish Rao. we feel ready to go into the next session right away? Yeah, we'll do that. The tea will start in 10-15 minutes and there will be snacks. So we can go and take tea and then come back. But we'll jump into the session right away. I think JW has fed us very well through the day anyways. So we'll move to our interactive clinical discussions and discuss some nightmare cases. For this, I'll call Dr. Kharkar as the chair, and Dr. Vijay will also be the other chairperson, and so you can continue to be where you are. The prompt to AI was minus 20 years.
Well, good afternoon and welcome to this very, very interesting session on interactive clinical discussions, nightmare cases from real practice. All of us who have been working with HIV right from the time it began, all of us know that this particular branch has been a very challenging branch right from the time it started. Right, the challenges were from diagnosing the cases, treating the cases, diagnosing opportunistic infections, treating and managing them, and having new cases coming to us with such complications where we have to really use our brains, use all our experiences, and definitely we try to give the best to the patients. So without wasting much time, I would like to call upon Dr. Kavita Joshi, Mumbai, navigating hepatotoxicity in HIV care. Dr. Kavita.
Suswagatam. Welcome Dr. Kavita Joshi to ASICON 2026, Mumbai. A leading clinician from Mumbai, she plays a pivotal role in managing liver-related complications and ensuring treatment safety in people living with HIV. Today, she speaks on navigating hepatotoxicity in HIV care.
Good afternoon, everybody. Today we are discussing navigating hepatotoxicity in HIV care. On the onset, I would like to thank the organizers for giving me this opportunity to speak in front of this learned audience. So let us go into the first case. So I had this 59-year-old man who was regularly following up in my ART center. He had known case of HIV since last 10 years, but only on therapy since last 4 years. This was the time when the patients were like on tenofovir, lamivudine and efavirenz. And there was a time when the phasing out of efavirenz was going on. So this patient got shifted on tenofovir, lamivudine on dolutegravir since last 6 months. He was recently diagnosed, then he was diagnosed as tuberculous pleural effusion. Patient was started for AKT for the same. He was started on 2 HRG and 4 HRE daily regimen. He was continued to follow up in ART center. He was actually a businessman and little bit of gentleman who used to create lot of. He used to complain and create lot of fuss. So he came for the follow-up, and this was the first follow-up after the ART AKT was started. His hemoglobin was normal, his SGOT was 100, SGPT was 110, total bilirubin was 1.9 and 1.3. All the other investigations were normal. His viral load was not detectable and CD4 count was 554. I told him, you're fine. You can follow up on OPD basis. Let us repeat this LFT again next week, because this LFT was done 3 to 4 days prior to coming here. So by the time he came to report, and he did not have any symptom whatsoever, no symptoms. So I said, let us follow up with LFT. He said, no, admit me. I want to get admitted, you admit me. So I admitted him in my medicine ward. And because he was admitted, I said, let us stop antitubercular treatment and see what happens. Then the patient was screened for hepatitis B and hepatitis C because LFT was getting deranged. Day 3, the LFT was settling down, 80, SGPT 120, total bilirubin was coming down, alphas was fine. Patient was seemed symptomatically better. We were started thinking, why did we stop AKT? Now let us restart. When to restart? Day 4, patient said, I am having nausea and vomiting. So then LFT was repeated on day 5. It was again rising. Like now patient was off ART since almost 5 days and the LFT was rising again. The repeat SGOT was 600, SGPT were 450, bilirubin had gone to 7.5, direct was 4.5. HBV DNA was done at this level, so it was negative. We had stopped ART at this particular point of time. This was my first experience with dolutegravir. That time we had not much had experience with dolutegravir. Day 7, the SGOT rose to 1,200, SGPT rose to 1,123. Total bilirubin has reached to 14 and direct was 8.5. This patient's relative was a 22-year-old young son who every day used to meet me on rounds and used to tell me what is happening, what is happening. So patient remained in our ward for almost 25 more days. The LFT kept on deteriorating. The patient kept on deteriorating. And he further developed acute hepatic failure, DILI, and repeated gastroenterology references were done at this point of time. They said that no, you have to go for conservative line of management. We shift the patient to MICU. Conservative line of supportive line of management was done, but the patient succumbed to acute liver failure. Basically, no hepatotoxicity in HIV can be discussed without AKT-induced hepatitis, but this particular patient has remained with me for many years now because AKT was stopped in time and the patient was admitted. Actually, early admission was done for this patient. The LFT was hardly deranged. AKT was immediately withdrawn and even the dolutegravir was stopped almost within 5 days. This patient, we could not save this patient. This patient has remained with me and the 22-year-old son used to keep on entire 1 month. He kept on coming to me, said that do liver transplant, do something for my father. This patient was somebody who had followed up. He said, admit me. I don't know whether he thought that something was going to happen. He said, admit me. I don't know. Admit. So this was one case where this was my first experience with the dolutegravir induced hepatotoxicity. But how do we deal with hepatotoxicity? So if it is 2 times to 3 times upper limit of normal, you can observe the patient. By 2 times, you can stop the treatment. I stop the treatment by almost, it goes to 2-3 times. I stop the treatment. I observe the patient. I usually always I tell the patient to get admitted in my ward and for observation, and we'll see and we'll re-challenge. I always tell my patients. Mostly the key hepatotoxic AKT drugs, as we all know, we all have treated AKT-induced hepatitis all our life. So pyrazinamide, isoniazid, rifampicin, these are the more hepatotoxic drugs. Ethambutol and streptomycin are rarely hepatotoxic. So this was one patient where AKT was withdrawn in time. Dolutegravir was also withdrawn in time, but we just couldn't save the patient. Maybe if there was a pharmacogenomic studies were available, we could have known that with this patient had vulnerability towards developing hepatotoxicity and we lost the patient. So this is one study which I had done with my ART center where we studied 319 hepatotoxicity patient with total patients who were studied. Out of them, out of 319, 48 patient had LFT derangement. There was no gender bias. The patient were between the age group of 41 to 60 and 11 of them, almost 3.4% required the change of ART and I changed to LPBR. So somehow in my practice in KEM hospital, we are seeing a lot of dolutegravir induced hepatotoxicity and I need to change the drugs. So with this, we'll come to a second case. A 21-year-old boy who was recently diagnosed with RVD 7 months back. He was first started on tenofovir, lamivudine, and dolutegravir. Tenofovir was stopped later on because, and it was switched to abacavir because the patient had developed nephrotoxicity. After 2 months of ART, the patient developed pulmonary tuberculosis. He was sputum AB positive, low rifampicin resistant. This all was happening outside. The patient had not come to us by now. He was started on HRZE. Day 40 MG report came. INH resistance was seen and rifampicin resistance was seen. He was started on B-PAM regimen for 7 days. While he was started on B-PAM regimen, this patient started having high-grade fever. There was no diurnal variation, there was no chills. There was it was relieved with antipyretic medications, and he had 10 days of history of fever. This is where this patient came to me. So the patient was a case of sputum positive MDR TB. He was previously treated by drug sensitive AKT since last 6 weeks, and he had now on all oral short regimen. The rash was maculopapular, and it was pleuritic, and it was centripetal. This was the rash with which the patient had come to us. By day 3, 4, the patient started having these commissions. There was a peeling. This was day 10. The patient started looking like this by day 10. The labs were done by that time. For hemoglobin was normal, eosinophil was 3%. Total Vili had gone to 13 and 9.8. AGOT, AGPT was 350 and 385. INR was 2.1. Ammonia was rising. A patient was HIV positive. Patient was also HLA was done. It was already done from outside from private setup where he was put on abacavir. So HLA was already done. Patient CD4 was 115. Viral load was target not detected. ANA was negative because he came with a fever and rash. Even ANA was the ANADS DNA was done for this patient was negative. At this point of time, when the patient presented to me, I thought whether this was now iris. Patient must be having pulmonary TB as iris, and viral load was target not detected. Patient was hepatitis B because the LFT was deranged. Again, we screened the patient for hepatitis B and C. The patient came with fever with rash. So fever with rash, we screened the patient for all fever profile in our setup. So dengue, malaria, leptospira, everything was screened. Patients AKT and ART both were stopped at this stage when the patient presented to us with the rash and everything, because we did not know what was happening. At this stage, again, we also thought in terms of abacavir induced hypersensitivity also, because patient came with fever and rash, although patient was HLA negative. So, but then in spite of that, I thought that whether the patient is having abacavir induced hypersensitivity. So we were thinking iris, abacavir induced hypersensitivity. So ART and AKT both were stopped. This was the reports of the patient while he was in our ward. Patient remained with us almost for 1.5 months. The TB went to 13, say it went to a maximum up to 20, and then it started coming down. Then AGOT, AGPT also went up to 400, then it started coming down. Hemoglobin was normal. WBC counts were in range. But there was a eosinophilia. The eosinophil 3%, it went to 6%, and then it went to 22%. So at this point of time, anybody wants to take a yes, Rett syndrome. So this was a drug-induced liver injury with a Rett syndrome, in a case of pulmonary drug-resistant TB with HIV, query iris, and to also still at this point of time, abacavir-induced hypersensitivity also remained at the back of my mind. So how many of us really think if you have any experience with abacavir-induced hypersensitivity? Any clinicians? Sir? Could I have thought about that also? Negative. I have had another patient also when HLA was negative and the patient had developed abacavir-induced hypersensitivity. So total of at least 2 patients which I have seen that they have developed the hypersensitivity. So the diagnosis of drug-induced liver injury was done in this patient. So what is a Rett syndrome? It is a severe, potentially life-threatening drug hypersensitivity reaction, which is characterized by fever, widespread rash, eosinophilia, lymphadenopathy, and multiple organ involvements, liver, kidneys, and lungs. Typically, it is 2 to 6 weeks after drug. Now, in this particular case, the patient was exposure to first line ART, and the second line ART was just started, hardly any 7 to 8, and before that he started having fever, and before that he had rash. So the culprit in this particular patient seemed like the first line ART more likely than the second line because it was just started. So although second line ART is more frequently implicated in Rett syndrome, more linezolid is supposed to be the one of the commonly reported culprit for Rett syndrome. Clofazimine, cycloserine, ethionamide, fluoroquinolones, and bedaquiline can be the other culprits. The first line drugs are rarely implicated. Standard management protocol calls for Rett syndrome is you have to stop all the drugs, provide supportive line of care. Reintroduction protocol in this particular patient, it could have been rifampicin, isoniazid, ethambutol, and then pyrizinamide. Wait till the complete recovery. Avoid the if we have found out confirmed the culprit drug, then we can permanently stop the drug. Corticosteroid use is controversial. You can use you can use it, but it is controversial. It has to be used with caution. This particular patient got better and went home. After 1.5 months, the rash was still there. There was a lot of hyperpigmentation, but patient's LFT had normalized. The patient had no fever. Patient was already HIV-wise, the patient was doing very well. So we put him because his hemoglobin was fine. Then we put him on zidovudine, lamivudine, and dolutegravir. Further, the patient went to pulmonology where they continued with a long oral therapy in view of whether the first line, the BPAM therapy was the culprit. So they continued with the long oral therapy in that particular patient. Let us come to our third case. Dr. Guha has very well discussed the management of hepatitis B. So now I would like to just show you one more case, which is currently in my ward, currently following up on OPD basis with me. This particular patient is a 30-year-old male. He is an office worker. He is a social drinker, 1 to 2 drinks per day. 5 years ago, he was diagnosed with tenofovir. He was diagnosed. Then since then he's on TLD. Patient CD4 count is 520. Viral load is not detected, and patient is at the time of diagnosis, the patient was given HBV SCV screen, so it was screened, it was negative. Patient came as a routine follow-up that coincidentally in that particular report, the ALT was 3 times on the upper limit of normal. Then on asking, he said, हाँ थोड़ा सा तो थकान महसूस होता है, but other than that, he did not have any complaints. There was no HBV vaccination previously. He was not an IV drug abuser. There was no history of transfusion. So the key diagnostic, we went on to do HBsAg screening again, which was negative. But anti-HBs total was positive. This patient again anti-HBV DNA PCR 1200, HBe anti-HBe negative and positive, and ALT AST later on was like just 2 to 3 times of the upper limit of normal. This patient was referred to our GI medicine. The fibroscan was done for him. That it showed 7.2 at the fibroscan. Okay, so this was a patient of occult hepatitis B infection, wherein why was it he missed? He must have been, maybe he was hepatitis B positive all these days, or maybe this was just a flare because of something. Maybe there can be a multiple reason why HBV flare happens in this patient, but why was it missed? So HBsAg alone, we screen the patient with HBsAg alone. If there is no indication, we don't do anti-HBc. As it is not available in government and medical colleges and municipal hospitals. It is not available. So what we learn from this patient is that if there is any chance that you are suspecting occult hepatitis B, anti-HBc or the core antigens or core antibody or HBV DNA can be done for screening of this patient. Just data where how much occult hepatitis B infection is there. Around 1% of the patients globally, they say that there can be occult hepatitis B infection. 80% of them get missed at the start, on the onset, and maybe this patient for 5 years. And as we know that if there is occult hepatitis B and there is viremia, both the diseases are known to deteriorate each other, and that can also precipitate towards SCC predisposition. So what is our challenge? The main thing is co-infections, then risk of drug-induced liver injury, also the impact of alcohol consumption and nutrition in our country. So how, and just on mention about metabolism dysfunction associated steatohepatic liver disease. This is now considered as is emerging as a dominant underlying liver vulnerability that amplifies drug-induced and immune-mediated hepatotoxicity. So we have to screen our patient for this, because if it is there, they are going to be more prone to hepatotoxicity in HIV and the heart drugs. So how can we manage? Pharmacogenetics can help. Another thing is newer ART regimens which are coming are lesser hepatotoxic, so that is also helpful. Also, advanced monitoring, taking the non-invasive monitoring technique like FibroScan, Fibro5, and integrated care models with hepatologists can be useful. And that was my last slide. Thank you for your patient listening.
Thank you, Dr. Joshi, for that excellent case presentation. I now call upon Dr. Nitin Karnik from Mumbai, and he will be tackling on Mind the Kidney.
Good afternoon, everybody. I would like to start by thanking Gilada sir and Trupti for giving me this privilege of talking in front of such an august audience. What are the risks to the kidney in PL-HIV? They can be because of the HIV itself, that is HIV-associated nephropathy called as HIVAN. It can be because of HIVIC, which is HIV-associated immune complex renal disease. It could be CKD because of age-related comorbidities like diabetes, hypertension, IgD, dyslipidemia. Polypharmacotherapy, including impact of heart on kidney function. But please don't forget that in India, we have a lot of, especially during the acute febrile illnesses of the monsoon, we have malaria, leptospirosis, and dengue. And as they affect us, they will also affect our PL-HIV. And with increasing longevity, CKD is slowly tending to become the leading issue. So let's start with the first case. This was a 45-year-old woman, known case of HIV since 15 years, on TLD since 2 years, compliant. Her CD4 count was 402. She had 1 week of nausea, vomiting, acute onset of lower limb weakness followed by upper limb weakness. So acute onset of quadriparesis. When she got admitted, her single breath count was 18, because below 12, then she'll go on a ventilator. Respiratory rate was 18. Vitals otherwise stable. Grade 0 in the lower limbs, grade 3 in the upper limbs. The planters were 0. Tendon reflexes were 1+. So any guesses as to the diagnosis here? Acute onset of quadriparesis. Yes. So potassium, the resident from MICU rang me up, sir, her potassium is 0.9. Once I saw that 0.9, I said, be very careful. She's going to be a proximal renal tubular acidosis. And there it was. On ABG, you can see a pH of 7.319. So there is metabolic acidosis, but the anion gap is 11. So this is a normal anion gap metabolic acidosis. Her spot urine analysis showed an anion gap of 16. So she had a positive urinary anion gap. And if you see the other reports, she has hypocalcemia, hypophosphatemia. Her HbA1c is 5.5, but she had a 3+ urine sugar. So this is a classic. This is a ECG which showed U waves. So there the diagnosis is that this is a classic Fanconi syndrome, a hypokalemic quadriparesis secondary to proximal RTA. And then the residents are telling me, but sir, she is taking TLD for so many years. But this is the evidence. We have case reports of hypokalemic periodic paralysis secondary to tenofovir-induced Fanconi syndrome and reported from various parts of India. So how does this occur? TDF is transported into the proximal tubule via OAT1, but exits into the urine via MRP4. If the exit is blocked or the entry is excessive, TDF accumulates in the mitochondria, mitochondrial DNA depletion, respiratory chain dysfunction, and proximal tubular dysfunction. Clinical marker, Fanconi syndrome, normoglycemic glycosuria, phosphaturia, which can untreated can lead to severe osteomalacia. There's bicarbonate wasting. And you have a TAF advantage. The tenofovir alafenamide provides 90% lower plasma levels, sparing the transporters and significantly reducing the renal footprint. So Fanconi's can be genetic or acquired. Now in HIV, a paraproteinemia related to occult, a lymphoproliferative disorder can be a cause. Aminoglycosides, cisplatin, tetracycline, valproic acid, all are implicated. Amongst antivirals, tenofovir implicated, and especially if used concomitantly with ritonavir. Why? Because ritonavir is predominantly secreted via MDR2. Ritonavir inhibits the multidrug resistance 2 protein, leading to accumulation of tenofovir. Now, our patient has developed Fanconi after receiving tenofovir ART for years. And IDSA guidelines recommends discontinuing tenofovir. And here, if you saw, the creatinine had also become 1.7. So there was an AKI. So we switched to a ALD-based regimen. Then something regarding covicistat and dolutegravir, the creatinine elution. The problem, physicians, we often see a 0.1 to 0.3 milligram per deciliter rise in serum creatinine. And after starting these drugs, and fear, is there an AKI? But the mechanism is that these drugs inhibit the multi-drug and toxin exclusion protein, MATE1 and OCT2. These transporters are responsible for secretion of creatinine from the blood into the tubule. So the clinical pearl, this is after discussion with Dr. Mayuri Trivedi, which is a nephrologist, she says that, sir, the GFR appears to drop, but the actual, the eGFR appears to drop, but the actual GFR, if you measure by inulin clearance, remains unchanged. So till the creatinine rise is less than 0.4, you can go. If it rises to 0.4 or beyond, look for alternative causes. Now, HIV and renal impairment, we've seen a lot of causes, and with survival, we've gone on to causes related to your comorbidities and CKD. Now, this table summarizes my talk. Like, what are the renal disorders? You have the classic HEVAN, then you have HEVIC, especially in combination with hepatitis C or D. And there are various types, mesangial proliferative, membranoproliferative, lupus. You have other minimal change disease, the other various glomerulopathies, and the HIV, TTP, and HUS. In tubulointerstitial disorders, a big list of drugs which can cause proximal tubular injury, chronic tubular injury, diabetes insipidus, then drugs like indinavir, atazanavir, sulfadiazine, acyclovir causing a crystal nephropathy. And interstitial nephritis, apart from this, can also be because of allergy to beta-lactams, rifampicin, or phenytoin, allopurinol, and so on. This is a lovely chart which shows the host genetic susceptibility, social demographics, the HIV-related factors, the comorbid conditions, the co-infections, and the underlying CKD etiology. So we can use this if you have a patient presenting, and my talk will be here, so the organizers can share it with all of us. Now, HEVAN is a, so initial days, we were thinking that HEVAN is the main renal affection. It's a clinicopathologic entity involving the glomerulus with collapsing glomerulopathy. It occurs during an AIDS-defining illness. The kidneys appear bilaterally bulky. The patient presents with nephrotic range proteinuria, RPGN leading to ESRD. And if you see the biopsy, this shows the classic focal segmental glomerulosclerosis with collapse of the glomeruli, tubular microcystic disease, and some interstitial fibrosis. Going on to case 2, this is a 16-year-old male, PL-HIV since 2023 on TLD. He's coming with facial puffiness, periorbital puffiness, abdominal distension. So this is looking like a nephrotic syndrome. He had a similar complaint back in 2022. Renal biopsy was done. It showed a diffuse proliferative glomerulonephritis, some immunofluorescence positive, but thereafter lost to follow-up. So now when he came, he had a very low total proteins of 3.9, albumin of 1.6, but see, 24 hours urinary protein 10 grams a day. So definite nephrotic syndrome, but what is interesting is the urine also showed 50 to 60 RBCs. So this is a mixed nephritic nephrotic picture, high lipids, CD4 counts were very good. This was the biopsy which showed diffuse proliferative glomerulonephritis with a non-lupus full house nephropathy. He received albumin diuresis and the edema decreased over the course of time. The patient was discharged with enalapril and he was started on 1 milligram per kg of prednisolone. Now, what is HIVIC? It's a HIV-associated immune complex kidney disease. It's characterized by presence of glomerular immune deposits on immunostaining. How does it present? Microscopic hematuria, AKI, RPG, and chronic glomerulonephritis. But patients of HIVIC are far less likely to progress to end-stage renal disease than those with HIVAN. And if there is association of hepatitis C, there is more chance of developing HIVIC. It's characterized by immune complexes, all related to complement HIV antigen reactive antibodies. It's associated with high HIV RNA levels, circulating levels of antigens, and strong polyclonal antibody response. The diagnosis on histopathology, variable mesangial focal or diffuse endopapillary hypocellularity, and immunofluorescence showing full house staining like IgG, IgA, IgM, C3, C1q, granular staining in the mesangium and capillary loops. And classification of HIVIC is IgA nephropathy like lupus-like nephropathy, membranous nephropathy, and biopsy is characteristic. Now, co-dynamics, Hep C can be associated with cryoglobulinic vasculitis. HBV causes membranous nephropathy. Syphilis can cause acute nephrotic syndrome via immune complex membranous nephropathy, and BK virus, while more common in transplant, can emerge in severely immunocompromised HIV patients mimicking interstitial nephritis. Now, coming to crystal-induced AKI, atazanavir can precipitate in the acidic environment of the distal tubule. 5 to 10% can develop asymptomatic kidney stones. Sulfadiazine has a higher risk of shock-like crystal precipitation. Acyclovir, if given without hydration, can cause crystalluria. So all these drugs need you to maintain, educate the patient to have a good water intake and maintain a good urine output. What about dialysis and transplantation in HIV? Transition to ESRD. HIV patients on dialysis historically had a higher mortality, but with viral suppression, outcomes now mirrors the general population. And the HOPE Act, HIV to HIV, it's a breakthrough in 2026, utilizing kidneys from HIV positive donors for HIV positive recipients. The challenge, however, of superinfection remains and drug-drug interaction, especially tacrolimus versus ritonavir. What are the biopsy guidelines for the specialist? When do you biopsy? If the proteinuria is more than 1 gram per day, unexplained decline of eGFR more than 25%, or an active urinary sediment. But you don't biopsy if the kidneys are shrunken. Now, before I end, this is a study which I had given to my postgraduate in 2021, because we saw a lot of, me and Rupal are seeing a lot of renal involvement, HIV patients getting admitted. So these were the aims of the study, studying the spectrum of renal disease, classifying the causes of renal involvement, assessing the outcomes, and seeing the adverse effects. So we did it over an 18 months period. This boy has appeared past his MD. Now, what the salient results? We had 60 patients, 39 male, 21 female. Now, see, the mean age was around 50, 47 years. 51 were unmarried, 48 were unemployed, but 68% had comorbidities like hypertension, diabetes, and hypertension with diabetes. The clinical presentation was actually more of fluid overload and pulmonary edema in 20 patients and sepsis in 14 patients. And as regards the renal dysfunction, acute kidney injury was more common than CKD. And in AKI, the pre-renal, so most of these, a lot of AFIs come with vomiting, loose motions. They are in pre-renal failure, and you can easily salvage them. So pre-renal AKI and sepsis were the leading causes of AKI. About 43 patients were biopsied, and FSGS was the most common finding in 26, followed by an IgA nephropathy. The outcome, 84% of AKI cases resolved, 15% progressed to ESRD. About 40% of CKD patients required maintenance hemodialysis. The overall mortality was around 8.26%, more in AKI, 12% compared to CKD. 72% required a change to Reno-safe ART regimens, but surprisingly, tenofovir is more a cause of AKI in our OPD or our DASEP OPD, whereas indoor tenofovir was not much implicated. So take-home points, renal dysfunction is common in HIV patients, and hypertension and diabetes as they age are the significant comorbidities. Apart from HIVAN and HIVIC, remember your all AFIs can produce renal involvement. ART regimens may need to be adjusted. Early detection and management of renal complications are crucial. Regular monitoring of renal function in HIV patients is needed because many times we find in the DASEP OPD the 2 साल creatinine किया ही नहीं है and they are coming with a high creatinine. And adapt the ART regimens to avoid nephrotoxicity. Thank you very much for the patient hearing.
Thank you, Dr. Karnik, for an excellent presentation, and thank you for keeping the time. I now call upon the next speaker. It's untangling ART failure in real life.
Yeah, good afternoon to all of you. So unlike the previous 2 cases, my case is going to be very simple, very straightforward. The reason I have selected this case is this is journey of a patient of mine who is there with me for the last 10 years. And I'll take you through the journey, and during this course, a lot of learning points, which is mainly aimed at the young doctors who are there in the audience. So we'll start off with the case. Yeah. So although the title says entangling the mystery around a case of treatment failure, it's not exactly such a complex case. But then I'll just tell you how I managed this patient over the last 8 years. So this is basically the case. A 45-year-old male with recent diagnosis of HIV. He's also a diabetes and has been diagnosed with nephropathy. And his baseline investigations are, I have not given all the investigations, only relevant investigations. Creatinine of 1.8 with an EGFR of 42, HbA1c of 7.6. His CD4 cell count done at the beginning is 136 with a viral load of 88,000 copies per ml. So he was initiated on renal adjusted regime of abacavir, lamivudine with dolutegravir. Since his CD4 cell count was low, he was started on OI prophylaxis, and he was also given IPT at some point of time, not at the same time. And then he was put on insulin for diabetes with a combination of dapagliflozin, and his cardiovascular risk was calculated, and the 10-year cardiovascular risk was found to be around 14.8. I'm referring to ASCVD risk assessment, and that's why he was put on statin and also prophylactic antiplatelet drugs. So this is the case. Now, the questions are, do you agree with the treatment initiated for HIV and also diabetes? Any comments? Anybody would like to say anything? Yeah, anything? Yes. So if you want to avoid abacavir, what else you can give through the ART? This patient was enrolled in ART center and that was the option available. And so although he didn't have any cardiovascular events when the medication was started, he had a very high risk. That was a risk we had to take since nothing else was available in the ART center other than this combination. He was covered with statin and antiplatelets. Atorvastatin. And what about metformin? Should we have started on metformin? There's an interaction between metformin and dolutegravir. So the metformin, especially when there is renal failure, and when you are giving dolutegravir, metformin level goes up, and it can cause complications, especially lactic acidosis. So it is usually avoided combination of dolutegravir and metformin if you have to give a higher dose of metformin, and that too in renal failure, it is better to avoid it. Right. So we'll go ahead. So the clinical status of the patient, he was asymptomatic and was adherent to the ART, and followed up at 6 months. Viral load was undetectable from 88,000. CD8 4 cell count had marginally gone up to 156. Creatinine was around the same range, 1.6, and HbA1c had come down to 6.8. So he was doing well on ART. So then we followed it up to 24 months. The repeated tests revealed a viral load of 45 copies per ml. CD4 of 170, creatinine of 1.7, HbA1c still 6.7. Any comments on this? What will you do next? Yes. Yes. Yes, yes. So switch dolutegravir to protease inhibitor, order an integrase resistance genotype test, repeat viral load in 2 to 4 weeks while maintaining the current regime, add tenofovir alafenamide or switch to AZT to intensify the backbone. Okay, the option given there is 3. Do you agree with third option? A and B. Okay, we'll see what we did. Yeah, we took the third option, and the reason given is when you have a undetectable viral load again becoming detectable, but not very high, you have to go through the checklist basically, whether patient was compliant to therapy, whether there's any drug interaction, whether there's any absorption related issues, whether there's any resistance emerging. All these things you basically go through the checklist. And what we found was he had received his annual flu vaccine with pneumococcal vaccine just about 1 month back. So based on this input, and based on the marginally elevated viral load after he attained undetectability, it was considered as blips. So it is blips versus failure. So what is blip? Viral blip says it's isolated transient increase in viral load, typically in the range of 50 to 200. The threshold can vary depending on which guideline you're following, and it followed by a return to undetectable level. So when you need to cross-check this, usually like when you repeat it after 3 to 4 weeks, by 4 weeks, if it comes down to undetectable levels, it's considered as a blip. So what's its clinical significance? Blips are generally due to lab variation or transient immune activation and do not require a treatment change. And there's another term called persistent low viremia. How is it different? Here it stays elevated all the time. It doesn't go back to undetectable levels. And this has got an associated risk of increased future virological failure if it is persistent low level viremia. Right. So moving on, the clinical status of the patient was asymptomatic adherent to ART. Viral load repeated after 4 weeks was undetectable. So that means we have confirmed that it was a blip. Right. Yeah. So what is the most appropriate next step when it comes to monitoring in this patient? Now we have proven that he has got undetectable viral load, almost 2 years on ART. D. Any? Right. So what we did was, yes, continue viral load testing every 6 to 12 months and make CD4 monitoring optional. Yeah, so what happens is, if the viral load is, according to the guidelines, if the viral load is consistently undetectable for 2 years, then if the CD4 has gone above 500, you don't have to do it at all. But in this case, the CD4 cell count is still below 500. To decide about OI prophylaxis, you need to keep it as an optional. If required only, it has to be done. Otherwise, not required. 2 years he has cleared. Yeah. Right, we'll move on. So the clinical presentation by 4th year after initiation of ERT, patient is stable, good adherence, viral load is undetectable, CD4 count is 180, it's refusing to go up, but he is undetectable. The diabetes is under control. So now what will you do next? Because already undetectable, but the CD4 cell count is still low. Yes. C. Okay. Continue the current ERT regime, maintain OI prophylaxis, and focus on managing age-related comorbidities. Right. So we'll see what we did. We did the same thing. Right. So the reason for that is there's something called immunovirological discordance. So here patient achieves complete viral suppression happens, but the immune system fails to reconstitute. The CD4 stays below 200. This is a subset of patients, about 20% you come across this. So it's called serodiscordant. So here the significance is discordant responders remain at a higher risk of OIs and non-AIDS event compared to those with robust CD4 recovery. Still they are at risk, but the risk of OI is less in those patients who are well suppressed compared to those patients who are not suppressed and low CD4. So OI prophylaxis has to be continued. And in this patient, we continued the prophylaxis. Right. So why it happens, this discordance? Because chronic inflammation, Dr. Rajiv had told this in yesterday's presentation, thymic exhaustion, lymphoid fibrosis, and aberrant T cell dynamics. Right. So OI prophylaxis, which is the most appropriate action in this patient. Yeah. So as per the what guidelines is, you can even consider discontinuing PCP in this patient despite low CD4 cell count because of this. In patients with CD4 count between 101 to 200 who were virologically suppressed, the incidence of PCP was only 0.48 cases per 100 person years, significantly lower than untreated patients who it was about 5.3. So that, and even when the CD4 is low, in a virologically suppressed patient, MAC prophylaxis also may not be required. So active HIV replication is a major independent contributor to OI risk. So it is, if the virologically suppressed with low CD4 cell count, the risk is much less compared to a patient with a higher viral load with low CD4 count. Right. So continuing, patient has been on ART for 6 years, has developed new symptoms. Investigations, CD4 still continues to be virologically suppressed. CD4 is 360, diabetes is under control. Then he has dry cough now for 4 weeks, low grade fever, weight loss is there. He has some crackles on examination. So it's very easy for us. This is what we see always. So we suspect. Yes. What will you do next? This is the X-ray. Very easy. So as expected, sputum evaluation was done. It came AFP positive. But only thing is there are a lot of other organisms which could be AFP positive in this setting. Nocardia, rhodococcus, and also, yeah. So luckily for us, it was sensitive TB. Patient was treated for TB. Do you think this has a treatment failure? No. Yes. Yes. Because he developed tuberculosis. Yes, that's the point. So it's not treatment failure. So he was treated with tuberculosis with conventional drugs for 6 months. The only thing is dolutegravir dosage has to be increased. It has to be doubled when rifampicin is there. And although the risk of iris is there, but is very less in this patient, regular monitoring of LFT is required. So now, what is the next step after 6 months of ATT? So I'm running low on time. Yes. B, the dolutegravir which we had doubled has to be continued for at least 2 weeks after we stop ATT. So that's the thing. Yes, quickly. So 8 years down the line, now patient has pill fatigue and because he has to take so many pills for diabetes and also for HIV, he starts complaining his viral load is 1,200 copies and repeated after 3 months. This is mandatory. You need to have 2 viral loads. Now it is 2,500. CD4 cell count is 110. So adherence compromised, but good over the last 4 weeks. Drug interaction, not significant. Drug absorption, not an issue. What will you do next? Yes. Yes, it was compromised for some time, but last 4 weeks, it is okay. Yes. The reason why I mentioned that is, the next question is, its virological failure is confirmed because we have 2 consecutive viral loads. There is immunological failure because CD4, it has come below even the baseline, although there are no AIDS defining conditions, but 2 conditions are fulfilled. It fulfills the definition of treatment failure. So the ART options here, obviously we need to choose a high genetic barrier drug and ART regime has to be changed. So coming back to Sir's point, what is the next step? B. Yes. So what we did was standard genotype resistance testing. The reason I said 4 weeks is because the genotypic resistance testing has to be done on a patient who is still on treatment on a failing regime. So it cannot be done once you stop and then. That's why I said, like, although he was not adherent, 4 weeks we waited till he took it properly and then we went ahead and did the resistance testing. So this is the last thing now. Genotype resistance testing was done and M184V was detected, K65 was there. 184V indicates resistance to lamivudine. K65 is resistance to abacavir and tenofovir. Integrase R263K was there, which gives low level resistance to dolutegravir. It resistance goes up by 2.7 folds, and it reduces the viral fitness. G18R mutation was also there. What I would like to highlight is this mutation is first comes when they are non-compliant with dolutegravir. That's the first one to come. So this patient has multi-class resistance to NRTI and also integrase inhibitor. So what to do next? Which second line ART will be most appropriate in this patient? Yes. Yes. So that's what we did in this patient. I think that's how we manage this patient. Just to summarize, viral blip, one of detectable viral load between 50 to 200, but it does not require any ART change. The immunological and discordance, persistent low CD4 despite low viral load requires continued OI prophylaxis depending on the, there I have given you the difference. Virally suppressed with low CD4, virologically not suppressed with low CD4. The risk differs. Tuberculosis and non-AIDS conditions may not always indicate treatment failure. Nephropathy related, the recent guidelines emphasize avoiding TDF and optimizing blood pressure alongside ART. Second line ART use high genetic barrier PIs like darunavir when integrase resistance is suspected. This we saw even in morning's one of the oral presentations. I think that was my case.
Thank you, Dr. Rao. I now call upon Dr. Priya Patil from Mumbai, and she'll be talking on lesser known ADRs.
Good afternoon, everybody. I thank the organizers and Gilada sir and Dr. Trupti Gilada for inviting me for this talk. And before I begin my talk, I would like to pay tribute to my teacher, Dr. Alka Deshpande. She did pioneering work in the field of HIV, as we all know, and her sad demise recently in December made us, actually, it was a great loss to her, the field of HIV. So I'm sharing some of the experiences of ADRs handled by me in being a member of the state AIDS clinical expert panel of JJCOE. So coming to case one, there was a 49-year-old male PLHIV on ART since 2019. So he was initially on TLE regimen up to 21 and then switched to TLD as per the NACO program guidelines. His viral load was suppressed all the times. And the SASEP referral to JJCOE was in May 25, was for pancreatitis. He had no history of alcohol intake and no past history of gallstones. So the patient was admitted for abdominal pain and vomiting for 4 days. And he was diagnosed as acute pancreatitis on 2nd May 25. His amylase was very high, 1,219, and lipase was also very high. USG showed mildly bulky hypoechoic pancreas with peripancreatic thin rim of fluid and fat standing. So it was clearly suggestive of pancreatitis. The CT scan was suggestive of acute on chronic calcific pancreatitis. So whenever there is calcification, it suggests chronic pancreatitis, and even atrophy, pancreatic atrophy is suggestive of chronic pancreatitis on the CT. The CT score was 6/10, and the TLD was stopped on 2/5/25. Then when the SASEP referral was made, by the time it was already 1 week past. So the repeat serum amylase was inquired by us. So it was 182, and lipase also had come down from the initial level. The other investigations were normal. And the serum triglycerides was normal. The sugars were normal. So the diagnosis was, this was a case of acute pancreatitis due to the pancreatotoxicity, likely because of the NRTIs in the ART regimen, that is tenofovir and lamivudine, in a case of chronic calcific pancreatitis. So the alternate first-line regimen prescribed by JJCOE was dolutegravir and ATVR combination. Coming to the second case. So this was a 41-year-old female patient. She was on ART since 2011. Initially was on SLN regimens for 2 years, then ZLN regimen, and then TL-ATVR as the second line in 2017. And then she had nephrotoxicity because of tenofovir. So she was switched to abacavir, lamivudine, and atazanavir from 2019 till 2023. She was on that regimen. Now, because of non-availability of plain abacavir and separate lamivudine, this patient received full dose of lamivudine, which was not adjusted as per creatinine. And now the patient was referred for persistent vomiting and intermittent abdominal pain. So persistent vomiting in a patient who is on ART, there are 2-3 differentials which we should think of. One is pancreatitis, if the patient especially has pain in abdomen. Then another is renal failure, which just now saw the lecture by Karnik sir. So renal failure can be suspected. And another, if the patient is on chronic ART, it can be lactic acidosis. So in this particular patient, the serum, we asked the ART center regarding to inform us regarding all the amylase and USG report. And we saw that the serum amylase was high and the lipase was also high. The USG was showing chronic renal parenchymal disease. And however, the pancreas was normal on the sonography. So here the pancreatitis was due to NRTI, mostly low lamivudine toxicity because of giving full dose and not adjusting the dose in the case of CKD. So our reply was withhold the ART, and once patient's pancreatitis resolves, change the regimen to DTG with atazanavir, ritonavir. So coming to the mitochondrial toxicity of NRTIs. So as we all know, the various symptoms like lactic acidosis and hepatic steatosis is because of most culprit drugs are zidovudine, stavudine, and tenofovir. Then myopathy, zidovudine and stavudine. Cardiomyopathy seen in zidovudine. Actually, there's some, the slide is showing the drugs are not aligned. But anyway, cardiomyopathy, it is zidovudine, stavudine. Pancreatitis, all drugs can be implicated right from, actually we know that stavudine and zidovudine were the most culprit drugs, but even lamivudine, tenofovir, and abacavir, they also can cause. Pancytopenia is because of zidovudine, lipodystrophy, zidovudine, stavudine, even tenofovir, and polyneuropathy because of stavudine and lamivudine. So all these symptoms are because of the mitochondrial toxicity, which was already discussed. Now coming to risk factors for acute pancreatitis in PLHIV. So this was from the study. It was a it is a beautiful article with a review of so many case reports and so many studies on pancreatitis. And so whether there is an implication, is there any role of NRTI? So that was the literature review. So this article concluded that yes, the NRTIs are implicated in the etiology of pancreatitis in PLHIV. So actually the older drugs are no longer in use, like diadenosine, stavudine. But as we saw in the first case, the patient was on TLD regimen and still patient had pancreatitis. So we should be aware of this complication. So lamivudine, tenofovir, zidovudine, all these can cause pancreatitis. The NNRTIs, efavirenz and nevirapine. In fact, we did a study. I'll be showing that study also. We had a lot of cases of pancreatitis on TLE regimen. So probably the efavirenz and tenofovir and lamivudine all had the pancreatotoxicity. The PIs also are implicated. They are generally much safer, but if they induce hypertriglyceridemia, then they can cause the pancreatitis. Then even direct lesion by HIV, that can cause pancreatitis. Then all the opportunistic infections and neoplasms, advanced disease like CD4 less than 200, high viral load, alcohol abuse, use of illicit drugs, past history of acute pancreatitis, long seropositivity duration, advanced age. So a host of factors which are responsible and make the patient at risk for pancreatitis. So this was a study. It was a thesis given to my student because I had a lot of suscept referrals with pancreatitis and we were seeing cases. So we did this study of clinical profile, risk factors, and outcome of acute pancreatitis in PL-HIV in tertiary in JJ that was done. And we took almost 50 patients, both the suscept referral cases and some patients which are admitted in our institution. And what we found out that the pancreatitis was predominantly biochemical. The most common USG finding was just a bulky pancreas. None of the patients had complications like pseudocyst or necrotizing pancreatitis. And the ART regimens in our study, the tenofovir lamivudine was the regimen in almost in 30 cases, that is 68% cases. Stavudine lamivudine in 6 cases, zidovudine in 4, and abacavir lamivudine in 4. So all the NRTIs were there in these patients. The NRTI and NRTI combination was seen in 70% cases, NRTI-PI in 18%. 12% of cases, that is 6 patients, were not on ART, and none of the patients had hypertriglyceridemia. So the conclusions of this study that 72% had advanced immunosuppression. So we saw even in the literature review that CD4 less than 200 is a risk factor. The most important factor was NRTI-based regimen, but what we saw that it was a multifactorial etiology because most of these patients had TB as a OI. Out of those 30 patients who were on TLE regimen, almost 22 patients had TB and they were on AKT. So even the antitubercle drugs like INH and rifampicin have pancreatotoxicity. 24% patients had no cause for pancreatitis except NRTI. 6 patients were not on, 6% cases not on ART, had no OI. So the cause of pancreatitis was unexplained, maybe HIV infection per se. OI was a significant comorbidity. And the usual causes of pancreatitis like alcohol, gallstones, and hypercalcemia were seen very less in our study. The conclusion was the INSTI at that time, this was done in 2019. So the INSTI 19 and later on. So the INSTI regimen in the program was raltegravir. So this regimen, raltegravir lopinavir, was tolerated very well. And there was no recurrence observed on this regimen. So patients having pancreatitis due to other causes or prior to exposure of ART may have recurrence of acute pancreatitis due to additional pancreatotoxicity by NRTI. So that is also, suppose the patient is on alcoholic and he's had history of pancreatitis, then we should be careful when we are giving NRTI in that patient, and we should observe and monitor for pancreatotoxicity. And INSTI with PI may be the best regimen for such patients, DTG and ATVR. Coming to case 3, a 48-year-old female patient, known case of RVD since 15 years. She had history of giddiness since 1 month. So she was recently admitted with us, more on exertion, and patient was on DTG lopinavir from October 20 till date. Her previous ART, she was on ZLE from 14 to 18. EL-ATVR was given as a second line for because of virological failure on ZLE. And DTG-LPVR was alternate second line due to tenofovir nephrotoxicity. She was switched to that regimen, again, probably because of non-availability of separate abacavir and low-dose lamivudine in that ART center. So we had to give DTG-LPVR. Now, this patient was evaluated at cardiology department at outside hospital, and she was found to have severe sinus bradycardia. And the cardiologist suspected a drug toxicity, so they advised to change ART in view of drug-induced bradycardia. Accordingly, the patient was referred to JJ COE, and we asked the patient to come and get admitted for a detailed clinical evaluation. So patient was admitted at JJ. Her pulse was 48 minutes, severe bradycardia. The blood pressure was 100/60. Systemic examination was normal. We investigated at JJ. Her HB was 12.1. Creatinine was slightly high, 1.3. All her electrolytes were normal. Calcium, magnesium, potassium, sodium were all normal. The ECG showed severe bradycardia, and the 2D echo was normal. So this was the ECG. You can see the severe bradycardia, and that was causing syncope-like symptoms in her. Again, the heart rate was almost 38 in this ECG. So the diagnosis was sinus bradycardia due to lopinavir. And the alternate second line, immediately we changed the regimen. The regimen was changed to abacavir, lamivudine, and DTG. The repeat ECG 1 week after the change of regimen, it is normal now. You can see the heart rate has normalized and the patient's symptoms were also alleviated. So cardiotoxicity induced by lopinavir ritonavir is a known feature, and there are many case reports and many studies, especially during the COVID pandemic. Lopinavir was used empirically. So there is a study reporting increase of cardiac ADRs associated with empirical use of lopinavir, and that study quotes all the mechanisms like and the features like cardiac conduction problems like AV block, severe bradycardia, QTC prolongation, and torsades de pointes. So these effects are due to multiple channel block effect by lopinavir ritonavir, consistent with the inhibitory action on the sodium, calcium, and potassium channels. Coming to the last case, a 49-year-old male PPL-HIV, weight was 67 kg, on ART since 2007. Previous regimens, long-term, NRTI use SLN 6 years, TLE 8 years, and the current regimen was TLD since 21. Referral to JJCOE was in 24. His viral load was suppressed, and the reason for referral was the buffalo hump with weight gain on TLD regimen. So patient was concerned about the cosmetic disfigurement and asking solution. We had multiple such patients. One patient had come from Akola, and she showed me the buffalo hump, and she had a severe upper chest obesity. She said, I cannot wear my blouse. When I have to wear my blouse, it is very difficult. And she was very much distressed. So similarly, this patient was also having this disfigurement. So all the investigations, the thyroid function test was normal, creatinine was normal, the lipid profile was surprisingly normal, and the sugar levels were also normal. So on inquiry to the ART center, the weight prior to DTG initiation was 55 kgs and the current weight was 67 kgs. So basically this was a problem of lipodystrophy with long-term ART use and compounded by the DTG weight gain additionally. So we told them to change the regimen. The alternate first line was TL-ATVR. And this patient, we said that patient has lipodystrophy, that is lipohypertrophy due to long-term NRTI use, which will not reverse. So please counsel the patient regarding diet, exercise, and for buffalo hump can refer to plastic surgery. So this patient had the weight gain, and as we already know that DTG causes weight gain and even TAF causes weight gain. So coming to lipodystrophy in PL-HIV, basically the lipodystrophy is of two types. One is lipoatrophy, that is fat wasting. So mainly seen in stavudine, and stavudine had all this mitochondrial toxicity. That's why it was phased out. Zidovudine still we are using. Loss of subacute fat in face, arms, and legs, and preferential subacute fat loss without lean tissue mass. That is how we differentiated from wasting per se in HIV. So in patients responding to ART, this is a preferential subacute fat loss, that is lipoatrophy. And lipohypertrophy or fat accumulation, this can occur with any regimen, does not reverse on change of regimen. And the BMI and waist tip circumference are not specific for visceral fat. This is the hallmark of HIV-induced lipohypertrophy or fat accumulation is the visceral adipose tissue accumulation. Then you can have cervicodorsal fat accumulation causing buffalo hump, and trunk and upper chest fat accumulation. So this is a facial lipoatrophy. So this we used to see a lot in patients with stavudine, but still it is not rare because we still have NRTIs like zidovudine and 4 in use. Now this is the difference in general obesity, just last 2 slides. So the usual obesity, you can see there is a visceral fat and there is a lot of subacute fat. But the lipohypertrophy in HIV, that is a visceral obesity, it's mainly the visceral fat and the subacute fat is reduced. So that is a distinguishing feature of HIV-associated lipodystrophy. And in this situation, the waist circumference may not change. So there is hardly any pinchable subacute fat over there. And this is a CT scan, which was done for because the patient had renal stone. But you can see that there is so much of accumulation of the visceral fat. The bold arrow. The white bold arrow shows the visceral fat, and the broken arrow that shows this. So there is a lipoatrophy along with visceral fat accumulation. So the subcute fat is hardly there. You can see that there is very less amount of subcute fat. So fat is seen as black in CT scan. So the potential interventions for lipodystrophy, actually, this is a very frustrating thing for the patient and for the physician also. For lipoatrophy, we can have injectable fillers for facial lipoatrophy, and pioglitazone can be used in patients with insulin resistance. And for fat accumulation or lipohypertrophy, we can counsel the patient for diet and exercise. Metformin can be used in patients with diabetes. Then there's a drug known as tesarmorelin, which is a growth hormone analog, basically, but it is very expensive, but has been used in Western countries for specific reduction of visceral fat. And surgery can be done like liposuction of dorsocervical fat pad or reduction mammoplasty. So some of my patients who had this buffalo hump, so we referred to our plastic surgery department, and with great willpower, those plastic surgery patients were not listening, and they were telling come again and doing a lot of anesthetic fitness. So that is a way how you can, just postpone the things. So anesthetic fitness.
Madam, please summarize. We have crossed the time. Please summarize.
So that with still that we could manage to do liposuction in those patients, and they were happy. So that we can try for our patients. So thank you for the patient.
Thank you, Dr. Patil. And now we call upon the last speaker for today, Dr. Noella Pereira from Mumbai. Growing up with HIV, adolescents challenge in ART era.
Suswagatam, welcome Dr. Noella Pereira to ASICON 2026, Mumbai. A dedicated clinician from Mumbai, she plays a pivotal role in advancing adolescent HIV care and addressing the unique challenges young people face in the ART era. Today, she speaks on growing up with HIV, adolescents' challenges in ART era.
Good afternoon, everybody. And today I'll be discussing what it feels like to be growing up with HIV and the challenges faced by adolescent patients in the era of ART. So to start with, let's discuss about adolescence and how this phase is really important in the course of life. So adolescents are basically those between the ages of 10 and 19 years. And these are delicate phase of life where children are gradually transitioning to becoming adults. And during this phase of life, we see a lot of development. There's physical development, secondary sexual characteristics are setting in, pubertal changes are taking place. There's a change in voice, rapid increase in height, and there's an interest in relationships as well during this phase. And then there's emotional development. There's a surge of sex hormones taking place, leading to mood swings, impulsivity, cognitive independence. The adolescent wants to have their own way many a point of time. And behavioral changes. This is the time when they indulge in risk-taking behavior. They want to do what their peers are doing, be it in relationships, drug abuse, or unsafe injections as well. And there is a need for autonomy during this phase because the child wants to have their way, and very, very often they aren't able to make the decisions that are right and safe for them. So we as healthcare providers and caregivers need to step in to make the right decisions for them. And this is the phase where they're most vulnerable to HIV. And the reason being because they're indulging in risky behaviors, drug abuse, sexual relationships, etc. And many of them leave the home, they're rebellious. Many of them face poverty, and that makes them more vulnerable to HIV. And now with robust ART regimes, many of our children are now reaching adolescence, and that itself poses several challenges. So we have two distinct populations of adolescents. We have the vertically infected adolescents and the horizontally infected adolescents. The vertically infected adolescents are most likely to present to us for the very first time in an advanced HIV stage. They have missed the boat. They have not been screened for HIV before, and now they're presenting to us with this opportunistic infection, disseminated TB, herpes zoster, tinea corporis, and various other infections. Their growth and development is usually affected because they've lived with the disease for that long and they're presenting to us today. They face a higher mortality rate. And very often they are not even told they have HIV. Disclosure is partial or none at all. They are likely to experience multiple HIV-related losses. They've either lost one or both parents, and they experience stigma very early on in life, both at the school front, the home front, and at the healthcare system as well. On the other hand, the horizontally infected adolescents are those who have acquired HIV either through sexual practices, drug abuse, unsafe injections. They are at an earlier stage of HIV. They are less likely to have opportunistic infections at the time of presentation. The effect on growth and development is less likely, lower mortality. They would only know their status if they access the healthcare system and access HIV services and got themselves tested for HIV. They lack familial support, social and clinical support, primarily because they're blamed for getting HIV through the various practices they've indulged in. And they experience stigma much later in life, especially stigma due to drug use and sexuality. So these adolescents are faced with myriad challenges, the challenges of being an adolescent and the challenge of HIV on top of that. The challenges of adolescents are many. They've got new cognitive capacity, they're evolving decisional capacity, they struggle for independence, they want to have their own way, they question authorities, both parents as well as us doctors. They need to identify with peers, and very often they get carried away by what their peers are doing. They're preoccupied with self-image and they indulge in risk-taking behavior, which may be harmful. And the challenges of HIV over and above those are plenty. The association of stigma and discrimination, living with a chronic disease requiring daily medication is not something that everybody's used to. Long-term morbidities related to both HIV as well as the treatment. And last but not the least, the adverse socioeconomic conditions that they're living in. So this beautiful study conducted in Kenya categorized these challenges faced by vertically infected adolescents into 3 categories: the individual level, those seen at the family level, and those seen at the community level. And at the individual level, what they found was disclosure was a challenge. To tell others that you have HIV was difficult. Many of these adolescents are in denial of their HIV status, and that denial leads to low ART adherence and high viral loads. Internalized stigma, the stigma of and the fear of being discriminated. And very often they're faced with anxiety, depression, suicidal thoughts, etc., because of their HIV status. And all that has led to low adherence in ART. At the family level, many of them are not accepted, and most all, they even despised by extended family. Many times cousins are not willing to sit on the same dining table as them, because they're HIV and they're afraid of contracting the disease from them. They're faced with the death of one or both parents. They're discriminated, and very often these parents cannot look after them sufficiently. As a matter of fact, even at the PCOE, we have to sometimes refer these children to be placed at orphanages because mom or dad is unable to care for this child. And at the community level, these adolescents attending adult clinics face long waiting times at the ART facility. They face stigma at school and stigma in the general community, discrimination, and even playground stigma, to name the least. Another major problem is transitioning to adult care. These children have been really mollycoddled in our pediatric center of excellence, and then to transfer them to adult care is a big thing. They struggle with navigating the adult clinic, new faces, new system, new environment. They suffer from loss of informational support because we've been looking after them and providing so much of informational support. They sometimes see a loss of that at the adult clinic because of the long wait times, the large number of patients, etc. Many of them felt in this particular study that there was lack of privacy. They were afraid of their HIV status being exposed and finding other members of their own community and village entering the same ART clinic and coming to know that they are HIV positive and then spreading the news. They also face stigma and loss of support from their peers. In the pediatric general clinic, they had so many friends, and now the adult, the adult patients may not be as engaging with them as their pediatric friends. And many of these children faced that they had lost support from their caregivers and healthcare providers, because now that they are in the adult clinic, they felt that the parents were not accompanying them to clinic appointments, and because the parents felt that they are able to stand on their own feet and they don't need as much care as they needed before. So What we pediatricians do is we use the 5 A's to assess our adolescents. The first one is to assess their goals, their physical, mental status, whether they're sexually active or not, pregnancy, whether the female patient is pregnant or not, and whether they're indulging in risky behaviors. What we use is a heads assessment tool, and that's very good because heads is a mnemonic, and you ask what's happening on the home front, or whether they're being studying or they are employed, what are their activities after school or after work, whether they indulge in drug abuse, what are their sexual practices, whether it's sexually active and whether using a condom or contraceptive, whether they are safe in the environment or not, and last but not the least, whether they are suicidal or suffering from depression. And this serves as a good tool to assess an adolescent. Secondly, we advise them using a non-judgmental attitude, using clear language, correcting any incorrect knowledge that they have, fill in the gaps in their understanding, ask about and discuss about sexual activity, condom use, contraception. Thirdly, agree on a treatment plan, whether you plan to start them on tenofovir, lamivudine, dolutegravir, or bacavir, lamivudine, dolutegravir, depending on their weight, once a day, twice a day, etc. Whom do they want to disclose about their HIV status? And how do they want to do that? What is the treatment plan? And then assist them, give them a written plan, arrange for referrals, whether they need referrals to the ophthalmologist, the psychiatrist, gynecologist, or the dermatologist. Many of these complicated cases are referred to the DARCEP and SARCEP meeting, where all of these are sitting around the table, so referrals become easy. They are then linked to support services, other treatments such as cotrimoxazole, as well as vitamins and minerals are to be given to them, and provide them with condoms and contraception if they need. And last but not the least, a next appointment date, refer them to support groups and group counseling. Group counseling is important, and I'll touch on that in a bit. What do you need to counsel this adolescent about? First and foremost, care and treatment, helping them understand what is HIV and lifelong ART, treatment adherence, staying adherent lifelong, disclosure, that they are fully disclosed about their own status and that they are able to tell others that they are HIV positive. Healthy living and nutrition, simple things, drinking boiled water, avoid junk food, stick to homemade, home-cooked meals, etc. And offering them a balanced diet. Discussing about sex and HIV. I know sometimes we pediatricians shy away from this topic, but we need to be more forthcoming about talking about growing up with HIV, changing behaviors, sex and relationships, pregnancy prevention. And last but not the least, life skills, teaching them communication skills, helping them handle fear, stigma, discrimination, helping make decisions for life as well as planning for their futures. At the Pediatric Center of Excellence for HIV Care, we conduct MITWA sessions. These MITWA sessions are conducted with directors from NACO. And these are sessions that are conducted in a small group where 8 to 10 are sat down for 2 to 3 hours per session, and 2 or 3 sessions are conducted, comprising 10 modules. And various topics are discussed: career guidance, handling peer pressure, abstaining from drug abuse, sex education. And these sessions provide a safe space for these adolescents to raise queries, clear their doubts, burst any myths that they have, and impart info and disseminate information on HIV and helping them survive in the world as adults living with HIV. So my take-home message to you today is that adolescence is a vulnerable phase of life that needs to be tackled very sensitively. We need to have transition clinics, adolescent HIV clinics, which may serve as a bridge between the pediatric HIV clinic and the adult HIV clinic. Early disclosure has shown to improve adherence to ART. We need to tailor our counseling sessions to the needs of the adolescent. One size doesn't fit all. And caregiver and provider support should continue till the adolescent feels comfortable enough to handle their own needs. On that note, I'll thank you all for a patient hearing, and credit to our PCOE team at SION Mumbai. Thank you.
Thank you very much for an excellent presentation and giving us information which is much needed for all of us. Thank you. And I would now like to call upon all the speakers. If there are any questions, you could put forward to them. Can I call all the speakers to come forward, please? Any questions for any of them?
Thank you very much. We'd like to call upon our chairpersons to please
Ma'am, when we deal with adolescents, in case if a patient is in the adolescent age group comes with a positive report in terms of disclosure of the status, what is the situation? Can we disclose it to the person who's less than 18, or are we obliged to disclose to a parent or somebody else also?
So if somebody is less than 18, we take the parent into consideration, the caregiver, etc., should be present, and we do take consent from the parent. But very often we've seen that parents are hesitant in disclosing their status to their child for fear that the child will inform others and be discriminated from their community, their schools, their friends, etc. But it's important to counsel the parent and tell them that it's very important to disclose the HIV status to the child early on, so that there is good ART adherence, because studies and several studies have shown this, that early disclosure helps to improve ART adherence. So the sooner they know it, the better. And it's better not to lie to them, because down the line they will discriminate, they will question the parent, question the caregiver, and they lose trust in you as a doctor for not having told them the truth. And we've seen many cases where the child has later on got very frustrated for not have been told the truth and just being told that you're taking some vitamins or minerals and hiding. Secondly, it's important that they do not live in secret. I know that the world outside may not be very accepting of the HIV status, but it's important that they take their medication, and important that in order that they take their medication, they need to be disclosed about their disease. So yes, consent from the parents, but importantly support. And it's an ongoing process. You don't just tell them now and it's a one, off we go. We have to support them. It can take 6 months, 9 months, but we have to keep on emphasizing the point.
Have you encountered situations other way around, where the child comes to you at 16 years? So do you inform the parents or only the adolescent kid?
No, usually the child presents for the first time with a parent or a caregiver. So we take them both into consideration, because if the child is going to go home, the parents have to support this decision. If it's a vertically infected adolescent, then obviously the parent is already familiar with the disease. If not, then they are put on ART. If they're not and they're horizontally transmitted, we definitely inform the parents, because that child is going to go back home to that same parent.
Thank you.
Yeah.
Madam, just my question is for all, that I am working in this epidemic since starting, all in NSCP 1-2 still now. Initially, there was no guideline about the disclosure of the status to the children. Now what happened, that after 2014 guidelines was clear that you have to disclose partially and all that. But what happened with that particular that period? Now they are 20 year of the 25 to 30, but they are very much psychological disturbed. So I think for such type of lands, there should be some program, so that how to conceal, how to psychological everything. Can you throw light on this?
So it's important to, we have seen children who've who've even committed suicide, who've had depression, anxiety, worry, etc. So early on, if it is important to disclose, but even if you need the help and you find that the child has psychological disturbances, refer them to a psychiatrist. Get that help early on. Get them to engage in psychological counseling, behavioral counseling, and help them early on. Taking the help of your psychiatric colleagues can help in a big way if there are serious psychological disturbances in that adolescent.
So yes, madam, such type of the suggestions should come in guidelines also.
Thank you.
Actually, there should be an expert counselor, sir. Some counselors, they know how to handle, how to disclose properly, just without avoiding trauma. So you should take help of such counselor who has knows how to do the disclosure.
Madam, that's why I'm saying such type of special counseling or such type situation.
We can arrange for
between,
that such
between the age
counseling.
group of the 25 to 30 disturbed or suicidal tendency, there should be some guidelines for to handling such type of patient.
Last question, please, ma'am.
This question is to Dr. Noala. Thank you for your very nice presentation. I just wanted to know these horizontally infected children that you're seeing. Are you seeing a large number of them in this age group of 18, 19 years who are getting infected with HIV and coming? Do you
No,
have a
they
large
are
number, or is it just
a small number? I would say 10% of all the adolescents, but they are an important group because they lack the family support. The parents are negative and they've got to deal with a whole lot of stigma and discrimination, especially in the family. And if they've indulged in practices, bad practices, drug abuse, all the more, the fingers are all pointed down to them. But I think with good counseling like Madam Self and a lot of support and just being there for them and helping them through that entire process, they've come a long way. And we are seeing light at the end of the tunnel. So,
and do they belong, a lot of them belong to the gay population?
Not necessarily. Some have been homosexually abused. Some have been cases of rape. Some have indulged in sexual practices and themselves got it. Some have had unsafe injections, and one has even had blood transfusions. So, yeah, it is what it is. So, yeah.
Thank you.
Welcome.
So, Madam, we had a case of a 16-year-old boy whose father died. He was from Dharavi, which is a big slum. He came to us, he was diagnosed as lymph node tuberculosis, but he had a rash which was looking like a secondary syphilis rash. And then on talking to him, he said that he has 3 younger siblings, mother is not earning, and he's been lured into the MSM sex trade. And he admitted that he's been having relations with men, and he was so innocent looking, we felt so bad. 16 years old and he's earning money for his family by this means. He now regularly follows up in our.
Children are children vertically transmitted. And we have a lot of programs for these children actually. And almost all of them have transitioned now into early adulthood. Many of them have finished their education. We've been supporting them for education for several years. Many of them are now earning money. Many of them have got married, some of them to negative people with appropriate counseling. And we have a lot of children who've also had babies, and all those babies are HIV negative. So that is very satisfying. But to know that we are still getting children coming horizontally infected, that's a little worrying. So, yeah.
It is.
So in that case, what to do?
So I think you need to sit down with the child. He is a minor. He is less than 18. Who is looking after him at home? And why does he not want? If he's horizontally infected, what is he afraid of? Bring the parents if possible.
He told, give me some time. It'll take time. I am going to reveal after a few months.
Yeah.
So I had to keep quiet.
Keep following up. Keep following up. I mean, slow and steady wins the race, really. But ensure that at least his members of the family, if he wants to, and as he feels he's ready to disclose, then fair enough. I think ma'am would like to say something.
Such cases, it's always important to involve the person in whom this particular boy has the most trust in. It may not be the parents. In most cases, it's not the parents. Maybe a grandparent or maybe some friend or someone in the, yeah. So whoever he has trust and he wants to sort of share about this and get some advice, try and involve that person first and then slowly take it from there and definitely involve the family members, parents as well. Sir, on this note, like it was an excellent presentation and we've had a lot of cases where children, like Madam mentioned, have really grown out of their adolescence and they've stepped into young adulthood and they're even 29, 30, 30 plus. Many of them have got married, they have children of their own who are negative, they're standing on their feet, they're doing very well. But also a significant chunk of these adolescents now we do come across on a regular basis who are struggling to cope up in society. Job opportunities, marriage opportunities, they're really struggling. So is there something through NACO, I mean, a little more visible platform that could be made available for these children? And we did have a lot of Mitva sessions. I remember being part of it, where in Vadala we used to have Dr. Shikalacharya Madam also, and all adolescents would be gathered together on regular basis. And they used to be empowered with a lot of life lessons as well as life skills, how to deal with peer pressure, stress of, coping up with the challenges of HIV and everything. So can that be reinitiated as well as used as a platform to give them some opportunities for job as well as finding life partners and stuff like that?
Yes, ma'am. Mitwa platform is still working, ma'am. And MDAX is in a planning phase to develop a skill development program for this adolescent. It is, we are thinking and we are collaborating with the like-minded people. We are calling for CSR also. And definitely for next 3 months, we will come up with the idea for skill development.
Thank you very much. And thanks a lot to all the speakers today. It was an excellent program, and I'm sure everybody has learned a lot and a lot of take-home messages. Thank you.
Thank you.
Thank you very much. We'd like to call upon the chairpersons to please felicitate our speakers with a memento. We'd also like to call upon Dr. Ishwar Gilada to please felicitate the chairpersons. Delegates are requested to note that tea and coffee is being served behind the hall if they're interested in having some. We will also be proceeding with our next session titled, What is the Menu for the Next Decade? This is chaired by Dr. Glory Alexander and Dr. Vijay Karanskar from MDAX. We will now hand over the proceedings to the chairpersons.
Hello. Hello, everyone. I am Dr. Vijay Kumar Karanskar. I welcome you in this panel discussion. What is the menu for the next decade? And to set the context, I request my co-moderator, Dr. Glory Alexander, to set the tone.
Thank you.
Suswagatam, welcome Dr. Glory Alexander to ASICON 2026, Mumbai. As president of ASI, she plays a pivotal role in shaping the vision, advocacy, and future direction of HIV and STI care in India. Today, she addresses setting the tone for the decade to follow.
So, good evening. This is the last session of the AIDS conference, ASICON 2026. And I hope you all enjoyed the entire two-day conference. This particular session is divided into two sections. The first section is a PowerPoint presentation talking about setting the tone for the decade to follow. And the second section is a panel discussion with a few people with regard to this. So, so if you look at the arc of progress of HIV infection, we all know that it's now become, changed or transitioned from a death sentence to a chronic care. And as we all know, ART is the one which has been responsible for this transformation. There were those days 20 years ago when a patient had to take 8 to 10 pills per day with a lot of dietary restrictions. And today patients have to take just one tablet a day every 24 hours and with less side effects, and they can have a normal quality of life and live a normal span of life. So that has been one big area of progress in the field of HIV medicine. Coming to prevention tools, you can see, as I've mentioned over there, about PMT-CT. PMT-CT has really been one of the landmark situations where prevention has made a big difference. At the time that we started working in this field, the risk of transmission from a pregnant mother to her newborn baby used to be as high as 45% in the breastfeeding population. But with the cascade of services that are available now for PMT-CT, we've been able to reduce this considerably, both in the government program as well as in the private sector. The last 10, 12 years, I've treated more than 500 patients living with HIV, and all the babies born to those mothers are negative. So that is very satisfying. And of course, the concept of U is equal to U. If a person is adherent to ART and the viral load is less than 200 copies, then the risk of transmission, even in the case of unprotected sexual contact, is 0. And of course, we have PrEP with all the various modalities available of dapivirine, vaginal rings, oral medication, injectable PrEP. So all of these have really expanded over the last few years. I think one of the most inspiring programs in the world is the program of India's National AIDS Control Organization's ART program. We have 794 ART centers all over the country, and they are providing free ART to 1.7 million people in India who are infected with HIV. And this program started way back in 2004, and now we are in 2026, and for the last 22 years, they've been giving this treatment free of cost with no let-up, and that treatment continues. I think we are the only country in the world which is providing this kind of treatment to people living with HIV, and it is something that needs to be really appreciated. The other thing that changed was the transition from, the top-down approach where we decided what needs to be done for people living with HIV. We reached down to them and told them, do this and do that. But it's very important for us to know that we need to involve them on a peer-to-peer basis, because they are the ones who know best what is good for them. And now over the years, we've started involving them in program design, in monitoring, in evaluation, and that helps also to reduce the stigma. At the end of the day, we can say that we have bent the curve, but we have not ended the epidemic. Science has moved really fast over the last 20, 25 years. We have long-acting ART, what you're all very familiar with. We have long-acting PrEP, the famous landmark trials of Purpose 1 and Purpose 2. Purpose 1, where young women who are at risk of acquiring HIV in Africa, and the Purpose 2 trial where heterosexual men and gender diverse persons received subcutaneous lenacapavir once in 6 months. And in Purpose 1 trial, the efficacy was 100%. And in Purpose 2 trial, the efficacy was 96%. So that was another landmark trial showing that just by giving 2 injections per year, you can prevent people from acquiring HIV, people who are vulnerable to HIV from acquiring it. Broadly neutralizing antibodies, again, has been a game changer. It probably is a game changer. It's being, research is going on not only in prevention, not only in treatment, but also in vaccine and also in cure research. So these are areas where there have been a lot of progress, and that's very encouraging. But we also need to remember that science without equitable access to everybody, to the global north, to the global south, to the rich, to the poor, there's no success if science, the access is not equal to all. But then there is also the unfinished agenda. We know that new infections persist. It's not completely eliminated. In our country and other countries of the world, advanced HIV is still there. We do see patients very late. PrEP, never taken off in our country. We have only about 7,000 patients who are using PrEP now. And somehow, in spite of its high efficacy, there are lots of pros and cons and second thoughts about whether we should really give this or not. So the current trend is not to give it. Rising non-communicable diseases, that's another challenge we face as people grow older and live longer. And even today, in spite of all the work that is going on, cure is still elusive, and so is a vaccine. That is the scientific realities. What are the social realities? We still have gender inequities. The woman continues to bear the burden of the HIV epidemic. She's still considered to be a caregiver and a child rearer. She's dependent on her husband economically, financially. She has no say of her own, and that is something that has to be changed. The key populations continue to remain very vulnerable. There is funding fragility. You're all aware of the PEPFAR fund, which used to be given in the USA, the President's Emergency Plan for AIDS Relief in African countries. That used to support 20 million people for free ART in Africa. And overnight, that funding was stopped, except for women who are pregnant. And also the WHO lost some of its funding from United States, and then USAID also lost funding. So funding fragility is there, and it's very important for countries to depend on their own domestic funding rather than look forward to receiving foreign funds. So that is something, again, which is not sustainable currently and which is causing some tension. People living with HIV have never had health insurance. That has been a big problem, especially in India. There are small, groups which are providing some kind of help, but they always come with a lot of caveats. So health insurance is another area which is unfinished. But just last year, there was an article in the newspaper where IRDAI talked about also including people living with HIV under their health insurance scheme, along with senior citizens. So I hope that will come into action in a few years or months, maybe. Unexpected realities, we all know. COVID-19 is a big example for us. It displaced HIV from the topmost place, and it also impacted HIV very badly in the sense that much of the funding that we were receiving for HIV went to COVID-19. A lot of people did not have access to, people couldn't come out to get tested and counseled and tested for HIV. It impacted access to healthcare services. It impacted access to ART, and therefore it impacted adherence also. Because of the climate change that is happening, there are lots of more frequent disasters like floods and earthquakes. And when that happens, there's a lot of internal migration or external migration from country to country and state to state. And that affects healthcare services, including that for HIV. War, there's lots of war going all over the world, going on all over the world. Ukraine, Russia, Israel, Gaza, Iran, USA, Israel. All these wars can also cause a lot of displacement of people, resulting in a lot of impact on provision of healthcare services, including HIV. We always looked at community as if we were just helping them and telling them what to do, but we now know that the community is not a footnote. The community has a very important role to play. We keep seeing examples of that over and over again about how, as peer navigators, when one person reaches out to another coming from the same situation and the same vulnerability and the same background, it helps. So that is something which has helped a lot in reaching out to vulnerable communities. I think HIV infection is the only infection where we have these extensive PL-HIV networks that go on from the national level right up to the district level, and they have a say in decisions that are made, and they fight for their rights. We have the link ART centers, which are at the primary health centers and district hospitals, which provide links between ART centers and the community. We need to take that a little more forward so that ART is available within the community itself and can be provided by peers. Self-testing is still something that has not taken off in India. It does, all the countries around India, the SAARC countries are all doing self-testing, but somehow we have not included that. Maybe that will respond to this last mile connectivity where the most vulnerable are still not coming out and getting tested. So maybe that is something that needs to be thought about. And finally, we just need to know that nothing about us without us. Unless we involve the community, we won't go anywhere with regard to eliminating HIV infection. And of course, in this climate of AI and digital technology, that cannot be ignored. How can that help us in the work that we do? So AI-enabled surveillance, by downloading all this data through AI and analyzing them, you can get a lot of information. You can find out where are the hot transmission spots, where is there likely to be treatment failure, where is there likely to be resistance. It helps us with all of that. mHealth adherence tools, mobile health adherence tools helps us to give SMSs to people, smartphone apps. Yesterday, Dr. Jaikant was talking about how that helps in reaching out to people in vulnerable groups. And by sending them SMSs about reminders, educational videos, it can be used for a whole lot of things. And it is something that is very feasible and very acceptable among the vulnerable communities. Data-driven micro-targeting, we do have the uniform standard national public health policies, but through data-driven micro-targeting, you can also work at local level and provide very precision kind of treatment for places where there are issues. Real-time dashboards give you real-time information on HIV testing and counseling, on drug uptake, on adherence, on failure. This is not something that we have in India, but Kenya is one of the countries where this is going on, and it is quite successful. But in the midst of all this, where you're really doing a deep dive into the community, it's very important that ethics should be maintained, that the vulnerable communities have the privacy that they require, and that you continue to maintain the trust of the community. So what are the 3 shifts for the next decade? It has to be right now, we were all looking at control of the epidemic, but now it has to move to the elimination mindset. We were able to do that, or we're in the process of doing that for prevention of mother-to-child transmission, but we need to look at an elimination mindset with regard to the whole of HIV medicine. We always were looking at HIV as a vertical, not as integration, and that needs to happen. We need to integrate HIV into the routine health systems. Today, if we look at Hansen's disease, it still continues to be a vertical, and it's still not been integrated into routine medical care. But we should not make the same mistake with HIV. We need to integrate it, and it's possibly easier now because of the NCDs. When you have a patient who has HIV, as well as hyperlipidemias, diabetes, hypertension, heart disease, or maybe cancer, it's easier to integrate them into the routine healthcare. And of course, I keep saying this, that we need to make a mind shift in our heads at looking at the community as beneficiaries and actually make them partners in the process. Moral compass, the next decade is not only biomedical, it's also about dignity, treating patients with dignity and respect, seeing that there is equity, that the distribution of facilities is fair and just, that there should be non-discrimination, there should be gender justice, and how when we are hearing about so many of these young people being so vulnerable now, youth empowerment is again very important. And talking about youth empowerment, I just want to mention that we at Asha Foundation are doing a lot of work with adolescents. We have 2 programs for them. 10 to 17 years, we actually take them to a residential therapeutic camp for 5 days, where we, the first thing is when young children see that there are other children just like them who also have HIV, it gives them a sense of, oh, I'm not the only one suffering from HIV. There are others just like me. And we give them a lot of information on HIV because many of them don't have any information. It's done in a very friendly way. We also focus on team building skills, life skills, etc. That is from 10 to 17. And then from 18 to 24, we do what is called a leadership and training program for youngsters living with HIV. And we've reached across to more than 3,500 children in the state of Karnataka, all of them living with HIV, where we've been able to do these programs for them and help them to cope with what they have. So youth empowerment is very important. Call to action, we need to be sure that the next decade must be smarter, science-led, not through myths and misconceptions, should be kinder, there should be no stigma, should be stronger because it should be system integrated and should be braver. When we look at HIV infection, those days we used to wait till the CD4 count fell below 350 before starting them on treatment, but then slowly we changed to the test and treat policy, and again that became a game changer in HIV management. So maybe we should become braver and look at PrEP and self-testing, but I understand there are lots of pros and cons, but maybe we need to make some decisions regarding that. And finally, whether we want to be remembered as custodians of a program or architects of the decade that follows. Thank you.
Thank you, ma'am. Now I request all the panelists to join us. Dr. Pooja Gori from Mumbai, Mr. S. Guru Raja, Mysore, Miss Bindu Ora, Mumbai. Please join us.
It gives me great pleasure to introduce Ms. Bindu Vora. Ms. Bindu has been living with HIV for the last 25 years, and she is an example of what it means to be a woman living with HIV and how she has traveled this journey over the last 25 years. And today she's a woman who is empowered, who has overcome all the challenges that she had to face in her life, and is right now in the process of writing her own book, her autobiography. And I think it's ready for publication almost. Yeah, so we just want to hear her journey in her own words.
Thank you, ma'am. So I'm a little nervous, but this is my first time that I'm facing such amazing doctors and such audience and sharing my experience. It is quite a journey and it's a roller coaster ride, but I can say that now I thank HIV that it got me, empowered me so much in a different way. And I have become from victim to a warrior now. And because of HIV, where I am right now, and that's why I'm facing this right now and got this amazing opportunity to share my experience with all of you. That it was, my journey has started in Africa. I got married in year 2000 and my husband was commercial pilot. But as every girl's dream, it was a dream life, like got married to a pilot and never thought of it. And I'm talking about year 2000. So it's almost like a 26 years back, and HIV, never heard of it, like it is, what is HIV, why it has come. And of course, it was a shock for me, for my family, everybody. And within 9 months, my husband passed away of my marriage. And that's how I got HIV. And then the journey, the struggle has started. How, to whom to meet, which doctor to meet, what treatment to start, and how expensive treatment will be. And my parents are not very rich, they're middle class family. For them it is like, how we will survive, how we will treat my daughter. And the biggest shock was emotional, that at the age of 20 I got married, first marriage, and I came back as a widow. That was a shock for my family, and top of that, HIV positive. Now what next? Like, how will my parents will face, the relatives, the friends. How can we say that? Like, it was very easy for everybody. आप दूसरा शादी करा दो, उसमें क्या है, अभी तो बहुत छोटी है, like that, But how my parents will face them? No, my daughter is HIV positive. And that was killing. More than that, like the emotional vulnerability was so much, was killing me inside. How will I survive? How, like, my life was shut. I was very vibrant, bubbly, and full of life, big dreams. I was pursuing a career of becoming an air hostess. And when I got married to a pilot, then like, oh, my dream man has come, and I'll be flying all over the world and all. And all of a sudden, the world has become so small that I have to face doctors, hospitals, all the challenges, all health issues, medicine, and the life has turned 360-degree. But then again, my doctor has found me another guy I got married to right now. And since last 23 years, I got married a person who is also HIV positive. And again, the challenges have started. My other husband has faced a lot of CMV retinitis. He lost his eyesight and he's handicapped. So another life challenges started. So many challenges. Even I have faced a lot of like eye tuberculosis, Bell's palsy. Then last year I faced acute TB. Like this, I can say this is my second life. So many challenges. But then like every year after the year, my husband and me, like facing all the challenges. Then you can't just think about that why this thing is repeating, because you are making a pattern of it. You are thinking, because now I'm into healing. I'm a yoga instructor. I teach yoga. I do heal people right now. And that's what I came to know in my awareness, that it was a pattern which I was only creating. I was only making significant that I'm HIV positive. And why I'm here? Because there is a stigma that people really don't want to like to talk about HIV. People say that I'm a cancer survivor, she's a cancer survivor, he is a cancer survivor. But nobody talks about HIV survivor. Why? It's not your fault. It has just come. Sometimes I forget because the kind of lifestyle, the kind of acceptance, the kind of surrender I have done in my life, I've forgotten that I'm a HIV positive. I can say that I'm a absolutely normal person than the normal person. I work out 6 hours in a day because I teach students and I'm on my toes. I don't feel anytime that, okay, I do face a lot of challenges, but I know how to come out of it because I use my mind power. I use my own power to heal myself. HIV को साइड में रख दो, वो एक रूटीन है. सुबह उठ के एक दवाई तो खानी है. But why you are spoiling and you are making yourself victim that I'm HIV positive? It takes me so much courage to come here, and it's okay. It's okay. Sometimes I am also in that state that no, I don't want to do it. But why? Like I want to do it. I want to tell people that you can be a normal person with HIV. It's not that scary thing. Why people talk, oh, she's HIV. Oh, isko HIV hai, like that, But no, it's okay. It's absolutely okay. क्यों diabetes वालों को पूरा हमेशा lifelong दवाई खानी पड़ती है, तो HIV लोगों को भी खानी पड़ती है. उसमें कौन सी बड़ी बात है? But it's only matter your mindset, your daily routine, your lifestyle, how you are taking it positively. That matters. No matter whether you are a cancer survivor or you are HIV positive. It's all about your mindset. Once you decide, you choose. Everyone has a choice. And you choose about your life, that how you want to lead your life. I wanted to come here. It was my dream. And I am here right now. And I want to spread this message to everyone that there is a choice. Choose for yourself. Choose yourself. Accept yourself the way you are. And I accept myself. I'm very much comfortable in my skin. I'm very much comfortable the way I am. Whatever I have achieved in my life, I have started my journey after 45, I'm telling you, because I had, my father-in-law was brain stroke patient. My mother-in-law was a heavy diabetic patient. My husband is handicapped, 3 patients, and top of me including. So I had to make myself so strong that I want to live my life. I don't want to give up. I don't want to be a victim that I'm HIV positive. I want to see the world. I want to share my experience to the world. I want to, see the world. World is so beautiful. So your life is. It's very beautiful. Don't waste it. It's okay. ये एक हवा का झोंका है, वो भी चला जाएगा. But you make it so beautiful by yourself. You think about yourself that you want to live your life. You want to make it happen. Don't give your power to somebody who can rule your life. You can rule your own life by thinking, by changing your thinking pattern. That you are a survivor, you are a warrior, you can do everything. I'm a healer. I do access bars healing. And I have healed myself after 15 years of same repetitive pattern of my life. Every year, my husband used to go in the hospital. 6 months he comes back. और रिकवरी में इतना टाइम चला जाएगा, थोड़ा सा रिकवर हो गया, वापस हॉस्पिटल. यही like after my husband, my father-in-law, then my mother-in-law. All these 15, 16 years, I've forgotten my identity. I was just taking care of them like a nurse. I was just taking them to the doctor, hospital, medicine, illness, negativity, everything. There was a time that even I was having a suicidal thought. And I've literally tried that. But now I'm realizing that I was, please never do that. Never do that. Life is so beautiful. And now I'm proud of myself that I have fought with all odds in my life. And I have come here and I've got all the courage to share my experience in my book. So I'm coming up with my own experience of HIV. It is the book name is HIV to Healer. So very soon it will be published, and I guess I'll take the contacts and I'll share with you all. And my message is just don't give up. Like whoever is listening on life, just don't give up. HIV is not that deadly disease. It's all about your mind, and it's all about the way you want to take up your life. So beautiful. Thank you so much.
Thanks, Bindu. This is what empowerment looks like.
One more thing, I would like to say thank you to my doctor, Dr. Trupti and Dr. Gilada, for giving me such wonderful opportunity and share my experience with everybody over here. Thank you from bottom of my heart. Thank you so much.
So this is what empowerment looks like. You know that women have a lot of self-stigma, and it needs a great mind and a powerful thoughts to be able to overcome that. She has done that. If only we could do this for all women living with HIV in our country, how wonderful it would be. Yeah. I would like to talk to Pooja Gauri and ask her about, with the rising NCDs that are happening for people living with HIV, how do you think we can handle that situation?
Yeah, it's working. Ma'am, with ART, people are living longer life and they are aging with the ART. So with the longevity, we have so many challenges like the NCDs and the impact of the ART on them. Some drugs have a direct side effect on the organs, and some drugs will increase the sugar level and lipid level in the patients. And even the added is that their lifestyle, the sedentary work style, diet, eating junk food, smoking, alcohol, and the most importantly is the stress level also. And added to it is a socio-economic status of the patient. If the poverty is there and late access to the healthcare system. So all these things contribute to the increasing NCDs in the patients, and how we can handle it. So we need to screen the patient every time they visit to the for the collection of the ARV. If we integrate with that, that will help them more. So whenever they come for the refill of the ART, we can ask for the screening of the small thing like the BP, sugar. We can screen and we can go for the routine checkup of the patient. So we'll come to know the early diagnosis for that. That is really important. And the second most important, I feel there should be the counseling for the lifestyle management of the patient. When the counseling on what to eat and what not to eat, there should be the more nutrition and more fiber in their diets. Do the regular exercise, quit smoking, quit alcohol, have a good lifestyle, and there should be the aim. There should be the aim in the life to achieve something that will help them to live the positive life. Along with that, I think there should be the more awareness about the NCDs in them, because they take it lightly. If they are suffering from the diabetes or the hypertension, they feel it is okay. Even if they take the medicine for the some days and they will skip the medicine. But there should be the more awareness, so that will give the more impact on their life, that I feel.
Thank you, Pooja.
Mr. Guru Raja. Mr. Guru Raja is working in HIV field through his NGO for many decades. So the question is, in this time of funding fragility and funding instability, what can NGOs do to overcome this situation, sir?
Dr. Glory and Dr. Vijay, and of course, I'm so happy. I still find a good lot of people are still in the auditorium. I'm the last person who is going to speak anything. Basically, we work on HIV. We started working in HIV field for almost last 3 decades. It's 29th year of our service in the HIV field. Right from the day one in which we started working on HIV, we are into a PPP model only. Yesterday, somebody was telling it is not just PPP, it is PPP. Exactly. That is how. In fact, we started our first ever counseling center, a daycare center in 1997. When nobody, including my own very good doctor friends, in fact, outcasted me and Dr. Moti. Oh, you are the people who are working on HIV. Why do you want to involve yourself with the sinners? This is the kind of information or talks which were happening in the city of Mysore. We started our counseling center. We started a community care center supported by the NACO. Sustainability was always an issue then, now, or probably even in the future. It all depends on how we manage our show. We have been more transparent in the field of the finance, especially. We are absolutely transparent with the NACO or any funders. We have never depended on foreign funding. Except once or twice, our first grant came from the Elizabeth Glaser Pediatric AIDS Foundation for a PMTCT program. But then we have always have the public, our own community participation was always important. We were so much involved into the community work. Even today, our team goes once a week, serves the community in temples. We do, our team visits, including me, we visit a mobile clinic in the remote villages of the Mysore district, where we treat almost, not only HIV, but we are helping the other community also. Whenever we had an issue, we are the first people or probably the only people in the entire country who have an MOU with the CII, Confederation of Indian Industries, which really supported us. Entire city of Mysore invariably supporting on our every aspect. We started from a scratch, and then we have a 30-bedded standalone HIV hospital in the entire country. How did this happen? This happened again because that we had a passion for the work. I always keep myself telling that, of course, it includes Dr. Moti. I'm a professional beggar. I keep asking people to donate money or donate anything which they can give. I am not asking for myself. We are not asking, we are asking for the community. Well, this has really helped us. A lot of corporates do help. Community participation was always there. So whenever we help the counseling sessions in the industries, they used to ask what we can do. RBI came up with a digital X-ray costing us 26 lakhs. Just they donated. Kluber, they came up with a gene expert machine costing 30 lakhs. That's how we were able to start our ERT center under a PPP model with the NACO. We started so many things like that. Each and every equipment we have is a history, is a story for us. We are treating over 11,000. We have treated over 11,000 patients in HIV in the city of Mysore. Now over 3,500 patients on ART supported by the NACO. Ours is a PPP model. We, like you asked, that we are basically looking at the more of a domestic funding than the foreign funding. So all of a sudden, if there is a stoppage of any funding and all those things, we still have a lot of our community, local community. We converted our HIV hospital into a COVID care center. we admitted over 500 COVID patients with zero death. And it was supported by the Corporation of Mysore City. One of our philanthropists, Prakash Jewelers, he said, "Sir, we are with you." Please believe me, overnight he gave us 21 lakhs to convert the hospital into a COVID care center. So we were able to do that, and we are the only people in the entire country where we started as a vaccines, COVID vaccines. We just started. Again, it is a typical PPP model. The government of India, through the health department, gave us the vaccine. We started with just about 100 vaccine per day. Finally, we reached almost about 1.6 lakhs vaccine was given by us and the other hospitals in Mysore. We just started. Only when you have a zeal, a mind, a passion, I'm sure any project will go through. So that's how we have a lot of such success stories. Again, I would request each one of you, whenever you are in the South, please do visit us. You will definitely get a lot of insights. That's how each day is a learning day for us also. Each new day is a learning day. So we keep on learning, and we will be able to learn from each one of you. Thank you very much.
Thank you, Mr. Guru Raja. So that's the best way to go, to look for domestic funding, because if you're dependent on foreign funds, something can happen suddenly and then your whole program just folds up. There's so much of money in India if you know how to get it. We have CSR initiatives, we have private philanthropists, we have NACO initiatives. There's so much crowdfunding. There's so many ways in which you can make money. It's a huge challenge, but you have to work at it, and it is possible. So that brings us to the end of this panel discussion. If there are any questions, we are happy to answer. Otherwise, we just want to say thank you for listening to us. I want to wish Bindu all the best in her life as she moves forward, especially with the book. And thank you for being here today. That brings us to the end of this conference. Thank you. You also may have an opportunity to visit Mysore very soon.
We'd like to call upon the chairpersons to please felicitate the panelists with a memento. We will now be starting with our valedictory ceremony. We pass on the mic to Dr. Gilada to continue the ceremony.
Respected dignitaries, esteemed faculty, dear colleagues, partners, friends, as we gather here for the closing ceremony of ASICON 2026, I stand before you on behalf of AIDS Society of India and the organizing committee of ASICON 2026 with immense gratitude and truly with our hearts really full. For 2 intense and inspiring days, this conference has lived its theme, adding life to years with science and solidarity. Not just as words on the banner, but I think we saw lively conversations in the hallways, debates in the sessions, collaborations, and a shared purpose in the hall. We even saw people discussing in the restrooms. Lovely restrooms they had. We have a little video to just show you a glimpse of the last 2 days. We actually had some really good, we have some good photos that we will share, of some of us dozing off, Vijay uncle reading the newspaper in the session. We have such lovely, cute photos from today. I think the discussions were rich. There was just so much power, so much engagement. There was disagreement, there was reflection. But I think at the end of it, there was solidarity. I think we really came with a purpose, and I hope that we've served the purpose a little bit. We really attempted this to be an eco-friendly conference. We made a deliberate decision that if we speak for public health, we must also protect planetary health. And we minimized plastic usage. You must have seen glass bottles. All our banners, including the one stalls outside, have been cloth. No flex has been used. All the lanyards and the badges have been no plastic and all biodegradable. And we tried to make it as paperless as possible. Each of the bags that you've received, it's a cloth conference bag with the idea of using lesser plastic with a dual purpose of a message of U is equal to U, a reminder that science reduces stigma, and I think solidarity will transform lives. So we want to take that message of U is equal to U, normalize the epidemic out in the community and create that awareness all over again. Coming to our program, we had a lovely 2 days, lot of sessions. We had Dr. Bhushan Gagrani, who was our chief guest, couldn't join us at the inauguration, but joined us last evening. And we wanted to acknowledge that he really kept his words and made it a point to travel 2 hours just to be here with us. Over the last 2 days, we've had 350 delegates. And of course, some of them are still sitting here, 350 of us, faculty from across the country and internationally. And before we go on to the scientific distribution of certificates, I would like to call Dr. Kumar Sami, Dr. Satish Rao, Dr. Sajid Kumar, and Dr. George Oman, who really went around looking at the posters and the oral abstracts. And we have the winners. You want to say something? Nothing? Yeah, the prizes are here. Come, no? Dr. Glory and Dr. Gilada. So, are the students here with the posters and oral who presented? Raise your hands. How many of you still hanging around? If you all want to go home, you have to clap. Okay, from now on until our last thank you slide, you have to continue clapping, all of you. Okay. The third prize for the poster goes to Dr. Dhyanesh Murkar for his poster on estimation of cardiovascular disease risk prediction by atherosclerotic cardiovascular disease score in HIV. This is for the poster. The second prize is Dr. Shambhavi Verma. Is she around? Exploring factors for high positivity of HIV and syphilis among MSM. And the first prize to Dr. Ranjana Thatte for assessment of HIV-related stigma among healthcare workers of tertiary care center in Mumbai. So the certificate also comes with a cash prize. The first prize is 10,000 rupees. The second prize is 7,000 and the third prize is 5,000 rupees. Abhi to taali bajao. The second prize for the oral Dr. Ritvik Jain, determinants of an elevated AST2 APRI and fibrosis 4 score in PL-HIV on stable ART with a cash prize of rupees 10,000. And the first prize goes to Dr. Shrijit Shrikumar, rapid emergence of pan-INSTI multi-class resistance in a treatment experienced patient with a cash prize of rupees 15,000. We had a quiz yesterday with some glitches. The quiz master. We'll give out the prizes for the quiz in a bit, but I'll announce the prizes. Dr. Sudhanshu Deshmukh, Dr. Kunj Dhabhuwala, and Dr. Hardik Jain. You want at least come up and take a picture. With a cash prize of rupees 7,000, rupees 6,000, and rupees 5,000. Coming to our vote of thanks. First of all, we have to thank our amazing faculty who traveled from across India. Some of them could even make it here. Thank you for your time, expertise, and generosity of knowledge. To our delegates, 350 of you, thank you for showing up, for the discussions, for even being here at this time. That really speaks volumes. To our academic partners and public health partners, MDAX, MSACs, AHF, and Central TB Division. Thank you for your collaboration and continued commitment, and we really hope that we can take this forward. Behind every successful conference is a team that's running only on tea, coffee, and very little sleep. Conferences don't actually happen on stage. They happen because of all that happens before that, off the stage. So first, thanking JW Marriott for really hosting us so graciously. Mr. Ketan Shetty and Ms. Shalini Sethi, if you're around. Our educational grant partners, MCure. Where is everyone? My bad. The local organizing committee. Dr. Wasim and Dr. Pooja Gori, the organizing secretaries. We had a fabulous local organizing committee. Dr. Kavita is still here. Dr. Nitin Karnik, Dr. Girish Rajadaksha, Dr. George Oman, Dr. Amar Pazare, Dr. Priya Patil. Come. Dr. Karanskar. Is everyone here? Coming to our big partners, without whom we couldn't have done any of this. Mr. Satya, Mr. Mangesh, Mr. Vivek and team from MCure. Memento. बाकी कहाँ गए? Mr. Gajendra and team from Hetero. Mr. Amit from Cepheid. है Cepheid का कोई? Karki from Beatrice. Mr. Patil from Sysmex. Safid, आइए. Come. Safid. Mr. Patil from Sysmex. Mr. Dheeraj and team from Loris. Sysmex. Yeah. Mr. Singh and team from Sipla. Mr. Abhay from GSK. Team Loris. Sysmex से कोई नहीं आया ना? Dr. Sam from AHF. Thank you so much. Yeah, please come. कॉन्डम को लेके नहीं आए? एक्चुअली बनता है. Thank you so much. Mr. Bobby and Shobhaji from CNS for being our seamless partners throughout years, for all the support. A lot of you were able to, and your students were able to attend the conference online, YouTube, all because of them. A lot of them were able to attend on YouTube because of them. Yeah. The entire team from Celebrations, Mr. Adnan, Faizan and their entire team for really setting this up, the audio visual, the stage, all the stalls outside. आ जाओ सब लोग आ जाओ. एक मिनट वैसे भी तो पॉज ही किया हुआ है. Where is there? No, no, no. कोई नहीं आ रहा है सेलिब्रेशन से. रोजा छूट रहा है. To the person who made us laugh through the conference with all those AI images. We all became 20 years younger. To that beautiful conference app that you will continue to use to download your certificates. The little technical thing with the quiz, but otherwise it's been great. Mr. Varun, thank you for doing this. We really had fun. Yeah, his AI picture.
And thank you, Mr. Guru Raja, for producing him.
Sudeshna, for facing every emotion that we've had over the last few months. I'm only saying every emotion, I'm not describing it. Our team in the office out here, Archana, Pradeep, Lakshmi, Sabina, and Nisreen. I think Nisreen has gone for Rosa. There's been one doctor who stayed behind the console throughout the 2 days. Rahul, please. Go. Rahul, thank you so much. We hope you enjoyed it. अभी हाँ ही बोलना पड़ेगा. Our absolutely wonderful, gracious hosts are your JW, team JW, our Annadata for the last 2 days for absolutely spotless service and for really making this our home for the last 2 days. Please. Come. Sorry, we kept you busy on WhatsApp constantly. Certificate. Have I missed anyone? Rahul? Rahul ने नहीं लिया? Okay, I'll give him. Yeah. Please use our app to download the certificate. Please fill in the feedback. We really need that so that we can make our next conference better. And before leaving you, I think the entire organizing and the scientific committee really wants to thank you and invites you to ASICON 2027 in So stay tuned for the dates. That brings us to the end. We are really grateful. We are really thankful to each one of you for being here. If you're leaving ASICON 2026 with one new idea, one new friend, one new commitment, one less hour of sleep, I think we've done our job. And I think we've truly added life to yours, including our own. Conferences end, our conversations will move on our WhatsApp groups, on emails. We'll meet again to deliberate. We'll see you again at CMEs and Mysore. So thank you on behalf of all of us. Safe travels. We look forward to welcoming you again. Yeah, and for those who are staying back, we have our International Women's Day special workshop in collaboration with Mumbai Obstetric and Gynecological Society tomorrow from 9 to 2. So please join us tomorrow as well. Thank you so much. And please join us this evening for dinner for the ones staying back. There is a beautiful Jal Tarang evening, musical evening, while we all, Kabhi Alvida Na Kehna, the team is here. So even the musicians yesterday, for those of you who missed it, we had a beautiful, very passionate group of doctors who sang for us. We also conveyed our thanks to our flutist, Mr. Mohan, who was there at lunchtime. Thank you so much. We see you again.